Sure.
Hi, Dr. Chen, Dr. Tu, how are you?
Hi, fine. How are you?
Fine, fine, fine. How's everything? Okay.
Yeah. Dr. Chen. Okay.
That's good.
Yes, sir. Good morning, distinguished guests, both offline and online, esteemed colleagues, our proud alumni, and all the delegates of the first International Conference on Interventional Pulmonology and MGMCRI Pulmo Alumni Meet. On behalf of the organizing committee, I extend a warm and fresh welcome to you all. We are honored to have so many experts and scholars from various parts of the world gathered here today to share their knowledge and expertise on interventional pulmonology. This conference will provide a platform for discussion and exchange of ideas in the latest advancements and research in the interventional field. Through this conference, we hope to create an opportunity for researchers, clinicians, and the budding pulmonologists to come together and learn from each other. We believe that this conference will not only enhance our knowledge, but also foster collaboration and promote betterment in patient care. We are fortunate to have a distinguished panel of speakers who will share their experiences and insights on various aspects of interventional pulmonology. The keynote lectures and workshop planned for this conference promise to be both informative and engaging. Finally, I would like to express my gratitude to all the sponsors, organizers, and volunteers who have worked tirelessly to make this conference a possible one. Without their support, we would not be able to bring together such a remarkable gathering of experts. I hope you all enjoy the conference and wish you a productive and enjoyable day. Thank you. And yes, let's inhale the vast knowledge and make a lung reserve. We'll start off with the scientific deliberation now. With a great pride and immense pleasure, I invite my beloved HOD and our Associate Professor, Dr. Pajanivel sir and Dr. Vimalraj sir for the first session.
Very good morning, dear all. On behalf of the management and the Department of Pulmonary Medicine, I extend a warm welcome to all the senior professors and the distinguished resource persons for the day. It's indeed my pleasure to chair this first session, especially from the international resource persons, Dr. Chi En Tu and Dr. Chia Im Chen. Thank you so much, both of you, for having accepted our invitations to be on the stage today with us. In fact, the motivation and the encouragement you have given to our faculty has been the reason why we have organized this conference and to stay the setting for setting up our interventional pulmonology in our department. I welcome both of you for this international conference. So I will request my co-chair, Dr. Vimalraj, to introduce the first speaker and start the session.
Thank you, sir. Welcome, everyone. Good morning, sir. Dr. Chi En Tu, he's a professor and head of the Division of Pulmonary and Critical Care Medicine, Department of Internal Medicine at China Medical University Hospital, Taichung City, Taiwan. He's a chair of Internal Oncology of China Medical University Hospital, Cancer Center, and he's a director of Taiwan Society of Pulmonary and Critical Care Medicine. He is the current head elect of the Interventional Pulmonology and Bronchoscopy chair at the APSR. He has trained innumerable international and national faculty in the field of interventional pulmonology. He has been a member of various national and international societies. He has more than 150 peer-reviewed national and international journals to his credit. I welcome you, sir. The stage is yours.
Okay. Good morning, ladies and gentlemen. I'm Dr. Qian Tu from Taiwan, and I will introduce a new IP technique of the transbronchial endobronchial ultrasound guided mini forceps biopsy. Okay, I will present the case. This 73 years old male and come to our clinic in this August, and then he feel the cough, and then we can see the chest X-ray show the right hilar lesions. This left side is his CT scans, and right side is his CT scan. We can know the right hilar lesions, and we perform the EBAS TBNA transbronchial needle aspiration. We can see the left side is his TBNA specimens from Rose, and then we just only can see the cell. And then, but the patients needed the tissue for his late stage small cell lung cancer. And so we use the TB-MFB transbronchial.
Sir,
Yeah.
Vimal here, sir. I
Yeah.
think we are not able to see the slides, sir. Can you just adjust the slide settings again, sir?
So you cannot see my slide, right?
Yes, sir. Yes, sir.
Okay, sorry. Can you see it or not?
Yes, sir. We can see it now, sir.
Okay.
Yes, sir.
So now is it okay?
Yes, sir.
Okay, sorry.
Yes.
So I have to from now beginning slide. Okay, sorry to late. Okay, this is my slides. Can you see everyone?
Yes, sir.
Okay.
Yes, it's
Okay,
good,
okay.
sir. Yes, sir.
First, I will present a case. This is a 73 years old male smoker. Then he come to my clinic this August, and then he just only coughed, and the chest X-ray can see the right hilar lesions. So we can see the this is his tumor, and then we arrange the TBNA for the diagnosis of his lung cancer. So we just only can see the TBNA needle, just only can see the cell. So we have to catch the tissue from the patient. So we use the TBMFB transbronchial middle and mini forceps biopsy. This is our technique. So we use the TBNA needle from the sheath, digging the hole, and this is his needle. And then after the TBNA, we can just only no tissue from the TBNA needles. So we dig in the hole. This is a sheath of the needle, and this is the needle. After use the sheath to dig in the hole, then we insert the forceps, and we can catch the tissue. This is a roses. We can see the rose is different from the TBN needles. We can see the tumor cells enriched from the forceps technique. Nowadays, non-small cell lung cancer not only one disease, because in previously we just only divide the adenocarcinoma, squamous cell, and other. Nowadays, especially in adenocarcinoma, we have to do many driver gene to test the patient if the target therapy can be used. So this is an update of the NCCN guideline. We can see if for a late stage non-small cell lung cancer, we have to do 9 gene test. Is a EGFR mutation, ORC, ROS1, KRAS, BRAF, NTRK, MET, exon 14 skip mutation, RET, and HER2. Especially for HL patient populations, the HL mutation is usually portions. So we have to just only no target therapy error. We just only the cell for diagnosis if the patient is a cell type. But so we usually use the TBNA score for the metastatic lymphadenopathy. So we just see the morphology IHC system. Especially nowadays, mutational analysis is important for the patients who cannot, especially for late-stage non-small cell lung cancers. The critical needs for sufficient tissues because we IP methods. We use the IP methods, the minimal invasive technique to obtain the sample from the patients. But the years of the sample is not nowadays insufficient for molecular test. So therefore, the bronchoscopist and the interventional radiologist should pursue sufficient tissue for all appropriate tests, especially the gene test. Before the mutational analysis needed errors, we just only catch the specimen, which how many pages of the TBNA needles it can be diagnosed the lung small cell lung cancer. So the aspiration per node is a center. 3 pages is needed for diagnosis. And if we do the TBNA score of 3 pages aspirations, the diagnosis sensitivity is more than 90%. But nowadays, genetic test is important for the patient's treatments. So how many pages needed for diagnosis genetic test? According to the 28 studies, EG1 mutation diagnosis can be reached 90%, and the OC is 95%. One study shows the PD-1 test is enough for can be used from the aspiration TBNA. The methods diagnosis years is 86.8. So NGS is important for future lung small cell lung cancer treatments. So there are studies if we want to sufficient sample for NGS test through the TBNA methods, we have to do the 6 pages per lymph node. In my experience in our NGS test in our hospital, the 6 pages still not enough to do the NGS because maybe our lab still have to do more effort to get the diagnosis from the NGS increase. So the EBAS, we can use the TB-MFB and TB-MCB. Is a difference. TB-MCB means you use the TBNA guided, EBAS guided, but after you dig in the hole, then you insert the forceps. This is a TB-MCB. You also dig in the holes from the airway and you insert the cryoprobe. So first, we need to localize the lymph node locations from the EBAS. Then we perform lymph node digging and then insert forceps or cryoprobe. And then you can catch the tissue for the patient. The digging technique, there are 2 types of digging technique. One is you can use the EBAS TBNA needle and then the sheath ridges. So after you puncture the needle, then you push the sheath to the locations. But sometimes it's so hard because the airway wall mucosa is hard. Hard to dig in the sheath to the lymph node. So cutting knives is better. You can easily to cut in the lymph node holes, and then you can insert the forceps or cryoprobe. TBMFB, like TBMFB, have the require some special forceps because if you use the largest forceps, you can insert the TBNA scope working channels. So you have to. There are Boston develop one forceps, so you can through the working channel and then open the forceps. So this is a videos. You use the TBNA ins dig in, then you can use the forceps to biopsy the tissues. This is a TBNB videos. So this is a forceps. So in the lymph node, you can open your forceps and then catch the tissue. The TBNB, there are some reports. If the user, this is a publication in Annals of Thoracic Surgery in 2011. The study used the TBN needle for to create a hole and then use the 1 millimeter mini forceps. And we can see the TBNA diagnosis about 81%. TBNB is 91%. If you combine two methods, the diagnosed years can be higher to 97%. So for non-malignant disease, you can see the combined the two methods diagnosis higher than TBNA, and the malignant disease the combined the two methods the TBNA just only 68%, but combined the two methods 96%. The other paper published this year in journal Journal of Clinical Medicine, they use a 19 gauge needle to create a hole and then insert a bigger forceps 1.5 millimeters. Then we can see the lung cancer or other malignancy, such as lymphoma and sarcoidosis. We can see that because lymphoma and sarcoidosis, you have to use to catch the tissues, but the TBNA needle cannot do the another tissue, cannot catch the another tissue for diagnosis of lymphoma and sarcoidosis. So especially for lymphoma and sarcoidosis, the TBNB is much better than the TBN needles. This is a meta-analysis to compare the forceps method and the TBNN method. All the study, the 6-year study, we can see the TBNB use the forceps to catch the lymph node tissue that is more better than the needle, just only the cytologies. The other paper in this year use the EBUS TBNA forceps with and without electrocautery knife. They dig in the lymph nodes, you use the needle or electrocautery knife, and you insert the bigger forceps. We can see the diagnosis years of the TBNA just only 73%, but you combine the two methods, you can diagnose 86%. The electrocautery knife can successfully let the forceps insert the lymph node. Sometimes, in my experience, the needle sheath is not so hard, not so rigid, so you cannot create a hole. So the electrocautery knives can be easily create a hole to let the forceps to enter the lymph node. Then another method is TBNFB. You can dig in the hole, the same concept. You use a knife and you insert the cryoprobe. The diagnosis years of the TBNA and cryoprobe, we can see the common lung cancer, uncommon tumor diagnosis or benign disease. The diagnosis years of the cryoprobe is better than the TBNA. But if you just only the diagnosis of the lung cancer, the TBNA diagnosis years is similar to cryoprobe. But if you want to see, if we face an uncommon tumor such as a carcinoma, sarcomatoid or lymphoma, seminoma, the cryoprobe have the important role to diagnose the uncommon tumor. For the benign disease such as sarcoidoid tuberculosis, the cryoprobe is better than the needle. So they compare the sample size. The TBNA just only the tissue sample size just only 4.6, but the cryoprobe 10.7. The molecular test is better in cryoprobe biopsy because cryobiopsy can be catch bigger tissues. Nowadays, I also think the for lung cancer tissue is an issue, and the tissue is an important issue. For the patient can find the molecular test, can do the forensic test and find his target surface for the treatments. So the digging the transbronchial hole in immune center can let the do not increase the when we use the method, we have to calculate the risk and benefits. But still now there are some not enough paper to not enough evidence to let us to routine use the TBNFB or TBNCB. But if you get the tissue, there is a better diagnosis because than the needle. So the EBUS TBNA still remain the first option for the mediastinal lymph node nowadays. But I think in future, if the TBMCB or TBNFB, if not increase the risk for breathing or other side factor, and then can get enough tissues, I think the TBNCB or TBNFB will be replaced TBNA for the lymph node diagnosis. So this is a famous this is to this year's they also use the EBUS TBNA in analyze the safety and feasibility and diagnosis years. They use the TBNA needle to dig in the hole and then use the cryoprobe to insert the lymph node. We can see the diagnosis pathology, and the cryoprobe is better than the needle, and the sensitivity, the cryoprobe is better than TBNA needles. This is a famous prospective multi-center open-label randomized trial. They use the TBMCB methods to analyze to compare the TBNA. So they use the electrocoated knife and then insert the cryoprobe. They do the single node, no rows, and TBNA 4 pass. After the TBNA methods, then he use the cryoprobe just one time. The lymph node, they select the 7 or 4R and conscious patients. So the diagnosis years of the TBNA is 81%, but the TBNA plus cryobiopsy is 93. And the benign disease, also the TBNA plus the cryoprobe biopsy is better than the TBNA, and the molecular test is a common sense that because the cryoprobe can catch the tissue, so the mutation test can be better than the TBNA just said. So we can see if they want just only the lung cancer diagnosis stages, I think nowadays the evidence is TBNA is enough, not needed for TBNMB, MCB or MFB. But the cryoprobe biopsy can be used and the granulation tissue diagnosis, detection, and lymphoma, especially in Taiwan, especially in Asia country, the TB and the sarcoidosis may be an important granuloma disease. So the tissue is better for diagnosis sarcoidosis and tuberculosis, and the lymphoma. Nowadays, TBNA needle just only can non-Hodgkin lymphoma can be diagnosed, but the Hodgkin lymphoma you have to bigger tissue for diagnosis the lymphoma. Now it's too early to use the TBNA mediastinal cryobiopsy routine, but I think if the methods develop mature, I think the cryobiopsy will be replace the TBNA. So it's a safe or effect, but when? So nowadays the evidence today, the point, the diagnostic benign disease is better in the cryoprobe. This finding just only balance the technical requirement, procedure training, and subsequent increase the cost of the technique. So the evidence and limitation of the cryoprobe. We can see the diagnosis years needle is lower than the TB cryoprobe biopsy. This is a systemic review. Even the benign disease and complication, the light breathing is just only 85% in cryoprobe, but the light breathing easily can be stopped by the transbronchial injection of the transamine or bosmine. So but there, the technique has some requirements. You have to let your puncture size not the more than 90 degrees. So entry point is important. So we can see the study, the entry point after the 22 gauge needle, they avoid the entry of the cryoprobe at the obtuse angle, maintain the perpendicular entry of the cryoprobe. sorry. So you puncture it, and then you have to insert your cryoprobe, not at the obtuse angle. Okay. So in my experience, the good location of the lymph node, you can use the forceps or cryoprobe is higher. Saccharina is better because the needles, the scope can fix there and enter the obtuse angle. For this 2R, 2L, 4R, 4L is a little difficult, but if you training well, you can catch this. But the yellow location is not good for TBNSB or cryoprobe biopsy. So the TBM MCB or TBM MFB, the historic sample can be supplied better in these two methods, more better than TBNA. The diagnostic years can be increased and improve the tissue sample for molecular profile, because from the methods you can get a large sample and do not require the rows because the tissue location is better. In my institute experience, this is a TBNA rows, this is a TBMFB rows. It's different because in TBMFB you can catch the tissue. In my institute, we compare the 12 patients TBMFB to TBNA. We can know this is the locations of our methods. For the tissue volume, the TBMFB is bigger than the TBNA. The statistically significant difference. Sorry. And the complications are similar because just only the TBMFB may be mild bleeding and can be stopped by injection of the transaminase or postmates. So this, I share our experience. We do the MFB or TBMCB in the 30 patients. 25 is the TBMFB, 5 is the TBMCB. These patients are usually from the lung cancer patient populations. So the lymph node diggings, we can use the digging two methods, such as I mentioned before. You can use the electrocoated or TBNA needle. Most of the patients from the electrocoated because it's easy to dig the holes. And the electrocoated plus the cryoprobe, the diagnosis is 100%. If we use the electrocoated plus the forceps, the diagnosis is 95%. In the 3 patients, we use the needle to dig in the holes, and the diagnosis is 100%. So my conclusions, still until now, the TBNA still should be first used for the undiagnosed mediastinal lymph node. Then if you use the TBNA, the rows can be, if you use the rows, if the rows diagnosis and then the rows give you the adequate specimens, you no needed to TBNSB, you just only the TBNA 3 times pass. If the rows are non-diagnosis or they mention the inadequate specimens, you have to consider to change the MFB or TBNCB. If the MCB is diagnosis, then stop the procedure. If the MCB cannot be diagnosis, maybe the patient further to use the diagnostic mediastinal scope. This is my final slides. TBNA still occurring the most common technique for mediastinal lymph adenopathy. But TBNFB and TBNCB combined with the TBNAs can be use the same bronchoscopy and to biopsy the enough tissue for further analysis. EBUS, TBNFB or TBMCB can be safe and significantly improve the diagnosis. And then the TBNFB, especially for the lung cancer who want to the NGS test or some common rare cancer, such as means lymphoma or sarcoma tumor or benign disease, special for sarcoidosis TB, and can get another tissue for diagnosis granuloma disease. So I have to advise to mention in 2025, welcome everyone to Taiwan to the 10th Asia Pacific Congress of the bronchoscopy. This is my my presentation. Thank you for your attention. Thank you.
Thank you, sir. That was an elaborate presentation outlining the importance of TBNA and incorporating the use of both TB MFB and cryobiopsy. And we understood the use, how you used in CMUH in the past 6 months and your yield in both malignancy and non-malignant conditions. The stage is yours. Is there any questions? You can ask the speakers.
What is its role in scenario like India, where tuberculosis is very high? I'm myself, Dr. Pratap from JIPMER. What is current role in, because specifically you highlighted it's for for gene testing. So in tuberculosis, what is the role? Where in India, we see it's more common, I feel.
Can you speak your question again? Sorry.
Regarding tuberculosis, any additional advantage over TBNA or tuberculosis diagnosis of mediastinal lymph node?
Tuberculosis can be from our TBM, CB, or MFB, we do not have the tuberculosis case. But in my experience, TBNA in TB lymph node, if you want to just only the bacterial diagnosis is enough. But the TBNA lymph node, usually, if you get the specimen for tuberculosis culture, is enough. But sometimes, and I mean that usually in tuberculosis, because the lymph node is necrosis, you hard to catch the tissue for diagnosis of non-cancerous granuloma. So if the TB lymph node, in my experience, you just only can be used the TBNA needle for cultures. But if you want to the tissue diagnosis for the TB lymph node from the TBNA method technique is so hard.
Yes, sir. What is the size of the biopsy forceps you use, sir, for TB MFB?
In my institute,
Yes, sir.
in my country, still the Boston forceps still not marketed in Taiwan. So we use our forceps developed by China, smaller forceps. So we can insert the TBNA needle working channel and use the forceps. We usually use the lung parenchyma biopsy, but because the forceps is smaller, can be insert the TBNA working channel. So we use the needle and the forceps to use the TBMFB. But Boston have developed one forceps can be used in TBNA working channel, but still marketed in Taiwan. I think in future will be can be used universal.
Okay, sir. For the budding interventional pulmonology faculty or pulmonologists who are starting EBUS TBNA procedures, what is your word of caution in starting, if there is any word of caution in starting a cryobiopsy or TB-MFB? Or do you advise them to start a cryobiopsy or a TB-MFB? Any faculty who are trained in EBUS TBNA?
You mean which type I choose, MFB or MCB?
Do you want them to be adequately trained in EBUS TBNA before switching over to TB-MFB? Or there is no learning curve as such? If anyone wants to start TB-MFB, they can start. Is that your suggestion, sir?
I think that because of price problems, if the patients can be used TBNB or MCB, I clinical suspect this he's late lung cancer. I will choose first if the use the TBNCB or TBNB. But just only one diagnosis, I think the needle is enough. And the learning curve from the TBMSB, because you have to dig in a hole. I think the learning curve you have to do more 10 persons, patients. And if have the 10 patient experience, I think the TBMB and or MCB can be done. And because the lymph node is you have to dig in a hole. If the cryo probe can be available, I think the cryo probe is better than the forceps, because forceps you have to open your forceps, and sometimes if the digging hole is smaller, you cannot open the forceps. So the cryo probe is better because they insert the same root, and you not needed to open the cryo probe. Is just just only a linear, and you can use the cryo probe, can make it the tissue. But I think that nowadays it's a price is a problem, because the cryo probe is expensive for us. And so if in future, I think that if you have the forceps, it's better and cheaper than the cryo probe use.
One last question, sir. In EBUS TBNA, we can adjust the needle direction while doing the subsequent procedures, subsequent process. But if we, for TBMFB, in non-malignant conditions, if we make a track, if that particular area of the lymph node is not having any granuloma, if it is non-diagnostic, there is a possibility that we might miss the diagnosis. Do you want to tell anything, share anything on that, sir?
You mean if TBNA is not diagnosed, right?
TBNA, we can adjust the needle direction, needle position in repeat process. In while we pass a cautery, we make a particular direction hole, and if there may not be any granuloma in that direction, we might miss the diagnosis in a possibly in granuloma conditions or sarcoidosis. Do you want to?
TBNA measure, right?
Yes, sir. Yes, sir.
Yeah, if you want to diagnose the granuloma disease in TBNA, you have to, in my experience, you have at least 5 paces for the same lymph node, and you have to catch the tissue until then. If not catch the tissue, you cannot stop the TBNA measure diagnosis for granuloma disease. So if the granuloma disease, I will do the TBNA at least 5 paces to catch the tissue. But the sarcoidosis, especially for sarcoidosis. So before the procedure, you suspect the patient is sarcoidosis, you have to do the TBNA until and finish the procedure until you get the tissue, because the tissue is important for granuloma disease. But the TB lymph node is a difference. The lymph node is a different for compare the sarcoidosis, because the TB lymph node usually the necrosis. So you can just only get the pass from the TB lymph node for culture, but you cannot catch the tissue for TB lymph node diagnosis.
Thank you, sir. Thank you, sir. That was an enlightening talk from you to start our inaugural conference. Happy to see you. Happy to hear your talk, sir. One more question, sir.
I'm Dr. Jagdish from Apollo, Bangalore. I just wanted to understand what is the size of the lymph node that you're comfortable doing an EBUS cryobiopsy? Is there a criteria for that? Do you have on the CT, when you see the CT, is there any criteria that if the size of the lymph node is 20 mm or more than that, is there any specific criteria you're comfortable doing an EBUS cryobiopsy?
Sorry, you want, sorry, one, I cannot understand your question. You can
Uh,
ask me.
Yes, sir. What he wants to ask is that, do you have a fixed criteria for doing cryobiopsy with respect to the size of the lymph node? Minimum size of the lymph node, should it be 2 centimeter, 1.5 or 1 centimeter?
If you want to use the lymph node biopsy for using the cryobiopsy, you have to 1.1 millimeter cryo probe. Because 1.7 or 1.9 is too big, you cannot insert the lymph node and the risk. So if the money is not a problem, I prefer cryobiopsy for lymph node is better than the forceps, because the root is easily using the cryo probe rather than forceps. Because the forceps in the lymph node you have to open, but sometimes if you creating if you cannot create a bigger hole from the in the lymph node, you cannot open your forceps. So the cryo probe in lymph node just only you can use the 1.1 millimeter, and you cannot use the 1.7 or 1.9 because the bigger, and you create a bigger hole. I'm afraid the breathing problems. And so if you want to use the methods using the forceps or cryo probe, I think cryo probe is better than forceps, but the price is a problem.
Yes. Do you use cryobiopsy in 10 millimeter lymph node, sir? Size of the lymph node for cryo, is it 10 millimeter minimum size? 15 millimeter, what is the size, sir?
Nowadays, I choose the bigger lymph node, 1.5 millimeter diameter at least. So if you want to choose the 1 millimeter, it's you have to have the good technique, and because you are creating a hole, and if you use the cutting knife, if the diameter of the lymph node is small, I'm afraid that if you cutting it, and then the knife will damage the big vessel, and too afraid of the breathing. So nowadays, in my experience, I choose the 1.5 millimeter, 1.5 centimeter of the lymph node. And if you, because our bronchoscopy, our technique is just only light stations, we not fully use the anesthesia. So we afraid the patient cough, and after when you dig in the hole, if the patient cough, damage will be deeply of the lymph node. I am afraid to cut in the vessel.
Thank you, sir. There is no more questions. We'll close the first talk.
Thank you, sir, for that amazing session. I would like to request our former HOD, Professor Dr. Surendra Menon, sir, to hand over the memento to our beloved HOD, sir, and our associate professor. Thank you, sir. Now, I would like to call upon Professor Dr. Surendra Menon, sir, our former HOD of the Department of Respiratory Medicine, MGM-CRI, and our Associate Professor, sir, Dr. Vimalraj, sir, to introduce the speaker for the upcoming session.
Good morning. I welcome Dr. Chia Hong Chen, pulmonary medicine PhD. He has done his PhD. He's associate professor, interventional pulmonologist, China Medical University, Taiwan, and he'll be emphasizing his point on central airway obstruction. And he has a long stint in this field, so he'll be better to explain about the central airway obstruction. He's a member of the Taiwan Society of Pulmonary and Critical Care Medicine and the World Association of Bronchology and Interventional Pulmonology. He received the ASPR Young Investigators Award in 2006 and Taiwan Society of Pulmonary and Critical Care Medicine Excellent Award on Oral Presentation for the years 2015 and 2016. He has published over 110 peer-reviewed journal articles and 6 book chapters. Now his research interest is focused on interventional pulmonology and airway disease. I noticed that you got the Young Investigators Award in 2006, but you still look very, very young. And congratulations, and wish you a great future ahead. Thank you.
Thank you, sir. Sir, you can start your presentation.
Okay. Okay. Thank you for the introduce from the moderator. Can you see my slide? It's okay. Can everyone see my slide? It's okay.
Yes, sir. Yes, sir. We can see, sir.
Okay, thank you. I'm Dr. Chen from the China Medical University Hospital. Today I have gave everyone a talk which is about the management of central airway obstruction in our experience. So first, I want to introduce the central airway obstruction. The central airway obstruction may be due to the location, and you can know the etiology. For example, if the central airway obstruction is over the upper, maybe it's due to the thyroid tumor, and if the obstruction site is over the trachea, maybe it's due to the trachea or esophageal tumor. And also if the site of obstruction is over the subcarina, maybe it's due to the median stenonephroencephalopathy. And if the site is over the hila, maybe it's due to the bronchial tumor. Now we have 3 types of the classification of airway tumor involvement. The first is the intrinsic stenosis. And this stenosis is purely endoluminal tumor without breach of the cartilage. The second is the extrinsic stenosis. This is the extraluminal tumor causing muscle effect but no endoluminal involvement. The third is the mixed stenosis. This is the extraluminal tumor causing muscle effect and the endoluminal involvement. So this is the picture of the 3 classification, the central airway obstruction. The first is the endoluminal tumor, and the second is the extrinsic, and the third is the mixed type of the central airway obstruction. So this is the etiology of the central airway obstruction. We can classify into the malignant central airway obstruction and the non-malignant central airway obstruction. Malignant central airway obstruction usually due to the lung cancer and the other metastatic carcinoma, and the non-malignant central airway obstruction may be due to the liver adenopathy, such as the sarcoidosis or infection due to TB, and also some cartilage problems, such as relapsing polychondritis or some granulation tissue, will also cause the non-malignant central airway obstruction. So I will introduce the equipment of the interventional pulmonology for management the central airway obstruction. First, I want to introduce the endobronchial laser. Laser is the effective and also a safe equipment for management the central airway obstruction. So we can use the Yager laser to cut the tumor and also give the tumor a correction to stop the bleeding. But the problem maybe is the endobronchial laser is too expensive. So you need more cost to use this equipment to treat the central air obstruction. The second, I want to introduce the endobronchial brachytherapy. So this method, we must insert the radian 192 into the central airway obstructed site. So we use the bronchoscope and let the irradiant 192 to the obstruction. Then the irradiant will use the radiology therapy to cause the central air obstruction, heal the treatment. Second, I want to choose the photodynamic therapy. In this therapy, we must injection the photo sensor to the human body. Later, the photo sensor is activated by a partial wavelength of light via the bronchoscope to generate the reactive oxygen species. After this procedure, the generated ROS is cytotoxic, which can trigger a apoptotic or recurrent lung cancer for the lung cancer cell to death. Also, we will use the endobronchial cryotherapy. This cryotherapy is used for the CO2. And if you use the cryotherapy, we can remove the endobronchial tumor to treat the central airway obstruction. So we can see right now, we use the cryoprobe. This can be used for the treatment and also can be used for the diagnosis. So we can use the cryoprobe for the cryoextraction for the foreign body, and also can be used for the endobronchial tumor. Now we also can use the cryoprobe or the minimal cryoprobe for the lung or for the pleural emission for the diagnosis purpose to use this cryoprobe. We also use the endobronchial electrocautery. Electrocautery right now is called the Pullman's laser. So it's not very expensive and use the unipolar electrode. So we had 4 equipment. The first is the knife to give the tumor resection. And this is the probe for the tumor bleeding. And this is the forceps. And we also use the snare to cut off the stalk of the tumor. So right now we will use the snare and the cryoextraction to fasten the airway tumor treatment. So we use the snare first. So give the snare to the tumor, and we will cut off the stalk of the tumor. After we cut off the stalk tumor, we will give the patient the cryoprobe. So cryoprobe will adhesion to the mask and remove the mask as soon as possible. So you can see this is the snare. So after we cut off the stalk of the tumor, then we will insert the cryoprobe. So we will insert this cryoprobe to adhesion this mask, let the tumor out of the trachea. So we can see it is easily remove the airway tumor by the cryoprobe. We also have the argon plasma coagulation. So we use the argon gas to shift to the argon plasma. Argon plasma can cover the tumor wound and then later the bleeding stop. So so the APC is the good equipment for the bleeding stop. We also insert the trachea or bronchial stent for the central airway obstruction. Now we have 2 types of the stent. One is silicone stent, another one is metallic stent. Silicone stent is difficult to placement, so we need the regional bronchoscope, and also the patient need the adrenal anesthesia. But the silicone stent usually do not have tissue ingress and also do not have the granulation tissue problem. If the metallic stent, it is easy to deliver, and the patient can be inserted from the flexible bronchoscope, and the patient just need to the conscious sedation. But the metallic stent maybe have some problem about the tissue ingress, and also sometimes will have the granulation tissue formation beside the metallic stent. So FDA has announced if we want to use metallic stent, maybe just use in the malignant central airway obstruction. So it is the stent insertion. So we will implant the stent to the site of obstruction. then we'll release the stent. So after the stent was released, maybe we can treat the central air obstruction and then the obstruction improve. So like to see some evidence from the interventional pulmonology. And the first is from the lung cancer, it is from the French, the study we call the Evermore. So we can see he do the interventional pulmonology for the central malignant airway obstruction patient. So after we do the interventional pulmonology for this patient, the patient will have higher survival gain than the standard group, especially if the patient with KRAS mutation or the lumen occlusion is more than 65%, and also if the patient lacking the enlargement of the left bronchus. The second paper is from the BMC Pulmonary Medicine in 2020. This study is made by the Korea. So we can see in this study there are 224 patients to do the interventional pulmonology for the central air obstruction. The most common etiology is squamous cell carcinoma, and the success rate for the technique is about 93.7%. And the acute complication is just about 50%, and the procedure-related death rate is about 1.3. The median survival time is 7 months, and the survival rate at 1 year and 2 years is about 30% and 28%. He have some outcome predictor, and the most poor survival predictor is about the underlying of COPD, and also if the patient is poor performance status, and if the lesion is extended, and also if the central airway obstruction type is intrinsic or is the mixed lesion, and if the patient do not receive adjuvant treatment after bronchoscopy intervention. The next is also from the BMC Pulmonary Medicine in 2019. The paper is made by China. So we can see he had 300 patients to do the interventional pulmonology for the malignant central air obstruction. So we can see just 50% procedure were unsuccessful. He also have some good outcome predictor, include if the distant pattern airway can be seen on CT scan or during the bronchoscopy, and if the patient is non-smoker, or if the patient is decreased time from the radiography finding of CAO to intervention. The next patient is from our hospital, which is published in Medicine in 2017. So we can see from the 2000 to 2015, we have 481 persons with central air obstruction. There are most patients is male. The mean age is about 16 years. The most common etiology of CAO is lung cancer and esophageal cancer. In our hospital, the IP technique success rate is about 95%, and the procedure-related death is about 0.7%. So from our hospital, we can see if the patient with the CAO, then the patient maybe have the poor outcome. But after the patient treated with the CAO, we can see from our hospital's data, this patient treated with IO, the outcome of CAO lung cancer will similar with no CAO lung cancer patient. So maybe it's the value of the interventional pulmonology. After treatment with the IP, the patient's outcome will be better. I will introduce some case for everyone. This is the first case. It's the 34 male patient. He do not have past history and is also the non-smoking. He had a short breath, maybe about 6 months. So from the traces, we can see the airway tumor over the trachea. So the CT is also see the airway tumor about the upper of the trachea. So in this patient, we gave the patient electrocotomy while extraction and also use the APC for the breathing control. And after the treatment, we also inserted the trachea stent. So we can see the diagnosis, the adenoid carcinoma. The second case is the 32 male patient. He's a cooker and do not have any past history. And he also do not smoking and have dyspnea for maybe about 1 month. So we also can see the airway tumor is over the right main bronchus. So from the CT, we can see the tumor is from the right main bronchus to the carina. So in this patient, we use the electrocotomy and also use the cryoablation to remove the airway tumor. And the diagnosis of this patient is lymphoma. The third case is the 46 years female patient. He had the past history of the breast cancer for more than 3 years. He do not smoking and also have to show breast for about 3 months. So from the chest X-ray, we can see the left side, the right lung is collapsed. So from the CT, we can see the airway obstruction size about right main bronchus. So in this patient, we do the bronchoscopy and we can see airway tumor over the right main bronchus. So we use the electrocotomy and also the cryoablation for the tumor review. And the diagnosis of this patient is the breast cancer. So after treatment, we can see the chest X-ray is improved and the closed lung is improved than before. Last case is the 35 years old male patient. He also is a cooker and he has a smoking history. This time he also have dyspnea for 1 month. So we can see the chest X-ray show the airway trachea tumor. So in this patient, we can see the bronchoscopy show the tumor is over the trachea. So we also use the electrocotomy snare and use the cryoablation to remove the airway tumor. And this patient, the diagnosis is the trachea lipoma. Next case is the 58 years old female patient. And he do not have the any past history and also is a smoker. This time he have the short breath for 1 month. So we can see this is the chest X-ray. From the CT, we also can see he have the airway tumor maybe over the trachea. So this patient, we use the electrocotomy and also use the cryoablation. After treatment, we also insert the stent for the airway obstruction. The diagnosis of this patient is lung cancer. After treatment, in this patient, after treatment with the chemotherapy, the airway obstruction is improved. So after 3 months, we remove the stent. So metastasis maybe can be inserted and can be also removed by the flexible bronchoscopy. Next, I will introduce my hospital's experience. So from 2008 to 2022, in our hospital, we have do 50,893 bronchoscope. And also we do about 1,225 electrocotomy and stent. We also do the percutaneous tracheostomy and maybe about 1,400 patients do this procedure. We also do the diagnostic bronchoscope. So right now we do about 7,000 patients for the EBUS and 1,632 TBNA. We also do maybe about 370 for bronchoscopy. So we can see right now we do average about 90 to 100% for the electrocotomy and also for the stent insertion. So I will introduce our hospital about 14 years experience. So from 2005 to 2019, we have 864 patients with central airway obstruction. About 60 patients is male and the mean age is about 61.6. So from this patient, we can see about 60% do the electrocotomy and about 22.6 patients do the stent insertion. And also we have 30.1% do the balloon dilatation. And the most common etiology of the central airway obstruction is lung squamous cell carcinoma, and the later is the benign lesion, the esophageal cancer, and also the lung adenocarcinoma. So this is the median survival days after we use the IP procedure for this patient. So we can see if the patient is the esophageal cancer will have the poor survival day. Also, sometimes this patient will have the acute respiratory failure after the central airway obstruction. So we also to see if the patient with the malignant central airway obstruction and cause the airway cause the acute respiratory failure. After we treat with the interventional pulmonology, if this patient can improve after we use this procedure. So we see our hospital from the 2010 to the 2017. In these 8 years, we have 87 patients with central air obstruction need mechanical ventilation. Also, we can see about 76 patients is male, and the mean age is about 60 years. So in this patient, there were 55 patients need stent insertion, and about 40 patients need electrolyte and stent insertion, and only about 6% patient will need electrocoated stent and balloon dilatation. The most common etiology of the CAL is esophageal cancer and the lung squamous cell carcinoma. So we want to compare if any outcome predictor can tell us after we do the interventional pulmonology, the patient can be successful for this procedure. So we analyze our hospital's data. So we can see if the FIO before the procedure is low, then patient can be successful is increased. And also if the patient is acute low bar or acute total lung collapse, it's also the good outcome predictor. But if the patient is pneumonia when respiratory failure, or is the patient with high CRP, maybe it's the poor outcome predictor. So we do the multivariate analysis to further analysis which one is the good outcome predictor and which one is the bad outcome predictor. So we can see if the patient, so we can see if initial FiO2 is more than 40%, then the patient will be a poor outcome predictor. And also, if the patient is the acute low bar or total collapse, maybe this is the good outcome predictor. And if the patient had pneumonia when respiratory failure, this is also the poor outcome predictor. And also, if the size of a tumor around the airway more than 3 cm, maybe this is also a poor outcome predictor. So we had to create a scoring center, which we call the two score. The two score maybe includes the 4 parameters. The first one, if the FiO2 person, if initial before the procedure, FiO2 is more than 40%, the patient will get a 2 point. And if the pneumonia when respiratory failure, the patient will get 3 point. And if the size of the tumor around the airway is more than 3.5 centimeter, and the patient will get 2 point. And then if on the procedure, the patient is acute low bar or acute total lung collapse, it's a good outcome predictor. So he have the minus 0.2 point. So this, so we can use this scoring system to predict if the patient can be improved after interventional pulmonology. So if the two score is more than 4 point, that means the patient is difficult to wean from the endotracheal tube even after stent insertion. So I will give you some conclusion. Central obstruction is it maybe is an emergent problem for treatment. So if the central air obstruction is emergency, maybe you if the lesion is submucosal or extrusion lesion, and then you need to stent to treat this condition. And if the lesion is an endobronchial lesion, maybe you can use the balloon dilatation, laser, or the electrocotomy or the APC for this problem. And if the central air obstruction is not emergency, and if the patient can take the curative resection, maybe the patient can be used the surgery to treat this central air obstruction. But if the patient cannot do the surgery, we can see what the classification of this central air obstruction. If the CL is the endobronchial lesion, maybe you can use the balloon dilatation, laser, cryo, electrocotomy, and also photodilated therapy. And also you can use the brachytherapy, APC, or use the external beam radiation. But if the lesion is submucosal or extrusion lesion, maybe you need the balloon dilatation, brachytherapy, and the external beam radiation for treatment of the CL. So this 4 chart maybe can use in the for the IPMED to face the central air obstruction to treat this patient, and then let this patient got more improvement. So this is my talk today. Thank you, everyone.
Thank you very much, sir, for an excellent talk. Is there any questions from audience? Stage is open for discussion. Sir? So Vimal here, sir.
Yes.
Yeah,
Yes, sir. I just want to know in the panel discussion, we'll be discussing elaborately about the central airway obstruction, the pros and cons with respect to dealing it with the rigid bronchoscopy and flexible bronchoscopy, sir. Since we know that in Taiwan, in China Medical University, we are dealing with CAO primarily with flexible bronchoscopy. I just want to give the audience a general idea about how we deal with a tumor with a flexible, and that too with a conscious sedation without help of anesthesiology, sir. Just an outline, sir.
That's you say if we just use the flexible bronchoscope and under the conscious sedation is okay for treat the central air obstruction?
Yes, sir. Here in India, we use primarily many centers use rigid scopy for managing central airway obstruction. So just want to know your our CMUH centers approach via flexible. Brief outlines.
Yeah, because in our hospital we do not use the rigid bronchoscope under the general anesthesia, so we just use the flexible bronchoscopy and under the patient with the conscious sedation. I think this is okay because we can follow monitor the saturation and to do this procedure and in these years, we do not have any complication after we use this method to management the central air obstruction. So I see the flexible bronchoscope with the conscious sedation is safety for us to treat the central air obstruction.
Thank you, sir. We will discuss about that in detail during the panel discussion, sir. Thank you for excellent talk, sir. There is no more questions here. We'll wrap up the session.
Thank you, sir. I would like to call upon our HOD, sir, to hand over the memento to our former HOD, sir, Professor Dr. Surendra Menon, sir. Thank you, sir. Now I would like to call upon our Associate Professor, Dr. Vimalraj, sir, Dr. Aravindran Alaga, sir, and Dr. Tyagesha Deva Ganapati, sir, to introduce a speaker for the next session and start with the proceeding.
Welcome, sir. The speaker is Dr. V.R. Pattabhiraman, sir, MD DNB in Respiratory Medicine. He is a consultant in interventional pulmonology and sleep medicine at CAPI, Center for Advanced Pulmonary Interventions at Royal Care Specialty Hospitals, Coimbatore. He did his MD and DNB from the prestigious MMC Chennai. He was trained in all facets of IP and is one of the pioneers in IP in India. He works in a group called Pulmonology Associates with Dr. Mahadevan and Dr. Arjun Srinivasan at CAPI, Royal Care Hospitals, Coimbatore, a comprehensive center for IP, which was inaugurated by Dr. Felix Herth from Heidelberg Thoracic Clinic. He has been visiting professor for the Department of Chest Diseases at Sri Ramachandra Medical College from 2019. He set up the first EBUS program in the country in 2008. In our China Medical University talks on EBUS, they had mentioned the first EBUS program was started in India in the year 2008. maybe they might not have known your name, sir. And Dr. Tu, sir, here we have amidst us the person who has introduced EBUS in Southeast Asia. He set up the first bronchodiaplasty program in the country in 2017. He heads the full-fledged department of IP. He has presented lectures in national and international conferences, has around 20 publications in index journals. And organizes annual IP meetings, which are well attended, and organized BronchoCon in the year 2018. He has trained more than 150 pulmonologists in the field of IP. Welcome, sir. The stage is yours.
Thank you, respected chairpersons. First up, thanks, Vimal, and thanks, Parni, my good friend, for giving me this, privilege to attend this wonderful meeting. So, over the next 25 minutes or so, I'm just going to discuss about what I think are relevant facts of peripheral lesions, past, present, and future, and there will be a focus on the Indian context completely. So what is a peripheral lesion? Any lesion that abuts the chest wall needs only an ultrasound guided biopsy, and it needs neither CT guided biopsy nor a bronchoscopic technique. So we're not looking at that. We're looking at a lesion or a nodule which is surrounded by a lung, predominantly in the mid or a lateral third, like this one, wherein there will be lungs surrounding all the while. So why is a peripheral lesion important in pulmonology practice? There are a lot of CTs in post-COVID era, especially. There are a lot of nodules that have been picked up. Lung cancer screening has shown a positive trial for the first time that came out in NEJM, and following which, a lot of nodule clinics that have become popular in the Western world. A lot of vendors have showed up recently, and a lot of noise in this particular area of peripheral pulmonary nodule, and that's again thanks to the reimbursement thing, and that's a predominantly a Western concept. And future seems to be aligned with both diagnostic and therapeutic capability in a peripheral lesions. But in pulmonary practice in India, is a PPL important? It is important. Though the CT guided biopsy remains the past, present, and possibly future in the majority of our country, previously there used to be a loop. There was a GP, he starts ATT for any shadow, a failed ATT, a CT biopsy was done by a radiologist and interpreted by a pathologist, referred to an oncologist, and that was a loop that was traditionally been the system, especially for a peripheral lesion, and pulmonologists were nowhere in the picture. Last 15 years, a lot of things happened. Oncologists needed staging. Convex probe EBUS showed up in the country. Pulmonologists became a little on the forefront, and they've become more, because therapeutics have become more customized now. And we are actually being pushed to the center of this loop, quite willingly though. So a CT guided biopsy would continue to hold its relevance because their yield is a 90%, and you can't really escape that. 90% is a number that the radiologist can show, and we are looking at all our trying to match up with them. The complications, as seen in the literature, has been briskly refuted by all the radiologists saying not in our hands, but it's a fact that there is a significant amount of a pneumothorax, and it's easier for the patients, and it's less costly, and there are no significant complications. So pneumothorax would be significant many thing. And what are the advantages? They don't go through this navigation process. See, CT is a beautiful thing. They don't need to worry about whether there is a bronchosine or not, because there is a lesion you go across. We don't need to respect any segmental boundary there. Tool in the lesion is confirmed because you put in a needle and then you take another CT and you get a thing. And there is not much of an anesthesia requirement. A mild sedation is all that you could get. There is also a significant literature bias here. See, a CT radiologist can upfront decide whether we can go at this or not. If there is a lot of emphysema around it, he would say that, no, I'm not going to touch this lesion. Whereas a bronchoscopist it has no such option. He has to go through all the processes, and then you realize that, okay, this lesion was not that thing. And so the denominator effect in a radiologist, you will right away rule that out. So all the thing that you see a 90% would be, taking off all these things. So is it actually a 90% is something that we'll have to decide? And so they don't attempt all those lesions, a lesion behind the thing close to diaphragm, all that. Our radiologists have this thing to say that, no, I don't need to do this. And so their denominator comes less, and so they have a skewed higher yield is possibly what I think it is. So a CT guided aspiration, it yields high sensitivity values with a slightly lower sensitivity for a smaller lesion. So a lesion which is smaller, the sensitivity actually drops down, and more than 22 centimeter traverse length, sensitivity drops further to 59%. These are not what they've usually told you. And the complication actually, if it's very deep in, can actually go to close to 50%. So look at this. This is not only the pneumothorax, which is on average around 24%. There is also significant pulmonary hemorrhage that can happen. So let's go via airways and let's see how we fare. Now, with a conventional bronchoscopy and a transbronchial lung biopsy, we didn't really do well. The size is the strongest determinant, and it's especially in the lower size lesion, less than 2 centimeter, especially in the outer third of the lung. Look at the thing. If I have a pointer, it'll be good, but otherwise, you are looking at a 14% yield. 14% yield is not something that we can really talk home about. Let's see if the fluoro has increased it anyway. Having a fluoro again in the less than 2 centimeter lesion. Now, this less than 2 centimeter lesion and bronchus sign will keep coming up in our talk more often. So this has a 34% chance, even if you use a fluoro. So let's just put it in perspective. What are the things that we'll need to do when you deal with a peripheral lung lesion? Oh, thank you. First thing is we'll have to get close to that lesion. The airways will guide us, but you can easily get lost there. So you'll need to have some kind of a navigation. You'll have to confirm that you have reached there. So it's not enough that you probably know that you're in. So you'll have to confirm it. And then you'll have to do a biopsy, which should also need a variety because it depends on the pattern of relationship with the lesion. I'll come to that a little further. And you should confirm that the tool is in the lesion and provide a real-time output. So it's not enough that you reach there and you know that you've reached there and you have the tools. You'll also need to know whether there is a tool in the lesion, and most importantly, whether the lesion is in the tool subsequently. So those are the issues, and for that, you'll need to know that these are the types of peripheral lesion. A radiologist would not need to know all this because he just comes like this. Here, you'll have to go through this. So type 1 is a very ideal lesion where there is a bronchus or a bronchiole which leads on to this tumor. So straight, and it doesn't go any further. Lovely place for a pulmonologist to do it. Now, there are other things where you just go through it and for some time you traverse through the lesion, versus a 3 where you can actually reach there till here, agonizingly close, but you can't really do a biopsy of this. Whereas here, there is a lesion and there is a bronchus, but you can't reach that bronchus because there is some compression above it. So these are the types of peripheral lesion that you have. And let's go to one by one. So again, size less than 2 centimeters, one such thing. Second thing is a bronchus sign. If you have a bronchus sign on a CT scan, always read your CT very well. You can see that the bronchus leads on to the lesion. It doesn't go any further. This is a good news. Even if the lesion is less size, with an appropriate navigation and tools, your yield is going to be upward of 80%. How to get close to the lesion? The best possible thing and the most difficult thing is to use your brain. Japanese did that consistently. This is Dr. Kurimoto's book called Bronchial Branching Tracing. Lovely book. I tried looking at it. It's so confusing. The Japanese are so adept in their surgical anatomy, and the way they train is, it's not only about your segment, subsegment, and we stop there. They go on further and further, and not only that. So this is a beautiful book, which actually tells you once you reach this area, what are the bronchus that will be there? And once you reach this area, what are the things that will show up? So for every segment, they just give you a diagram and they follow in a very systematic way. And, the result is, I'm not able to. Yeah. So you can see it's not only this and this, you can see it's further, and they just keep having a nomenclature which includes alpha, beta, 1, small letter, capital letter, and all that. And in the end, they'll just say that you'll have to, for this lesion, you have to go in, take a left, take a right, and they do it everything in the brain. We tried reading it, and immediately we realized that it's not for us, and so we embarked on something costlier. Navigation bronchoscopy. Put it simply, it uses a technology instead of the brain, beyond the standard cross-sectional imaging, to help the bronchoscopist accurately to navigate to the bronchoscope to the area of interest beyond the airway. So what does it have? There is an electromagnetic navigation. I'm not going to discuss anything further because it's not available in India, whereas this is a virtual navigation system, which is essentially usage of your CT. And what we have is called as a lung point. We are looking at the present here. Now, what is a lung point? It has following requirements. You will need to have a recently done CT, and it should be in thin section. More than 200 images should be available, and it should be available in a CD. And once you do that, this software will take the lesion. You'll have to draw this lesion and you'll have to feed it in the thing, and it will make a virtual thing. It will give you 3 paths which suggested the easiest path can be followed depending upon the operator's preference, and it will be given on a virtual bronchoscopy path. So before you go in, you can see that, okay, so this is how it looks, and you can see that once you feed everything in, it will give you a path. And this is a path 1, wherein the blue line is what you'll just take it. So once you go to the thing, you have the vessels coming over here, and you could actually go to the, so here you can see the left upper lobe, and then it's going into the anterior and then go further and further. So it will lead you a path so that you can actually, reach the lesion. It also gives additional information, like this is the distal end of the target, this is the proximal edge of the target, and this is a maximum diameter and a minimum diameter. So you can also choose which bronchoscope to use so that you reach there, and what is the distance between that. So all these things can be calculated or understood. And so this is, for instance, a patient with an ingular, inferior lingular thing, and we use this. And what is on the right is the computer derived, and this as we go in the bronchoscopy. So you have a video bronchoscopy. So it's like a video game. So you keep following that blue line. And if it shows red, you're going to the wrong place. So it just guides you. So you just keep going there. So, and it will tell that, and you'll have to believe it, and you'll go there. Now, once you reach that point, it is a blind point. You would have reached the target, but is that enough? So navigation will help you to getting where you want to go. But is that enough? I have a problem moving the slides now. Okay. Okay, thank you. So here with this navigation, you can reach that place. However, you'll need to have a confirmation. So let's look at what the confirmation can be done. So, so you have what do you require to sample? Once you have a navigation, you'll need a bronchoscopy, preferably a thin one. You'll need accessories appropriately. The most important thing is you'll need a confirmation. Usually it is a radial probe EBUS. Anyone investing in a VBN is likely to be having a radius EBUS facility. We think it is important. And fluoroscopy, which is also optional. So confirming after you reached it is what we're going to do. What are the things that are available? Radial probe EBUS is available. Fluoroscopy is available. These things are, I would categorize it as a future, though it is kind of present. So radial probe ultrasound is a small probe, which you can use it in a regular bronchoscope, which gives you a 360 degrees idea using a scan all around. So this is a 360 degree forward, 360 degree, diameter. You can see all around. So you see, this is a lesion. You've reached there using a navigation. However, you'll have to use it by confirmation. So you'll just put in a probe in, and this is a probe which actually rotates 360 degrees and it scans all over. It's usually typically a 20 hertz, megahertz thing. And you actually reach the lung. Once it reaches the lung, it will be showing a sunstorm appearance. But once you reach the lesion, then it will just suddenly become hyperechoic and it becomes black, and so you know where the lesion is. So you'll have to appreciate a normal lung. A normal lung looks like a sunstorm appearance, whereas a lesion will look quite dark. So this is how it is. You can see that. So let's look at how it performs. A diagnostic performance, it has a reasonable sensitivity. The diagnosis yield increases with bronchus sign depending on the size of the lesion. Again, less than 2 centimeter, no bronchus sign. Even if you have a radial probe, you can see it, but you can't really diagnose it, or meaning take a biopsy. So biopsy yield is significantly higher when performed within the lesion. So which means this is the airway and this is all around. So tumor is all around. So you take a biopsy, you have a very good chance of making a diagnosis. Whereas this is an eccentric thing. This is the airway. The lesion is on the right side of the airway. Even if you try and take a biopsy from here, it might not give you a proper thing. So if the location of the probe is within, you have a 87%. If it is adjacent, which is what is type 3, Type 3 will have a 42% yield because there's only a small chance that your wall of the bronchus will be involved. So we just looked at this. But in that case, we also, in the same area, put in the radial probe and look at it. This is an eccentric thing. So if there is anything eccentric, what do? It's not only about forceps. You might also have to put in a needle, or you might have to do a cryo. So cryo will shear the wall, and also you can give a better yield. So your accessories are also very important. Yeah. So if you use a combination of a VBN with EBUS to diagnose small peripheral lesion, there was a randomized trial which showed between the virtual bronchoscopic navigation and without virtual bronchoscopic navigation, there was a significant difference only when the lesion was less than 2 centimeters. More than 2 centimeters is not statistically significant difference. So bigger lesion, you don't need to worry. Just put in a radial probe and take a biopsy. If there's a smaller lesion, you might have to use a a navigation will help not only in a smaller lesion, it also helps in reducing the time on spent in the bronchoscopy. Now, this is what we've been looking at. The bane of all our interventional thing is forceps can reach the lesion, or the probe can reach the lesion, but yield substantially is between 70 and 80%. So for this, we might have to have a nuance in terms of a biopsy tool. We'll need variety of tools because you can see this, but you can't reach it. So for that, you'll have to have a cross country. You'll have to, kind of break the wall and then take a biopsy. So this is how you look at it. If the lesion is type 1 upfront, you'll have to see that this is a comfortable thing. A biopsy will be enough. You can use a forceps, or you can also use a brushing. A type 2, wherein it passes in, you'll need a proper fluoro also, along with forceps and brushing, because you should know where the lesion is and stop there, because you can keep going in because it's not a real time. In a type 3, you have to necessarily have a needle that goes in, or a cryo. In a type 4, again, you'll need to have a cryo and a needle. So these are the tools that you'll have to use, and the cryo can be very useful. And so here you can see that we are putting a sheath. So this is a sheath, a small sheath. This is just an extended instrument channel. So the sheath goes in, and through which you put in a cryo. So first thing will be, you'll have to make sure your radial probe is showing that there is a lesion. So this is there is a sheath now, and through which the radial probe has shown that the sheath is just before that lesion. So all you need is just put in a cryo probe, go further as long as it goes and hits, and then take multiple biopsies, so that this is a type 1 lesion, but still we can use a cryo probe. The advantage of cryo probe in this sheath is it's a smaller sheath in a bigger scope, but it will allow a 1.1 cryo to go in and come out. So you don't need to take the whole thing out when you use this kind of a sheath. And this also helps in preventing the bleed. So this is a very convenient thing to use. Now, this is as far as the present goes. Now, what is the future? The last few slides about the future, which is to confirm that the tool is in the lesion and provide real-time inputs. This is where we lack. This is where we are 70%, whereas radiologists are at 90%. This is a tool in the lesion, and there is also something called as a CT body divergence. I'll just give a small perspective on that. Now, a future role in a PPL, if you're just going to fight about between the 80% to 90%, that's not enough, because we would not be restricted by the boundaries that airway anatomy presents. That would be our future. We should also not be prevented by the boundaries that the tracheobronchial tree offers. So we'll have to breach that boundary. We can reach most places. We can confirm the track. We will be able to put the tool in the lesion. We will be able to confirm it. We will be able to do it real time. We will be able to make a diagnosis, and we will also be able to think about treating it. Now, that is the most important key, because all these are going to be just extended working channel. Think about this. Our scope, the working channel stops at the end of the scope. The lesion is somewhere in the periphery. We would like to have the sheath that goes all the way, and we'll have to have a technology to ensure that the sheath reaches the center of the lesion. With whatever be the type 1 or a type 2 or a type 3 or a type 4, we should go with the sheath into the center of the lesion. We should make sure that we're able to put enough tools We'll also be able to track it. We'll also be able to identify that the tool is in the lesion by imaging process, and we'll also have to make sure that we can treat it either with the radio frequency, microwave, or a cryo. Think about it. Malignancy, smaller, early 1A malignancies, where at this day and age we can have a smaller EBUS to make sure that not much of nodes inside, and so that we stage it in the same day, and then you can actually put in a sheath there, and from there you just make further biopsies, confirm it at the site, and then you also pulverize it using with the radio frequency, microwave, or a thing. It could be extended. Even just think about it. You'll have to have an ignited mind. You just keep thinking about it. If you have a MDR TB, that is a problem, and you can even use a steam, or those things can be used. It's not necessarily confined to malignancy, but we will have to have a more impetus on therapeutic work. Until such time, I think this will remain a very, very costly proposition for just a diagnostic thing. I'll just talk a bit about the robotic and the body vision cone beam CT. These are very, very, advanced things. They have a lot of cost as far as the setup goes, but I think these are coming in a big way. So a robotic, what does it do? In a robotic, there are three kind of platforms that are available. The earliest one was a Monarch, and then there was an Ion, and now this is the latest to be approved in the March this year, is a Galaxy system. But the important thing would be a Galaxy is something that is disposable, because that is the problem. You'll have to have a disposable scope in a thing, so you're looking at a cost which is going to be humongous, whereas these are not. And the navigation technology in a thing, and so there is also another navigation technology, and Robo just gives you additional thing. The problems tackled by Robo, I'm not going into the details of the Robo, but what you can do is the robos can go into more distal airways. The more importantly, the steerability is enabling the navigation further into the lung, and you can also fix it. Now the thing is, think about it. If it is in the right upper lobe apical or a left upper lobe apical, you'll have to use a wrist. Here the Robo, we are not using the scope, we're just using the joystick, and so that you can keep the lesion and make sure that the lesion reaches in the most convoluted kind of bronchial branching, and you can keep it staying there so that the biopsy forceps can be used. So you will get the stability of the whole process of the human component, so it's making it a bit of an idiot proof. However, you can only go there. I mean, it just steers you there. But again, the factors affecting the yield, look at that. The primary bronchus sign again, and the size. If the size is less and the bronchus sign is not there, you would still have a reduction in the percentage. What is not affected is operator experience, location of the lesion, and the distance from the pleura. This is all that the Robo can tackle. So again, despite all this, including a navigation platform or a robotic platform, you will still have a yield of 75-77%. Now, this is because of what is called as a CT to body divergence. Now, typically, you do a CT with patient lying down, conscious, on a day before or a week before. You will use your mind and say that, okay, this is where it is. However, there can be differences between a static pre-procedural CT and a dynamic breathing during a lung bronchoscopy. There can be a movement of a nodule, which is, look at it, 17 millimeter movement. Now, 17 millimeter is the size of the lesion, but the whole size of the lesion can be so if you think about it and you go with the way of, see, this is a lesion like this. Once the patient lies down, see, all these technology will involve sedation or even anesthesia. Most of a cone beam CT and all that, the patient will be anesthetized. When he lies down, all these atelectasis and all this will completely make sure that the lesion is actually not seen in the place where it's supposed to be thing. So these are the issues when you go for this small and the peripheral lesion, especially closer to the diaphragm and so on. So what are the reasons? There is a difference in the lung volume, full inspiration versus FRC, because that's what you're supposed to do when you do a full CT when a patient is comfortable. Timing of a pre-procedure CT, again, there can be new evidence of changes. There can be change in size if it's done sufficiently late. There is a ferromagnetic interference. Atelectasis is the most important thing because the patient is under GA, supine. You also wedge the bronchoscope, you keep suctioning, so there can be changes that can happen. So when you do all these procedures, you'll have to have a protocol. The patient has to be ventilated with a PEEP, and you'll have to ensure that you'll have to keep a ventilation hold at some point. So this is what is done when you do a cone beam CT. Now, cone beam CT is you're doing actually close to almost in a CT gantry. This is how it is. It just takes a whole rotation. It's not as bad in terms of radiation as a regular CT would do. One full spin would probably have a radiation which is almost equivalent to one chest X-ray. That's all it is. There is a conformation of the tool in the lesion. It overcomes CT to body but divergence. It's most accurate. It is expensive. It can be floor or ceiling mounted, and it can be mobile. It can be combined with other modalities. It can provide navigation. Now, this can be seen done in also a O-arm. If your hospital has a O-arm, if your hospital has a cone beam CT, it is available in most of the radiologists. All you need is just have to take your thing into their gantry. The only thing is you'll have to take all the things and then go there, so that this will eliminate the CT body divergence. However, this will only make sure that you are looking that the tool is actually inside the lesion. So the two things, CT body divergence and the tool in the lesion is taken care of. If you run a cone beam CT. So you imagine all this. If you have a robotic, even if you don't have a robotic, if you have a proper cryo, you'll have to put it in. And then also you run a CT so that ensure that the tool is inside the lesion. Invariably, the lesion will be inside the tool. What does it? How does it prove? So CBCT, which is cone beam CT plus augmented fluoroscopy. I'll tell you what it is just the next few slides. And in 2018 and 2019, there were a couple of things. The single center, most of it is overall diagnostic yield was around 83%. Now we are approaching somewhere meaningful. All of them are done a GA or a hybrid OR, and similar in the nodules of size less than 2 millimeter also. So this is for the first time, this 2 millimeter is going off. All procedures were done. Ball, brushing, TBLB, and needle aspiration. Again, here the yield is 90%. There's only one case of pneumothorax, again done under a GA. And this is by Robert Casal, came out in, again, 20 cases, 4.2 mm. The diagnostic yield was 75%, again lower due to atelectasis. This is the paper from where we just start. We'll have to use PEEP subsequently. The procedure time was a little high. Again, another thing in 2021, they were looking at an 83% thing. So these are the studies that are available. This is a setup. You're looking at a thing. You do a bronchoscopy and you have to run out because there's going to be a fluoroscopy. So you'll have to have a fixed frame. So you put the bronchoscope in. If you have a robotic along with this, it is fine. Otherwise, you'll have to use this, and there will be a adapter which will be stuck. You'll have to hold the scope there, and then you leave and you take one spin. And this is how the spin will go. You can see the whole thing will spin, and you can see the scope is inside. We'll know whether the scope is inside and the lesion is also the instrument is also inside the lesion. So this is how a CBCT works, and integrating everything is lung vision by body vision. This is the last few slides. This is a standalone navigation plus real-time imaging system, which is compatible with any standard arm. So if you have a fluoro, there will be, this is an AI based. This will be compatible with any existing robotic or a navigation platform. It has three things. This is the main console, and there will be a remote control, and this is a bronchoscope, and this is a body vision or a lung vision, it's called. This is a special sheath. You can see that this is a steerable sheath. So it just go in, and then you can steer it further to make sure that you go to the center of the lesion. First thing, like a lung point, you do a virtual bronchoscopic thing. Then the first spin is done when there are two C-arm spins are done. First spin is to look at the carinal lesion. The second spin is to make sure that the lesion is properly seen. And subsequently, this is an augmented fluoroscopy. So the fluoroscopy is integrated with that software, and so you will have the path which is aligned here. So you'll have to steer the thing looking at the fluoro. You'll need to keep steering it here, here, and here, so that you get close to the lesion. So this is one such spin. So the first spin, once there's something called a tool in the lesion spin. First is the registration. Second thing is actual thing when the patient is ventilated, and you just make sure that you go inside, and then you do one spin. And here you can see that this it's not very close. It is almost anterior to the thing, and so you make proper adjustment. Here it is, the lesion is here, this is anterior. So you look at all the dimensions, and you can see in this dimension, the lesion is here, the needle or the steer is quite thing. So you readjust it, So instead of going here, you take it back and then you find this pathway and then you push so the sheath goes into that pathway. And then you identify that the lesion is actually the tool is inside the lesion. This is how you confirm it. So this is AI-driven intraoperative imaging. It is available and it is available for sale in India also. It delivers the CBCT quality intraoperative 3D images with any C-arm. It eliminates CT body divergence, and the tool will actually be in the lesion. So once the sheath is inside, you can use all this. You can do a lavage, you can do a needle, you can do brushing, you can do cryo also if you want. So you can actually add a robotic if you have a lot of cash, greater stability and articulation will come. So this touches 90%. So key points is just a sum up of all the talks. All the points in the talk is peripheral lesion or SPN or a diagnostic challenge. Radiologists are the gold standard, unfortunately. Addition of bronchoscopic navigation adds to the diagnostic yield. The count constraints, obviously huge in initial cost. The requirement of sophisticated liaison between a CT and a VBN software is needed. There's a close attention to the lesion size, especially you'll have to look at the CT very carefully. Relation to the airways would determine the need for nuanced tools also. A combined fluoro, VBN and a radial probe EBUS helps in reaching a peripheral lesion more than 80% of the time in a proper hands. As we keep doing it, it improves, especially when you have a EBUS, TBNA needles and the cryo. The tools are important, especially in type 2 and type 3 lesions. Type 1, anything will help. Type 2 and type 3, you'll have to necessarily use a needle and cryo. To improve the lesion yield close to TTNA, body vision, Archimedes, CBCT may be needed. I didn't touch Archimedes, another platform. Setup is costly. Unless it is followed by a therapeutic benefit, it is unsustainable at this particular point. I'll be very happy to answer it. Until such time, I think sending him to radiologists is not a very bad option after all. Thank you.
Thank you so much for the wonderful presentation, sir. The session is open for discussion. Is there any questions? Dr. Arvind Alaga, sir, from Malaysia has joined us virtually for the discussion. Sir, if you have any questions, you can ask.
Okay, thank you, Dr. Vimal. I think thanks, Patabisa, for a wonderful talk. Just that, would like to ask your opinion. If you notice, like, Asian countries, I think except for Hong Kong, none of us actually really into the robotic bronchoscope system. And looking at the demography, I think India, Malaysia, I think we are on the same scale. In your opinion, when exactly, what is the timeline you're seeing that robotics will have an impact in our countries? That's number one. Number two, do you think that if robotics have a more scope rather than in a peripheral, if let's say we can incorporate in a central tumor also will have a more scope for its influence in our countries? What is your opinion about actually?
Thank you, Dr. Alaga. So, I would think India, I'm sure most of other parts are, but more specifically, India is a few decades together. I mean, there are different decades built up in India. So there might be some places where this can still be viable. For that, I think we'll need to have some real good data. And I think robotics as a surgical thing also is now slowly setting a foot, whereas it is a standard of care in many other places. I would think that it's going to take a long time before robotic reaches with any significant proportion in India, whereas it might be different in a more regulated medical care setup, wherein you will have one unit which will cater to certain I think if there is any governmental control, I think it will still be viable in some of the Asian countries. But I would think in Indian setup, I'm not too sure how it is going to come. Frankly, I do not know whether the robotic would be a great buy at this particular point. The reasons are there is a very competing technology which is going to be at a very minuscule cost. So that right away takes away a bulk of reason to invest on such a huge thing. As you said, if there is a additional involvement along with just a peripheral lesion, so I would think that any peripheral lesion is going to catapult into a bigger relevance only when there is a more than just need for a diagnosis. I think if there is going to be either a therapeutic application, not necessarily only in tumor, in other fields also, then I think there will be a lot of clamor for these things. And I think also if there is a screening which becomes a very mandate, I think every peripheral lesion issues started once there was a positive trial on a lung cancer screening trial, and after that there was some kind of a thing. Now there is a nodule clinic in most of the US. Every center is starting a nodule clinic because their thing is if just goes to the radiologist and then comes back, the time is saved because in a nodule clinic everything happens in a very specified time. So average time to make a diagnosis and meet a oncologist has come down drastically by weeks when they started this nodule clinic, and that's how they were able to justify the costs that are thing. In our country, at this particular point, there is no such compelling reasons to, reduce the duration because it's already, radiologists reaches faster, and there's not much of a governmental control in terms of how many centers have to be there and how many population that it has to cater to. So, a short answer to your question is I do not know when it is going to be relevant. And interesting thought is when there is a whether the robo can be used for central lesions. I'm not very sure because the fact is I'm talking without any personal experience, so I would just be very wishy-washy in this. I'm not too sure. If you have any experience you could share with us, because I have absolutely no personal thing with either the robo or a cone beam or a body vision. So
I think, sir, what is my thought is actually, if you notice that, as you mentioned very clearly in your slides, where radiologists can achieve the high yield and where we are using these adjunct tools, we are achieving like almost 70 to 80% of the yield.
Yeah.
Additional of robotics, we're going to see around, maybe we are talking about 90 to 95%. I mean, around 10 to 15% of increase in the yield, but that's come up with the additional upfront of the cost, initial setup and everything.
Yeah.
So that is where the issue is the initial setup cost, and the increment of the yield is around, we are talking about 5 to 10%, where
Yes.
this can be done by our radiologists who are well trained actually. Number two, when I'm looking at it, where Westerners, they have a less tuberculosis burden, whereas in our part of countries, we have a significant TB burden, and a lot of TB can present as a, rather than lung cancer can be a TB as well, and nodules and everything. So that's another way we are looking at it.
That's right.
But for me, like when I see that when Western so much of research now is going towards the robotic and everything, where we are looking at the cone beam and augmented fluoroscopy, I think we still can use whatever available tools, and we can increase our yield based on our own expertise. Like in my center, we are using mostly like Kurimoto's way because I was trained in Japan actually. So our yield are around 75 to 85% based on the various diseases actually. But again, next we are bringing in cone beam very soon, hopefully. But the initial setup in government-based setting is have a significant resources and a significant obstacle in procuring the tools per se. So that would be my view on it actually.
Absolutely, I completely agree with you, Dr. Arvind. Yeah.
What is your it was a very nice presentation, sir, as usual.
Thanks, sir.
So you gave a good overview of the different modalities in diagnosing a PPL. So can you share some knowledge of what are the various therapeutic options that are available in pertaining to peripheral nodules?
Okay, so bronchoscopic therapeutic applications, there are only 3 that are available at this in the market at this point. It started off with the radio frequency, and then there was this microwave, and there is a cryo. I mean, all these are offshoots of what the radiologists already did. So they did a percutaneous radio frequency, they did a percutaneous microwave. Cryo was the only one that went through our thing first. Again, there was they were just doing a microwave and radio frequency, which is already available in a prime time for liver tumors. The radiologist again did a liver tumor, all this is still available. So it's essentially using the same technology. We just have to use different probes and different things. So what is the competition there? Competition obviously is surgery. Surgery is a gold standard. So if you have a patient who have a small lesion, peripheral lesion, we'll have to do a surgery. That would be ideal. And the second alternative is SBRT. I think these were the number 1 and number 2. And SBRT, people were trying to show that it reaches the surgery. There is always a pro and con about the recurrence rates in these two, but it was around 80%. Both of them had 80% chance of a cure, and 20% recurrence due to tumor biology rather than a effect of the malignancy or effect of the technique. So surgery, they were talking about a lobectomy versus a segmentectomy, and for that is how and in all these SBRTs and so on, our role became important as a staging process. The staging has to be very robust. Even if there is a small N1, if you do a primary also, it would actually not clear the thing. So that is how the pulmonologists came into front, and once the radiologists started using, we started using it. So all these are again at the level of stage 1 and stage 2 type of trials, which is not available in real time. The issues are when you use a radio frequency, again, the issues are unless you go to the center of the lesion, you put the sheath in the center and take all around, you will not have a clearing zone. The zone has to be very clear. Now, the problem is in radiology, you will not know what the zone is because everything looks white after this. So you do not know whether you have appropriately covered using either radio frequency or a microwave or a cryo. So you will not know whether you have done a good job because you'll have to wait out and then find out after 6 months whether there's an thing. So those are the things that they're trying to tighten it at this particular point. There is also a heat sink effect. When you use a radio frequency ablation, when you use a radio frequency, when there is a blood vessel, it will absorb all those radio frequency, and so the area beyond that blood vessel is not appropriately handled, and so there is a higher chance of recurrence. That is where microwave became better than the radio frequency. Radiologists can put the catheter straight in the center of the lesion, whereas we have to struggle. So that is the reason why all this breaking the wall and making sure that the sheath goes to the center of the lesions are all important. So if we can handle all these, if we can take care of the sheath going in the center, and if you can assure that the proper dosage is done, then we have some kind of a role to play in people who don't want a surgery and who don't want an SBRT. So there are very strong competitors here, but it is a fascinating field because we are looking at a one-stop shop where the patient comes in, you make a diagnosis using bronchoscopy, peripheral lesion, you do an EBUS staging, all these, the rows we find out in the same thing, and then you use a cryo. It looks fascinating. That would be a future where a patient comes in walking with a peripheral lesion, and we do it at a T1, N0, M0. I mean, of course, the patient comes with a PET, and then you just go in and then deal with this thing after diagnosing in the same setting and finish it off, and the patient walks back home cured of the lung cancer. That sounds a very exciting thing. That's what we're all looking at. Well, let's see how it goes. Yeah.
Thank you, sir.
Any other questions from the audience?
So just slightly deviating from that. So suppose if you have a lower lobe mass lesion and you have a 10R and 10L lymph node. So while doing a staging, does it make sense that you biopsy the 10R and then do the 10L? Is there a better, diagnostic yield by doing that? If there is a lesion on the right side, right lung, and there are bilateral hilar nodes.
Okay.
So what do you, biopsy first?
So the assumption is this is a malignancy.
Assumption is this a malignancy, yes.
Okay, so you're saying which node to go after first?
Yeah. Does it improve the diagnostic yield if I go after the 10R first?
It depends whether you have a rapid on-site. If you have a rapid on-site, you go through the proper staging process. Even if you don't, it makes sense for you to go to the opposite side N3. If you're using the same needle, which I think we will. First thing will be go to the opposite thing, prepare slides, and then keep it separately, and then go to the thing, and then mark it separately as an N3 and an N1. And go after the main mass and then send everything together, and so that you get a diagnosis and staging together. Yeah.
So one last question from my side, sir. What are your personal preferred choice of tools for chasing the peripheral pulmonary nodules at present?
So we try to have a cryo in every case that we go in. So that would be our preferred tool. And again, rest of it depends on 1, 2, or 3. Stage 1, cryo plus everything else. If it's a stage, if it's type 3, we always use a needle and the cryo. Needle is only when there is a 3. Cryo, we'll try to do it in every case. Yeah. And also the most important thing we found out is that just first do a cryo and then start off with others, because when you use other modalities and there is a little bit of blood and then you put in a cryo, it just takes the blood out. Every time you push the pedal, it just comes out. It's just a blood that we are taking out rather than the tissue. So first pass cryo seems to be the biggest chunk and the most important chunk that we have.
Thank you. Thank you so much for the discussions.
Thank you, sir, for taking time out of your busy schedule and coming here to impart knowledge and wisdom that would empower us in our future. I would like to welcome our HOD, sir, to honor Dr. Pattabhiraman, sir. Thank you, sir. Now we'll move on to the inauguration event. I'm elated to invite the chief guest for the inauguration function. I would like to call upon, first let us stand together for the SBV anthem.
Education gives humility. Humility gives character. From character, one gets wealth. From wealth, one gets righteousness. In righteousness, there is joy.
Now, it is indeed my honor to request our HOD, sir, Professor Dr. Palanivel, sir, to deliver the welcome address to the audience.
Very good morning. Respected Dean MGMCRI, Professor Gosher, respected Dean SBV Alumni and Student Affairs, Professor Karthikeyan, our guest of honor, Dr. Pattabhiraman, sir, our special guest, my predecessor and our advisor, Professor Menon, sir, all the resource persons and the chairpersons, the pharma company and the equipments, all the audience online, because this is a hybrid mode, there are many behind the screen. So to participating in this extraordinary academic event, a very warm welcome on behalf of the management of Sri Balaji Vidyapith, MGMCRI, and my department of pulmonary medicine at MGMCRI. So this is basically two mega events together. One, we are setting foot into our interventional pulmonology. We are already started marching towards pulmonary function testing level 3, and we have a good basics in bronchoscopy. I think with the training of our associate professor, Dr. Vimal Raj into IP, we are into the IP field slowly. And the second mega event is that you see all our students are there as faculty and as resource persons. They are, in fact, shining stars in interventional pulmonology. It's beautifully written by Dr. Pattabhiraman in the foreword of that book. I think we should develop conscientious interventional pulmonologists. I believe that our students are to that mark and they do the purpose with ethical background. And we are happy about that. With those things, it's my pleasure again to invite each one of you to this extraordinary event. And this is something which is very new for most of us and something which is frightening. looking at the cost of the equipments, and he said, most of the speakers have highlighted it's very costly, it is very costly. But looking at the benefits and the comforts, and everything is under our own roof. We do not rely on other specialists. I think this is really a challenging and very fascinating field to work with. I think personally, I will have a lot of learning experience from today's conference as well as the workshop which is going to follow. And once again, I welcome all of you for this wonderful workshop. Thank you so much.
Thank you, sir. I would like to call upon our HOD, sir, to honor Dean, sir, Professor Dr. Shitesh Ghose. Now, I would like to call upon our Dean, sir, to facilitate the guest of honor, Dr. Pattabhiraman, sir. Again, I would like to call our Dean, sir, to honor other special guest, Dr. Surendra Menon, sir. Now, I would like to call upon our Associate Professor, Dr. Vimal Raj, sir, to honor Dr. Karthikeyan, sir, Dean, Student and Alumni Affairs. Now, I would like to invite the chief guest for lamp lighting. Life is not about how many breaths you take, but about the moments that take your breath away. Now, let's have a glimpse on the achievements of our Pulmo family in the last 2 decades.
The Department of Pulmonary Medicine or Respiratory Medicine at MGMCRI started a humble beginning as a service department in the year 2001, with a single faculty department headed by the senior chest specialist Dr. Udayraj, followed by Dr. Pajanivel as assistant professor in 2003. The transformation was initiated with the admission of first batch of PG students in 2007 under Pondicherry University, with the taking over of the department by Dr. Surendra Menon. And in 2009, the first batch of PG students under Sri Balaji Vidyapeeth were admitted. The department faculty strength slowly increased to fulfill the complete requirement of NMC or the erstwhile MCI, and there has been a consistent filling up of all the PG seats every year with 100% pass results. This has been possibly by dedicated academic orientation of both the faculty and PG students through a well-drafted academic schedule focusing on the basics as well as on the update in respiratory medicine. The postgraduates are regularly encouraged to participate in co-curricular and extracurricular activities both at the regional and national level. The faculties are regularly participating in professional development activities at the national and international levels. The department also regularly participates in various commemorative days like World TB Day, World COPD Day, etc., as well as in various outreach activities. The department contributed its best to COVID patient care during the pandemic period by administrative and patient care deliverance both within MGMCRI and the local government. ICMR selected this department as only center in the region for clinical trial on India's first indigenous COVID-19 vaccine, Covaxin, and the department was accredited by US FDA as the best vaccine trial center for good clinical practice implementation. The department is the first to set up the functional level 1 sleep lab in the region with the establishment of Christian Gallimanol Center for Sleep Diagnosis and Research in 2019. In 2023, the department upgraded its pulmonary functional lab to level 2 lab with the setup of airway oximetry and pheno instrumentations. Again, the only one of its kind in this region. To saturate the requirements for departmental excellence, we have begun our mission to acquire the complete interventional pulmonology chute today. Through this, we hope to deliver the holistic service for diagnostic, curative, and rehabilitative aspects of pulmonary medicine, so that we offer every patient who walks into the department our motto of breathe free.
As our Vice Chancellor, Professor Nihar Ranjan Biswas sir, could not make it to the occasion in person due to pressing administrative issues, we are happy to play the recorded address of our Honorable Vice Chancellor sir to the gathering.
A very good morning to all of you gathered for this inaugural Interventional Pulmonology Summit. Vanakkam. First of all, on behalf of our beloved Chancellor sir and on my own behalf, I congratulate Professor Dr. Pajanivel and his team for organizing this wonderful event. I would like to express my inability to attend this inauguration function. I am currently out of station due to some official work. Sri Balaji Vidyapeeth has always been in the forefront of healthcare, taking care of the needy in this region for more than 2 decades. Thanks to the consistent support from the visionary Chancellor Sri M.K. Rajagopalan, we have been constantly encouraging new academic, patient care, research initiatives from the departments from time to time. In that way, we will support the department in their attempts to add interventional pulmonology services to their armamentarium. I got to know that this program is a dual event, interventional pulmonary conference plus workshop and also MGMCRI Pulmonology Alumni Meet. More interesting fact is that our alumni form a good proportion of faculty for this event. It is good to know that they also have contributed in the preparation of standard operation procedures for key interventional pulmonology services. In this occasion, I am happy to release that standard operation procedures manual. It is indeed a nice gesture that former head of the department, Professor Dr. K. Surendra Menon, has come for this event after his superannuation 5 years back. Welcome back to SBP, Dr. Menon. I also welcome the experts from Taiwan and Malaysia and other delegates who have joined online. The conference has close to 90 registrations. That is a good number given the fact that the official State Pulmonology Conference is also taking place at the same time. I am sure that with this hybrid mode, more doctors will benefit from that event, both via live streaming and also the Zoom recordings once shared widely. One has a good standing in the academic world if they possess good clinical acumen along with fine procedural skill. Hence, it is the need of the hour to update ourselves constantly to the changing demands of this competitive world. With the constant increase in the number of gadgets to aid in the diagnosis and treatment of patients, conferences and workshops like these are needed to keep ourselves updated the changing winds of time. At the same time, one can never overemphasize the importance of gaining sound clinical knowledge and clinical skill during their formative years. I once again wish the organizers and participants all the very best for a successful IP Summit and alumni event. God bless you all. Nandri, Jai Hind. A very good.
Thank you, sir. Now, I would like to request the guest of honor, Dr. Pattabhiraman sir, and our Dean sir, to release the standard operating procedures in interventional pulmonology by Department of Respiratory Medicine, MGM-CRA.
Basically, this manual is to how to do the various procedures in interventional pulmonology. For any beginner, I think this will be a useful document. So this has been made possible with the efforts of each one of these alumni who are here, who are shining in each of these techniques. And thanks to Dr. Vimal for taking this initiative in compiling this. Thank you so much.
Thank you, sirs. Now, I feel privileged to call upon Dr. Pattabhiraman sir, Consultant Interventional Pulmonologist, Royal Care Hospitals, Coimbatore, to deliver a few words on this special occasion.
Respected Dean, Dr. Karthikeyan, Dr. Menon, is senior professor, my dear friend Parni, and Vimal and friends. It's a great privilege for me to be here. First to give a talk and more importantly now to release a souvenir. I think I read the whole thing through the standard operative procedure. I think as already been alluded to, bronchoscopy, especially in a setting where there is not much of a control over how you're going to do it and what you're going to do, it is a very responsible procedure. This is a very responsible field, and I encourage all of you to be very, very careful in case selection. Very, look at things that are boring. With the most important thing being taking care of the scopes, going through the proper indication, go through the rigmarole of checklisting everything. I think we'll have to have an obsession about the safety. It's quite exciting to do procedures. It's quite exciting to make videos. It's quite exciting to show the world that you've done this or done that. It's exciting to post in the social media. The most important thing is that we're doing all this for the patient who is lying down, who's nowhere in the picture. Make sure that he is the center point. And so his safety becomes paramount. I might sound like a very old-fashioned thing, but I think I can't emphasize it more. The most important thing is the safety of the patient. And for that, you'll need to have a protocol. This is a wonderful document for that. There are also other documents. You'll have to have the guidelines. The Indian guidelines also is available. So I would think this and the Indian guidelines are very important SOP. Those two are, actually they're quite complementary to each other. I congratulate Vimal for this and the whole team of the alumni. My good friend Varun, Tyagesh, and others, Dr. Roshan and the group have done a wonderful document. I'm quite happy to see that I haven't seen much of documents like this coming out, and this is the most important piece in a bronchoscopy. And I'm sure under guidance of Parni, the stalwarts have come, and me and Parnivel are kind of batchmates meaning the same vintage. We belong to the late 90s, early 2000. We've seen the grown world together, how pulmonology has evolved. I took a different path, and Parni took the hard-working and the academician. He's become more meaningful in terms of training a lot of people. I can't congratulate him enough. I hold him very dearly. So I wish this department, which is going to come with the next feather in the cap, which is a complete comprehensive interventional pulmonology thing. I wish them all success, Vimal and team. And I think under able leadership of Parnivel, you'll see a lot of a bright future lies ahead. And I also thank and wish all the alumni of this wonderful institution. Thanks, Parni, for giving me this opportunity. Thank you.
Thank you, sir, for your kind words. I'm much obliged to call upon our respected Dean, Professor Dr. Shritish Ghosh, sir, to address the gathering.
Very good morning to you all. Basically, when the video was playing that journey of the Department of Law, and I was just recapitulating the department. I have seen the department growing from the one-man show to the present, and now it has grown beyond department. Like I can see the alumni here. Yes, it's nice feeling to see the, what you can say, the seed that was implanted long back. Now it has started germinating, not in the form of what you can say, disseminating the knowledge, but also they have started working in the field. So it gives a nice feeling. And in fact, when Bimal went for a training, I was just dreaming for this day only. Yes, one day he will come back and start the department. Yes, that dream come true for the department. And really, there is no dearth of words to leadership of the department by Dr. Surendra Menon previously, and at present Dr. Palni. Like under their guidance, it has grown leaps and bounds, and yes, it will keep on. Privileged one who works under Palni, yes, he is a taskmaster, but during that period, yes, you may feel like, as you know, like a PG period is the training period. Once the more you get grilled, the more you sign. And once you go start working in the field, then only you realize it, the whatever the amount of the grilling was done is for your betterment only. Hope this alumni they will vouch for that. I wish this workshop, I think following this hands-on workshop will be there. Yes, it will be useful, and the gadgets are there to make the patient safe, but again, unless we handle it properly, it can put you into trouble, right? I wish all the best, Palni, for this successful completion, like what you can say, completion of this workshop. Thank you. All the best.
Thank you, sir. I'm elated to call upon Professor Dr. Karthikeyan, sir, Dean, Student and Alumni Affairs, SBB, and HOD of ENT MGM CRA to say a few words.
Respected Dean Professor Sitesh Kose, Professor Palnivel, HOD Respiratory Medicine, Surendra Menon sir, former HOD, Dr. Pattabhiraman sir, and delegates and my dear PGs. So very good morning to you all. With the immense glee and fervor in my heart, I'll wholeheartedly welcome you all for this MGMCRI Pulmonary Summit 2023 and Pulmonary Alumni Meet. Education gives humility. From humility, one attains character. From character, one acquires wealth. From wealth, one gets righteousness. And from righteousness, one gets happiness. This beautiful quote I have taken from SBB anthem. It's originally comes from the Sanskrit. And it says that education gives happiness. So I could see the happiness in all of you, the alumni, which comes from various parts of the India and other country also. And happy to see you all here on this Pulmonary Summit and Pulmonary Alumni Meet. You all wonder why I'm here. Since I'm the Dean Student and Alumni Affairs, this combined with alumni and the educational feast, that's why I'm here. And the word alumni is derived from the Latin word aller, which translates to nourish. SBV, the deemed to be university, and iconic Mahatma Gandhi Medical College have been your alma mater. The very place where you have forged your knowledge, honed your skills, and imbibed your virtues. It has literally nourished your academic quench and pivoted you all to become prestigious members of medical fraternity. The alumni gathered here today are surely filled with feeling of pride and accomplishment while they revisit down the memory lane. SBV binds us all in one imperishable bond, the one big family. The core qualities of ethics, integrity, and morality have been inculcated in all of its proud peoples. Wherever we stand in our career path, whatever we have achieved in our respective fields, how much ever, God willing, we shall achieve in your future, we owe it deeply and assuredly to respected teachers and our luminous institution. While this alumni meet might stir up feeling of nostalgia, but it will surely bring back 100 memories, thousands of laughs, and so many more moments of cherishment here. So let us rejoice, reacquaint, remember, relate, and relish these beautiful times. Once again, I welcome you all for this Pulmonary Summit, along with the academic meet, along with the Pulmonary Alumni Meet. Thank you all. Let the well-being prevail.
Thank you, Dr. Karthikeyan. As you welcomed our alumni, there is another alumni of us, Dr. Kaushik Reddy. If you can show his face, he's joining us from Italy. Yeah, he's there. So, welcome, Dr. Kaushik. Yeah. Yeah. You can say hi to us by unmuting.
Thank you, sir. Thank you for this opportunity.
Thank you. Thank you. It's a pleasure to meet you.
Thank you, sir.
Thank you, sir. Now I feel much privileged to welcome Professor Dr. Surendra Menon, sir, our former HOD, Department of Respiratory Medicine, MGM CRA, to share a few words.
Good morning. Sorry to take a few moments, because it takes some time walking up the steps. Actually, I get excited and emotionally disturbed because whenever I speak, come to the dais of any dais in MGM CRI, I get emotionally rather carried over because first time I was called for a capsule talk after joining this college. I gave a capsule talk on palliative care, and after a couple of years, I gave an internal oration on XDR-TB. That time, XDR-TB was just coming to the picture. That time, I predicted TDR-TB is the next one to go about. And I think it's happening around. Now, I am proud to be a part of the Department of Pulmonary Medicine from 2006 to 2018. The department had name got a metamorphosis from, as Dr. Palnivel said, TB-CD first, followed by respiratory medicine, and finally Department of Pulmonary Medicine and Critical Care. And now with all the modern sophisticated methods, I know I have to add something else. From 2008, the department grew in stature with the admission of PG students, 1 DTCD and 1 MD. With that, the growth of the department was phenomenal. The department has a fine record of PG teaching and outcome with the innovative teaching, and we'll see the teaching sitting examples over there. And they've become faculty also. I'm so proud of them, actually. I am sure at present with Professor Palnivel's effort with department has become self-sufficient with all the modern gadgets, which is happening and going to happen also for the diagnosis and treatment. The department faced tough time with frequent inspections by MCI, now NMC, and inspection by NAC and NABH. Fortunately, Professor Palnivel was the NAC coordinator, so NAC inspection went rather smoothly, so was NABH. I am sure with perfect guidance from Professor Palnivel and his team, the department will reach the zenith by Silver Jubilee year. My best wishes to the leader with a vision. My best wishes to a leader with a vision and his team to bring accolades to the department in future. It is my pleasure to present a check of rupees 25,000 towards the department corpus fund. I request Professor Palnivel to kindly accept the check. Thank you.
You are more a treasure for us. Your advisors are more a treasure for us rather than anything. But I don't want to disappoint you, sir. I will accept this, but you are more a treasure to us. Thank you.
Thank you, sir. Now I humbly request our beloved Associate Professor, Dr. Vimal Raj, sir, to deliver the vote of thanks.
Thank you. At the outset, I thank our beloved chief patrons, Shri M.K. Rajagopalan sir and Dr. M. Prashant Rajagopalan sir, and our patrons, Vice Chancellor Professor Niharanjan Biswas, Dean of Faculty A.K. sir, Dean MGMCRE Sitesh Go sir, Director Hospitals and Outreach Services Nirmal Kumar sir, Dean Academics A.K. sir, A.K. Das sir, and Dean Student and Alumni Affairs Karthikeyan sir, and our beloved former HOD Surendra Menon sir. And a special thanks to our guest of honor, Professor Dr. Pattabhiraman sir, for coming here and delivering a wonderful talk along with his insightful forward in our SOP. And I thank Director Nirmal Kumar sir and GM Admin Asha ma'am for their financial and logistic support, which was first of its kind for inaugural IP summit and other events in under SBV. And I especially thank our workshop partners, Fujifilm, Dumont, Richard Wolf, Roby, and Olympus for their support. And I thank our sponsors, CIPLA under 2 divisions, COPD and Cresta, Christine Pearl, Sun Pharma, Solaris Division, and Force India for their consistent support. I thank our biomedical team, I thank our housekeeping, I thank our chief librarian who had given us a hall. I thank our Asha ma'am in particular, where the admissions are still going on. They should switch over to the college building for 1 day so that we can have this hall today. And all the support staff of our SBV, MGMCRI, so that we can have this event smoothly. Last but not the least, I thank all the delegates, both online and offline, who have joined in, and all those who will be benefited when this, those who could not join today, so that we can disseminate the information, this videos in the future. Thank you one and all. Have a happy learning.
Thank you, sir. Now let's have a short break for 15 minutes and gather back again.
That along with the Dean, Alumni Affairs and Student Affairs, the department with the alumni should take a group photograph. Maybe I
Yeah, this one. We should always see this final.
I would like to call upon our alumni, Dr. Varun sir, to introduce the panelists for the upcoming panel discussion.
Very good morning to one and all. I'm Dr. Varun. So thank you, Vimal sir, for giving me this opportunity to moderate the session on management of central airway obstruction, rigid versus flexible. It's my privilege to call upon Dr. Pattabhiraman sir, Dr. Ilamaran sir, Dr. Roshan, Dr. Tyagesh to be the panelists for the session. And we also have Dr. Shinyan Tu, Dr. Shia Hang Shen, Dr. Arvindran Alaga sir from Malaysia, Dr. Kaushik Reddy. So they are all online via Zoom to be panelists in the session. Are they all connected? I think Dr. Kaushik Reddy is there online.
Yes, sir. Yes, sir.
Yeah, similarly, Dr. Arvindran Alaga, sir, you're available online?
Yeah, I'm here. Can you hear me?
Thank you so much. Yeah.
Since we are slightly behind the schedule, due to other commitments, Dr. Shin and Dr. Shia is not available at the moment. So, am I audible, sir? Arvindan, sir?
Yeah, audible.
Yeah. So, welcome you all again. So, basically, today's session is about the management of central airway obstruction, rigid versus flexible. So, to begin with, so let us go into the basics of what is a central airway for the understanding of the postgraduates. So any the major airways, there is trachea, right main, left main bronchus, and the bronchus intermedius is called as a central airway. And on a bronchoscopist point of view, whatever you're able to see with an adult bronchoscope is called as a central airway. So can I ask Dr. Roshan, what are the common symptoms when we have a central airway obstruction? So what are the symptoms that will differentiate from a patient having some other pathology with a central airway obstruction?
So looking at the central airway, the most common symptoms of acute presentation would be a dyspneic cough. Only less number of patients, I think, they are asymptomatic. Otherwise, they usually present a dyspnea, cough, stridor. Less common is hemoptysis.
Okay. So when a patient presents with stridor, you think of a central airway obstruction.
Yeah, one of the differential we have to keep in the mind as a central airway obstruction.
So clinically, when you're suspecting a patient with central airway obstruction, the first modality you do is to get a CT scan done. So that will give you a fair idea of what we are dealing with. So it will tell you if there is a stenosis or something, it will tell you the length of the stenosis, how the distal airway is, whether it is patent or not, whether if there is a collapse or how is there a viable lung beyond the point of stenosis. So all these parameters we'll be able to get from the CT scan. And when you are seeing such patient, so how will you proceed? So the first thing is, directly do you plan for a therapeutic intervention, or whether would you do a diagnostic bronchoscopy? Dr. Tyagesh, please.
Sir, performing a pre-bronchoscopy has its own advantage and disadvantages actually currently. So when we see the luminal patencies more than 60 or 70% uploaded in the CT scan, what I usually do is I don't do a pre-bronchoscopy, and most of the cases will be coming to ER with an tachypnea and tachycardia. So we may be taking the patient as an emergency procedure. But when adequate luminal patency is there in CT, we'll consider doing a pre-bronchoscopic evaluation. But we can do a pre-bronchoscopic evaluation in even in the sick patients. But when we have an adequate setup of rigid intubation and our anesthetist and all the equipments available with us, actually.
Okay, so once you do a check bronchoscopy, so at that point of time, we'll not be sure of what we are going to deal with. So if you're doing a diagnostic bronchoscopy, so what are the things that you will be looking at? What are the decision-making points that you should check when you're doing a diagnostic bronchoscopy? Can I have your input, sir?
Yeah, so in a diagnostic bronchoscopy, we're looking for a diagnosis, and B, I mean, a patient comes with a set symptoms, so we just have to see whether whether we have a diagnosis made, and also whether there is an appropriateness between the patient's presentation and things. So if the patient is unduly breathless and you have a tumor, you first make a diagnosis, and then you'll have to go back to the CT. If the CT previously was a non-contrast, you'll have to look at seeing whether we'll need to do a contrast CT and so on. If you're planning to do a therapeutic thing, then a diagnostic bronchoscopy will help you in assessing the extent of the problem and surrounding areas, and then make sure that you are prepared for the therapeutic aspect. So you might have a PET CT, or you might have to see whether there is a viability beyond the extent. So you'll have to there will be you'll have to go back to the CT, and then we'll have to discuss. So we would preferably do a diagnostic bronchoscopy, make a biopsy, ensure that the diagnosis is certain, and then we'll have to go for the subsequent thing. So we plan for a further procedure on the diagnostic bronchoscopy.
So how safe is it to perform a diagnostic bronchoscopy in a patient with central airway obstruction? In other words, like, what are the potential complications you can anticipate in a patient who is already having an obstruction and you're doing a diagnostic procedure?
Okay, so everything is, I mean, as far as central airway obstruction is concerned, there has to be, loss of airway, hypoxemia, and the patient can have a bleed, and that bleed can be a thing. So you're looking at a patient with a very, very poor or a narrow therapeutic, narrow risk margin. So you'll have to be very prepared. So if the patient has a significant, patient comes with a stridor, there is no question. You'll have to ensure that the patient continues to breathe through the procedure. And for that, you'll have to ensure that proper airway is ensured. You'll have to have a backup. You'll have to have an anesthetist. You'll have to have a consenting process, which will be quite elaborate. So any patient you're doing a procedure, when the patient has a stridor, there has to be a high risk consent involved. And second thing is the bleed. Already narrow airway can get worse. And so loss of airway and the bleeding are the two important things, is resulting in a hypoxemia and a very poor consequence. So the things that I'll be worried about will be the bleeding and a patient not able to breathe post procedure. So those are the things that needs to go on a consent form. Those are things that you'll have to be careful about. Those are the things that if you are not able to do it, never attempt to do a bronchoscopy. If you don't have a wherewithal or if you don't have a setup to manage either a bleed or a ventilatory process subsequently.
As you rightly said, sir, there can be potential complications of further compromising the airways when we are trying to do a diagnostic bronchoscopy on deciding on what has to be done. But supposedly, if the patient suddenly collapses, in the sense like due to any of the complications, what we accept, say, for example, bleeding or any mucosal edema. So, and if you're not well equipped, so what are the things that you can do in case of a
Okay, so you'll have to ensure that there is some kind of a conduit to ensure the patient is oxygenated. Hypoxemia kills a patient, and nothing much actually kills a patient at that particular point. Of course, there are other things like if the patient has a cardiac issue and can develop an MI, those things apart. Procedure-wise, hypoxemia can kill the patient. Make sure that oxygen goes in. So whatever way you can ensure that there is some kind of oxygenation that can happen, it can differ in different things. So you'll have to ensure that there has to be a conduit available. Either it can be an endotracheal tube or a rigid bronchoscopy or whatever. If you have a personnel who can handle that conduit, that is the most important.
Yes. So you can also plan for a tracheostomy if it is subglottic. I mean, if you're not well backed up.
Yeah. So if ability to do a tracheostomy would be, transtracheal things, so whatever. So that's essentially the point being, if you can shove some catheter inside which can oxygenate distal to whatever is a problem. Those are the things that you'll have to ensure.
Maybe that point of time, MLS tube also can help. And
MLS tube can help if it's a proximal, very proximal thing. MLS tube can help, or just simply pushing a catheter alongside, or of course, through the bronchoscope, whatever. You'll have to think on your feet at that particular point. Things can be very different. Ensure that oxygen reaches distal airway. Those are that is the most important thing. So if you're working, let's classify it simply. If there is if you're working on a bronchus, one bronchus and the other, ventilation, the patient cannot die of hypoxemia if you can handle it. Only way the problem happens is there is a bleed from this side, which can go that side. In which case, you'll have to have a balloon. So a Fogarty balloon should be an integral part of any bronchoscopy sort. So if you do working on one side of the airway and you do something and the patient has a bleed, which can be massive, it can also go to the other side, in which case you'll have to make sure that you're isolating the lung. So in a bronchial thing, isolation is easier because you can pass a balloon and then block that whole lung, shut it, and the patient continues to breathe so that you can have a thing. Whereas if you're working on the major airway, which is either in the proximal part or even the mid or a distal trachea, that is when you can't have a balloon to work on it. You'll have to have a conduit or a catheter through which you can give oxygen, ensure that the patient lives till the patient goes to the ICU or a definitive procedure, either through radiology or whatever it is. So that is the distinction that you'll have to have. If it is a bronchial area or a tracheal area, tracheal is more critical. You'll have to ensure that you can intubate the patient fast. If you can't intubate, you'll have to actually do, whatever, MLS tube or whatever, just ensure that there is some catheter that going in and ensure that there is a thing. A very important thing for a postgraduate or for someone who's beginning, make some trial runs. We did that in our bronch suite. Do trial runs, it's easy. Get the preparedness of your suit. Your people have to know that what to do at that particular point. Call the anesthetist immediately. Get the balloon initially, and things that needs to be in the thing. Emergency cart. All these are important things to save the lives
there. So Arvindran sir.
Yeah.
Would you like to add some points to what sir has told?
Yeah, I think I agree with Dr. Patabi, sir. What is important here when we are dealing with central airway obstruction is how prepared we are actually. And rather than we alone as a pulmonologist or interventional pulmonologist, we have to prepare our team. So the first thing is we have to educate our team members what is necessary thing and what is the steps if anything happens. So how to secure the bleeding. So what necessary items. So when I'm handling with any central airway obstruction or suspected central airway obstruction in my bronchoscopy suite, I make sure I have a cryo, I have a APC. I make sure my emergency trolley are equipped with the ETT various size. And now I even equip my center with high flow nasal cannula technically, and also I have an NIV within my suite as well. So that, sometimes like my center per se, my anesthesia is a bit far away from my, my interventional suite. So I will start institute all the high flow nasal cannula and NIV by myself if needed. Then we can refer to our colleagues. So that's supposed to be the preparedness we have to have. And then again, over the time, I think we learn from our experiences and we will try to equip ourselves with more like, balloon and all the catheters, whatever we needed. And I also do agree that I prefer, if let's say it's not tracheal, if let's say it's involving a RMB or LMB, I prefer to have a pathology first. I mean, I would like to take a biopsy and I have to have a HPE first before I go and debulk or the tumor or anything like that. So that I need to know the pathology first. And I think some of you know that I always try to instill alcohol in the mass before my rigid bronchoscope for the certain vascular tumors. So when I do the diagnostic bronchoscope and at the same setting, after I take the sufficient biopsy, I'll try to instill the alcohol within the tumor so that from our experiences, we yet to publish the case, we are collecting the case series now. So when we go bronchoscope, rigid bronchoscope, after 2 days later, we noticed that the luminal patency increased technically, and the field became less less bleeding and easy for us to debug. But again, it's I think choice of us to choose which modality we want to use first before we debug it.
Okay, sir. So if we have a patient with a central airway obstruction, probable malignancy, and who is a stable patient, so will you do the therapeutic intervention in the same sitting, or do you wait for the biopsy reports to come, or how do you deal? So do you get a frozen section?
If a tracheal mean, I would go for both therapeutic and diagnostic at the same setting. But if RMB or LMB, I would take the biopsy and I will get my HP within a day or two so that I can plan within the next 48 hours or within 24 hours. I will see the patient's conditions first. But again, my pathologist usually get back to me within 24 hours to 48 hours for urgent cases. So we can plan our urgent, rigid bronchoscope accordingly.
Okay. So as the management protocol differs based on the type of lesion, whether it is extrinsic, intrinsic, or mixed.
And also condition of the patients actually.
Okay. So may I ask Kaushik to give an overview of what are the different types of lesion one can expect when you're dealing with the central airway? And can you give briefly, like if it is an intrinsic, how do you manage, or extrinsic, how do you manage? Can you give an overview of how things are done?
Yes, sir. Thank you. So when it's intrinsic or extrinsic, once we see the bronchoscopy picture, we'll know whether if it's intrinsic tumor or if it's a CT is done previously, obviously, then we'll know it whether it's extrinsic compression or anything. When it's an intrinsic tumor, we can actually see the area that the trachea, which part of the trachea it is in, or if it's in main bronchi. Then if it is in main trachea, we know the area, upper or middle or lower trachea. Then we can see if we can snare or debulk the tumor. Then put, if it's an intrinsic tumor, then we can put SEMS, deploy SEMS, so that we can have the patency of the airway for the patient. Or then that's the thing we can do. Otherwise, if it is in main bronchi, yes, if it is, then we can debulk the patient, then give a patency of the airway, because if it is in main bronchi, because of the other lung, it's ventilating, so not much of the catastrophic things will happen. So if it bleeds more, yes, that can we can give some management to the patient.
So, okay. So in general, if anything that is intrinsic, you can do a debulking and maintain the airway patency. If it is extrinsic, you depending upon the etiology, you place an airway stent. So Roshan, can you tell me what are the different debulking? I mean, what are the different ways of doing a debulking? What are the different techniques that are available?
So basically, we have an hot and cold technique. Hot technique is more involved of electrocortical surgery, APC, and cold is more of an cryobiopsy. Okay, and even hot we have a laser technique. So they do a combination of modality available to do a debulking. Okay, that includes electrocortical snare, then do it with cryo. Some do with a coring with a rigid bronchoscope also. So it's not a single method that we do a debulking. It involves some multiple modality that involves doing a debulking.
Yeah. So since our Taiwan colleagues are not there, so may I ask Vimal sir, like I heard from you that they are all doing all the procedures under a flexible bronchoscopy. So I was just wondering how like they're technically able to do a debulking through a flexible bronchoscopy. How do they do, sir? Even if they're doing a snaring and taking the tissue out, how do they take it out? Or if they're using a cryo, how do they pull the lesion out? So,
basically, faculty at Taiwan, they are trained in both rigid and flexible. They are trained in NCC for flexible, and they are trained in Shanghai Chest Hospital for rigid. Unfortunately, though this is a very big center and it is a referral center, and they have a 27 faculty department with 3 HDUs with more than 50 beds in each HDU with for long-term patients, and 2 dedicated ICUs for respiratory medicine, and 2 separate dedicated bronchoscopy suites. Unfortunately, they don't have a proper anesthesiology backup for doing intervention procedures. That's why they were forced to tailor-made procedures based upon the available things. So that's how they started. Though at present, SAR is planning to start build a hybrid OR, incorporating all the rigid armamentarium that we have here for all rigid and central area obstruction and other things. They have all their publications in the reputed journals in chest or AJRCCM, where they have, and they don't have fluoroscopy also, sir, for radial and also for central airway stenting also. They just mark the stents in that outside with a marker, and first they, with respect to stent, first they pass the thing catheter, and they remove and then pass the catheter, and then they one with the oral and the scope in nose, or the dilator stent in the nose and the scope in the oral they do, and they just see with the distal end, they just see the position of the stents, the distal end, and then they fix it. They don't have the option of doing Y stents, unfortunately. Everything is under insurance in Taiwan. So up to 3 SEMs are given through the national insurance in Taiwan. So they use SEMs for stenting. They don't have silicone for obvious reasons. And so even if a patient is poor or rich, that doesn't matter. If the patient have come crashing to the casualty when we are doing bronchoscopy, and then they just take them and assess if there is a need for stenting, they debulk and they do stent at the same time. If there is a need for Y stent, again for that also they adjust it if possible. If it is just proximal to the carina, in the danger zone where Y stent is the ideal way, they debulk it and they just put 2 stents overlapping and just they manage with the stents.
So do they do it under general anesthesia or
no anesthetist? Only twice in my 6 months of posting there, anesthesia faculty have come there for GA. That again for a simple ball, because the patient is an affordable patient, they don't want any disturbance or any difficulty. So they came with their entire cart and with Tiva, everything for lavage in upper lobe, and on any other day, everything will be by the team. But not one faculty will be there. The HOD is there, the entire team will be there. At least 4 or 5 people will be there finishing their rounds, and they will come there and they will be there observing, assisting with both radial or linear EBUS. And cryo, everything, they just take it in toto, go in come out in toto.
So that will be done through the oral airway? Or?
Yeah. Okay. Oral. They have 2 dedicated oxygen ports and 2 dedicated suction ports for one thing for other side. So oral section will be there again, and one section for the bronchoscope.
So in general, if you're doing a debulking, you expect a bleed over there. And when you're debulking it, and then again you find difficulty in going inside, again you'll have to intubate and go into the vocal cords. It might be really challenging for them to do a debulking with a flexible bronchoscope, especially with only sedation is what I expect. What is your take on it, sir?
Yeah, please.
Okay, so that's interesting because I mean, if you're looking at a debulking, yeah, the multiple attempts. But one thing is, I mean, they have a lot more tolerant patients than we do. I mean, my personal opinion that I mean, when they did an EBUS in Japan was also in 2008 when we went there. So the patients will be on conscious sedation, but they'll be lying quiet and they're very, very, I don't know, there is some other cultural interplay here because it's quite different. And Yasufuku was there, Professor Yasufuku was there till August 2008, and then he moved to Canada, Toronto now. So the next time we met, he said the sedation that I gave for our patients back in Japan doesn't seem to work in other parts of the world, is what he says. So there's some other difference. I mean, that is one thing, but that's by the way. But again, for a massive debulking where in a vascular tumor, I would feel better if there is a conduit. Now, the conduit can be an endotracheal tube or a rigid bronchoscopy. See, that clearly exemplifies how a local influence, local factors influence the practice. So you'll have to find out if there's no right or wrong answers here. As long as there is a tumor that comes out and the patient goes home safely, is the bottom line. So you'll have to evolve with what is available with your thing. And I'm sure our friends from Taiwan will be happy if there are anesthetists. They'll be happy to put in a rigid tube, but it's because of the compulsions they're doing it. If there is a possibility, if there is an availability of an anesthesiologist, I would encourage everyone to use their services. We use them even for a regular bronchoscopic biopsies, excepting for BALs or check bronchoscopies. For everything else, we would look for and we will have anesthetists in our thing. The reason is the idea of doing a procedure is to get a diagnosis or make the patient better, not to prove a point. So if it is helped by having an anesthetist around, and especially in a nuanced case where you do a radial probe of a 2 centimeter, we would just want to concentrate on that nodule and your accessories rather than what is happening otherwise to the patient. So if you can leave that to other trained people, I think it will be a very useful thing. Even for a diagnostic procedure, if that would be the case, for a therapeutic procedure where you are completely focused on the tumor and its bleed, we wouldn't want to have anything else in our mind. So I personally would think that anesthetist is mandatory, and having a conduit is a very, very useful thing, because the number of times you'll have to go in and come out would be a thing. One thing, of course, would be they have lasers. Laser is different if, it's a better weapon for mass destruction. So that way they can kind of either vaporize it or, make it, devitalize it and take it in a piecemeal rather than our thing of a cryo and yank it in piece by piece. So that is one thing. Very important thing is a non-intubated patient is a tumor where you apply your snare. So you can get rid of this tumor from the wall, but getting the tumor out of the airway is a different challenge in a patient who is non-intubated. We've had disasters earlier in our life where right main bronchus tumor goes into the left main bronchus and patient coughs and a lot of things happen. So the art is, removing it. If you assume that a patient is in a light conscious sedation, a tumor is there, you debulk or you snare it out, it stays there the way the patient shouldn't cough. And there will be a time taken for you to put the cryo in and then remove it. Cryo, I would assume, will be the most important or the optimal way. You can't, have it loosely dangling and then falling off in between. So putting a cryo in, taking it in toto and the patient remaining quiet, again, probably it will work in their setting. I would be extremely doubtful if you can. Yeah, thanks.
I think I agree with Dr. Patabi. So, I mean, in Malaysia, I would say that I reserve debulking and stenting purely under rigid bronchoscope. I mean, any type of stenting, even SEMS as well as a silicone, I prefer to do it under rigid bronchoscope because you should be ready to handle any complication if it happens, and you should be able to remove the stent if needed, and you should be able to do any other techniques when you need to have the conduit for your patient safety per se. So any tumor debulking and stenting is purely under rigid bronchoscope, under anesthetic backup, technically in our center. Just that for biopsy or we have done a removal of small tumors under conscious sedation. Yes, we have done. But again, you know, when it's angry looking, a large tumor, polypoidal, I think better not to risk the airway actually.
Yeah, so when it comes to debulking, it should be the comfort of the operator as well as the patient. So it is always better to, in my personal opinion, it's better to have a rigid bronch there. And if we look at the simple, like in the sense like post-intubation tracheal stenosis, if it is a simple web-like stenosis, so how do you manage that patient, Tyagesh?
When we have a PITS case like post-intubation tracheal stenosis, and if it's a very simple stenosis, just putting a nick with an electrocautery over the fibrous tissue and dilating with a CRE balloon will be my first option. And I don't go for stenting for a post-intubation stenosis. Most of them I'll try to avoid stenting the patients. So once if the patient again, if he develops some restenosis, then I think up to 2 attempts we can take to open up with the CRE balloon dilatations. If he developed a third time of stenosis, at that time maybe I'll consider going for a silicone stenting. But mostly it will be with electrocautery and CRE balloon dilatation will be done.
Okay. So since it's a simpler thing, balloon dilatation can be done under IV sedation also. But the question is like how long the patient can tolerate apnea when we are doing this thing, balloon dilatation. So
In
how
our
long
center,
do they do, sir, generally? How long do they dilate using the CRE balloon? How long will the patient tolerate the apnea when the balloon is being inflated? No, generally, if you're doing it under general anesthesia, we do it for 40 to 50 seconds, and then we deflate it. So
once we dilate, we keep it for 40 to 50 seconds.
Yes, and
they keep it only for 10 seconds, sir.
Fine. So is there any other option wherein you can, instead of balloon, there is something called as tracheolator. So whether that can be used, sir, Aravindran, sir?
Yeah, I think we use a tracheolator in our setting. I mean, because tracheolator is a device where, I mean, I notice it's quite useful because it's a non-obstructive way of balloon dilatation where it has a 6 to 8 pillars where when you dilate, each pillars became a support to each other and it's dilated and you can ventilate through the opening. So it can be used in even conscious sedation, and when we use it even for rigid bronchoscope because it can help the jet ventilation to be passed on very well. That's another option, but just that this tracheolator is a bit in Malaysia. It's a pricey strictly. I mean, we are talking about 1,000 Malaysian ringgit technically. But again, I've noticed it's very useful, especially in this simple tracheal stenosis. We can do it under rigid or flexible bronchoscope. But again, if I would like to highlight, there's a study done by our Chinese colleague actually. So they've compared the prolonged CRE dilatation together with the short, ultra short. I think they are talking about 20 seconds with the intermittent of 5 to 10 seconds, then dilate again for 20 seconds. They noticed that outcome is almost good, equal or non-inferior to the other method where we have to dilate up to 40 to 50 seconds as well. So I think they published the paper somewhere in 2018. So in certain cases, I think even we can use the 20-second dilatation times 3 for this kind of cases if needed.
Okay, so when it comes to the benign causes of central airway obstruction, most often it's the surgery that is going to be a definitive option. In cases of post-intubation tracheal stenosis, so what is your criteria for taking up for surgery?
Actually, when we decide about surgical role of tracheal stenosis, the luminal diameter I generally take it as less than 7 mm. When it goes for less than 7 mm, it is more than 1.5 centimeters. I generally take the patient and directly to surgical role. We don't generally see that basically because of reason it is a cicatrized lesion, which is probably going to be circumferential rather than the stenosis going to be an eccentric one, probably a bed which you all tell. But when it goes to be a post-intubation or especially the subglottic stenosis, which is generally going to be a cicatrized one, which is circumferential. So when it is more than less than 7 mm and it's more than 1.5, that means it involves 2 rings, then generally we take up for a surgical rule. And tracheal resection, if you leave first 2 rings and you do the anastomosis, you get a beautiful result. So always when the first 2 rings are there and you go in and do the resection, definitely the patient is going to do better. After hearing all these intervention things now, I have a doubt because when I was with Professor Agustin in Singapore, who is probably my mentor for thoracic, so he usually tells when you see a tumor in trachea, don't do anything in trachea. You just do a biopsy. Make sure that it is, if it is not amenable to surgery, then you do what all therapeutics you do. Because his point is that when you do interventions wherein a surgical role has a better outcome, he says that you should be genuine in seeing that. So because when I was there, we did a tracheal. So what happened is, he did a biopsy of it and he stented it. So he get upset and he said, because what happened is when we went in, because it's an carcinoma, and he said, if you leave 1 or 2 mm of clearance, this tumor is going to be a beautiful curative resection. Because he has stented it 4 centimeters on either side. So he said, no, I don't have an option of a resection and anastomosis of this patient. And no other option, this patient is going to have a palliative role rather than a curative role. So that's why, because when I'm hearing this now intervention is coming in a big way, but my thought from him was that whenever I see a tracheal tumor, which is not causing any major bleed or a stridor, I think better we have a histopath, then we better go and do a therapeutic role rather than directly proceeding on to diagnostic and therapeutic on the same setting. That will be my take on. And tracheal resections, if at all done in a better way, I think it has a beautiful result. But what is it, like what experience now say that the morbidity and mortality of tracheal resections are coming down actually, especially with because after I've been to Shanghai and with Agustin, I've noticed that they use a prophylactic silicone T-tubes if they do a subglottic. So if they do that, then results are better actually. So tracheal resections, if it is less than 7 mm and 1.5 centimeter, I generally now go for surgical role rather than any other intervention. Sir, your take on what I have told.
Okay, points taken. So the issues are the following. I have a major problem in radiologists trying to stent. So that is the, by the way. The thing is, silicone stents do not affect the airway. So if you have to do a stenting in a doubtful thing, silicone stent has a very minimal effect on the mucosa, so it doesn't interfere with the surgical role. So that's one thing. Second thing is, stent is a poor choice for any mucoepidermoid or adenoid cystic carcinoma. If at all you have to do. So there are few things. One is mucoepidermoid and adenoid cystic carcinoma are surgical diseases. Carcinoma, for most of it, is a surgical disease. I would stick my neck out and say that post-intubation tracheal stenosis is a surgical disease. If a surgeon, the problem is getting a competent surgeon who can actually do the job. There are very few and far in between this vast country. So those are the issues that we face in this thing. If the first ring is if it's less than 1 centimeter from the cartilage and all, those are the cases which come with the stridor. At that point, if it happens to come to an emergency, we'll have to handle that, open it up and maybe keep it open. And then, so the guidelines for a post-intubation tracheal stenosis is the following. So if you divide it into simple and complex based on whether the cartilage is involved or not. If the cartilage is not involved, it's just a membrane, as Tyagaj said, just give cuts and either balloon it or use incremental use of rigid bronchoscopes, open it up and see if it keeps happening, then leave a stent, remove it in 18 months time, and then in all probability, they'll be all right. So you'll have to remove the stent. That is the most important. And the timing is 1 year to 1.5 years. That is what the data shows. happens if it is a complex stenosis? Complex stenosis is when the cartilage is involved, which means the support structure is gone. So the patient, you dilate it dilates, and you leave it, it just collapses again. And so those cases, you'll have to either remove that area or stabilize that area. Remove that area being the most important thing. Like a surgeon, if you can be very clear, and if it is less than 3 or 4 or 5 centimeters. Now they say that up to 1/3 of the trachea can be removed if you do appropriate releases in hyoid and in hilar release and all that. But again, there are very few surgeons. So if a surgeon is competent, and if the length is amenable, and if it is below the vocal cord, I think the first thing you'll have to do after your emergency management is to hand it over to surgeon. If you cannot do that, leave a stent, remove it at the end of 18 months. 30% of them will not need it. 70% of them will need either a restenting. At that point, you say, think of a surgery and then send them. So that seems to be the guidelines in the European thing also. If the surgeon is there and if there is a amenable thing, do it. There is a 2 to 5% chance of restenosis post-surgical. That is available in the literature based on the paper you read. There again, it becomes your baby. And at that point, you'll have to have a stent, and that goes on for a long time. So all these things in this situation, when there is a complex stenosis, you'll have to use a silicone stent, not a metal stent. Metal stent is when the patient lives for 6 months or less. Otherwise, the stent will cause more problems. So that is the guideline as far as the metal stent is concerned. And I would agree with Dr. Arvind that even if you have to put, if you can put a metal stent without any conduit, I would prefer a rigid bronchoscopy. For removal of all the stents, metal or otherwise, you'll have to have a rigid bronchoscopy anyways.
Arvindran sir, would you like to add something to this?
I think the tracheal stenosis post-intubation, I think as correctly pointed out, we have to discuss with our thoracic surgeon. But again, the availability of surgeon is the issue, even in Malaysia. I mean, the coverage and then the priority, because we have to depend on cardiothoracic surgeons rather than thoracic surgeon per se. So obviously, when cardiothoracic surgeons are there, cardiology cases became a priority rather than thoracic surgery. In our part of the world, it became a kind of secondary cases actually. So that's where we are forced to go in at the first, and then we refer to our cardiothoracic surgery as well. But again, if let's say it's a dedicated team within the center available, surgeons are available, I think definitely we need to have a multidisciplinary team discussion. Then based on that, obviously, if let's say we come to a consensus whether we want to go and release it first or we refer to our surgical colleagues, that will be my choice actually. But again, as I mentioned, I think from last 3 years, from our records in our center shows that they've handled only around 12 cases, despite there's many cases we have been, intubated during COVID. The cases were referred to us actually around only 12 plus actually. If you notice, quite a number of cases are being referred to ENT surgeons because ENT surgeons handle the subglottic stenosis and everything here. Some of the cases have been taken over by our cardiothoracic surgery as well, based on the complexity. So again, the proportion and patient being referred to is totally depend on the services being practiced in your center, I would say. But again, emergency cases, if they refer to you, I will go and try to release it. Then we'll refer in our discuss in our MDT cases and refer to our cardiothoracic surgery.
Yeah. So thank you for the point.
Sir, can I have a question?
Yeah, please.
Sir, I would like to ask Aravind Nalagan sir and Pattabhiraman sir. So, what is your take on application of mitomycin C in post-dilatation, or the installation of triamcinolone injections on the stenotic segments? What's your take on it, sir?
Hey, Dr. Pattabi first, I think.
We do it, it doesn't work.
I mean, I practice it as well. I think for the first initial few cases, I practice it applying my mitomycin C. But again, I noticed actually it doesn't work as well. So I try to phase it out. But in certain cases, I've experienced giving the triamcinolone. But again, I think if the outcome, I don't have a data on from my center per se, but I noticed my ENT colleague loves triamcinolone actually. They try to give for all the subglottic stenosis. But another way we are trying to do now is actually rather than I'm moving away from both mitomycin and triamcinolone, once I dilated, I try to apply my cryoprobe for a prolonged period. I mean, we are talking about application of almost 40 seconds to up to even 1 minute plus for each segment. And surprisingly, it works actually for certain cases in my center. So, but again, the data wise, we don't have a data to prove that cryoablation technique really works in this kind of patient or not. But just that, I mean, I move away from mitomycin C technically.
Thank you,
So
sir.
as we
Thank
are-
you so much.
Thank you, sir. So as we are running short of time, we'll wrap this session up. I thank all the panelists for giving you valuable inputs. Thank you all.
Thank you. Thank you very much.
Special thanks to Dr. Aravind Alaga, who has joined us via Zoom and given his valuable inputs.
Thank you very much.
We'll be happy to have
Be
you.
part of this conference.
Yeah, we'll be happy to have you for the rest of the sessions also, based upon your time availability. Thank
Sure,
you.
definitely.
Thank you, sirs. Now I would like to call upon our beloved Associate Professor Sir, Dr. Vimalraj Sir, Dr. Pratap Sir, and Dr. Praveen Sir to chair the next session.
Before introducing our speaker, Dr. Tyagesh, I would like to welcome Dr. Pratap Upadhyay from JIPMER, Associate Professor in Pulmonology, and Dr. Praveen, our Associate Professor in Pulmonology from Manakala Vinayagar. Dr. Pratap has finished his MD and DM in pulmonary medicine, along with DNB in pulmonary medicine. He has a specialty certificate examination certificate in respiratory medicine. He is also a fellow in APSR, and he has completed his EDRM. He is an associate professor in pulmonology at JIPMER. He has been trained extensively at PGH Chandigarh in his DM and JIPMER Puducherry in EBUS bronchoscopy, thoracoscopy, thoracic ultrasound, and critical care. He has published various articles in national international journals. He is part of a research team which had released Lung India's parametric guidelines when he was in PGH Chandigarh. He is successfully running dedicated asthma clinic, lung cancer clinic, and post-COVID care clinic in JIPMER currently. He has contributed 2 books, including a chapter titled ANA negative, seronegative SLE with DAH, in the book New Frontiers in Medicine and Medical Research, published in the year 2021. Welcome, Dr. Pratap. Dr. Praveen.
Morning, everyone. This presentation, we will. It's okay, no, sir. We'll start now.
Just. Yeah. Dr. Praveen is from Manakala Vinayagar. He is an associate professor in Department of Respiratory Medicine. He has been trained in EBUS, bronchoscopy, rigid bronchoscopy, and cryobiopsy and thoracoscopy under Dr. Yuvarajan. He has published various papers in national and international journals. He was invited as a speaker for various state and national conferences, including EBUS 2022 workshop and the recently happening TAPCon 2023. He has presented various case reports in international conferences like WABUC and APSR. He has been an active faculty organizing various conferences in Manakala Vinayagar. Welcome, Dr. Praveen. Dr. Tyagesh is an alumni of our institute. He completed a MD MGMCRI and he is currently working as a consultant interventional pulmonologist at Adyar Cancer Institute, Chennai. He has been trained in EBUS, bronchoscopy, thoracoscopy, and all IP procedures at Yashoda Hospitals under Dr. Harikrishan. He has published various papers, national international journals. He is a regular faculty in many of the national international pulmonary IP workshops on bronchoscopy, especially rigid bronchoscopy. Welcome, Dr. Tyagesh. The stage is yours.
Morning, everyone. In this presentation, we will see about management of central airway tumors and some of the cases which we had in our institute, and we'll share our experience on it. Before going to central airway obstruction, the basic definition of central airway obstruction is it represents a pathological condition that can lead to airflow limitation of trachea, mainstem bronchi, bronchus intermedius, and lobar bronchus. And around 20 to 30% of patients with lung cancer will develop complication associated with obstruction secondary to this central airway obstruction, like atelectasis, pneumonia, and dyspnea. And up to 40% of lung cancer deaths may be attributed to the locoregional diseases. Basically, central airway obstruction is classified into malignant and non-malignant condition. Malignant being a primary lung cancer or metastatic diseases like breast cancer, colorectal, and renal malignancies, and extensive compression or direct invasion of adjoining intrathoracic malignancies. In our center, the most common cause of central airway obstruction we see is CA esophagus patients who is presenting with a tracheal obstruction. And secondary to CA esophagus, we have CA lung, and then mediastinal nodes or masses compressing the airways. And the common non-malignant cause of central airway obstruction or the granulation tissue secondary to ET tubes, tracheostomy tubes, airway stents, foreign body material, and mucus plugging or any disease pertaining to vocal cords, and infections like mediastinal adenopathies. These are all the non-malignant cause of central airway obstructions. Basically, central airway obstruction is divided into these three types. So type 1, we have only intrinsic obstruction, that is a growth which is there only inside the airway. And type B is an extrinsic compression where there is a tumor compressing the trachea from an outside. And type C is both intrinsic and extrinsic, along with some tracheal cartilaginous destructions. So in this three types of central airway obstruction, this type A requires only tumor debulking procedure. And this type B and type C requires both a tumor debulking, and when the luminal narrowing is there more than 50%, those patients will require tracheal stenting. And this is the grading system which we use for grading a tracheal stenosis patients. It's Mayer Cotton grading, and grade 1 is from 0 to 50%, and grade 2 is from 50 to 70%, grade 3 is 70 to 99%, and grade 4 is complete total obstruction of the trachea. So when do you call the central airway obstruction significant? We consider any endoluminal diameter of less than 50% of normal to be indicative of significant airway obstruction. And there is a myth that the exertional dyspnea occurs if there is an endoluminal diameter of less than 8 mm, and on rest dyspnea occurs if the endoluminal diameter is less than 5 mm. And ideally in our clinical practice that is not the scenario. Like when it also depends on the comorbid condition what the patient has. Suppose if he's having a COPD lung, if his lung parenchyma is damaged, then the dyspnea will be disproportionate in that condition. And so any luminal diameter of less than 50% normal we consider as a significant central airway obstruction or tracheal narrowing. The common presentation of central airway obstructions are cough, breathlessness, hemoptysis, and wheeze, and these symptoms may depend on the location and rate of progression of the airway obstruction, on underlying health status of the patient, and also associated symptoms such as the post-obstructive pneumonia conditions. So when to suspect a central airway obstruction is mostly misdiagnosed with an exacerbation of COPD and asthma, or a partial improvement or persistent symptoms. We have to look for the central airway obstruction. And anatomically fixed obstruction like unresponsive to bronchodilators, we should consider the central airway obstruction, or when a patient presents with stridor or any non-specific symptoms such as exertional dyspnea and positional wheezing. For diagnosis of central airway obstruction, this PFT and chest X-ray are usually non-specific, and diagnostic modality of choice will be CT chest. The CT chest will give us a detailed idea about what is the location of the lesion, what is the extent of the lesion, what is the distal lung status, and planning for procedure and ruling out any alternative diagnosis. And other ancillary tests like visual bronchoscopy can be done, and fiber optic bronchoscopy will be a gold standard for assessing the central airway obstruction. It helps in treatment planning information such as relative amount of intraluminal and extraluminal disease, and also it allows for a tissue diagnosis. If you see the chest X-ray, only if you look closer, we can see some hyperintensity noted at the area of carena. So chest X-ray is usually non-specific in case of central airway obstructions. But in the coronal sections of CT, we can see the extent of the lesion, what is the size of the lesion, and where is the base of the tumor and everything. So CT gives more clear picture than a chest X-ray finding. And whenever a bronchoscopy is not feasible before going ahead with a therapeutic intervention, in that kind of patients, this visual bronchoscopy will help us to give us an idea about the airway lumen. So you can see this is a visual bronchoscopic image, and this is a bronchoscopic image. It's almost corresponding with the endoluminal lesion pattern. And advantages of bronchoscopy in central airway obstruction is it is gold standard in assessing and helps to do the biopsy. Disadvantages, when we do a bronchoscopy in an unstable airway, meddling with the airway and it will itself cause airway and tissue edema, and it will compromise whatever minimum airway patient has. And also the bleeding which happens will convert the previously stable airway into an unstable patient. And use of sedative agents, particularly neuromuscular blocking agents, it has a potential to induce a complete airway obstruction, secondary to loss of the respiratory drive muscle tone which the patient has. And indications of therapeutic bronchoscopy or intrinsic obstruction, extrinsic compression, or the combination, or any tracheobronchial bleeding, or tracheoesophageal or bronchoesophageal fistulas, and complex foreign body extraction conditions. So, on the basic idea of central airway obstruction, which patient to choose for a malignant central airway obstruction interventions, like the predictors of success are a pure endobronchial disease or a pure extrinsic compression patient. These patients have a good predictor of success, and predictors of failure are left mainstem bronchus involvement. Because of the length of the left main bronchus is more compared to the right main bronchus, once the left main bronchus involved, it will be very cumbersome to debulk the left main bronchus tumors. And mucosal infiltration of tumor and ASS score more than 3, and renal failure. These patients, these are the predictors for a failure in the case of central airway obstruction management. For a prerequisite for a successful procedure, the tumor should be the obstruction should be more proximal in the trachea, mainstem bronchus, or bronchus intermedius, or it should be a localized disease. And the patient should have a functional bronchi and lung parenchyma beneath the obstruction to enjoy the benefit of debulking. and the patient should have a functional pulmonary artery in that side of involvement, and the performance status of the patient should be stable to enjoy the clinical benefits of whatever interventions we are doing. There is no point in doing an cumbersome intervention for a patient who's going to expire in 10 days or a week, where taking up these cases will increase the more morbidity to the patient compared to that. So when should we intervene? Primarily, it will be a palliative aim with aim of relieving the dyspnea or controlling the hemorrhage, or as a bridge to more definitive therapy such as surgery or radiation. Or in the absence of symptoms, it is generally ill-advised to intervene, and based solely on the radiological and bronchoscopic findings, and it is tailor-made for each patient. And in a critically ill patient, it will help to facilitate rapid exhumation and de-escalation of the care and long-term survival. So we'll directly go to the case scenarios, like what are the cases we had in our institute. So the first case is a 40-year-old female. She's a case of CA hypopharynx. She presented with a tracheostomy stoma with a stridor. When a bronchoscopic examination suggested of severe tracheal stenosis with approximately 3 mm of tracheal opening. And the issue with the case is that upper airway is completely collapsed because of CA hypopharynx and not able to pass through the pharynx. Only way to ventilate is through the tracheostomy stoma, and the patient has a tracheal stenosis over there, and we are not able to put a tracheostomy tube into the tracheal lumen. So patient is in stridor and dyspnea. So this is a pre-procedure bronchoscopic video. You can see there is a very small, approximately less than 3 mm narrow opening of the tracheal lumen. And this is a flexible bronchoscopy, which we did under sedation through the tracheostomy stoma. With a small pediatric suction catheter, we kept as a backup for oxygenation whenever patient needs it for this case. You can see the lumen size over here in this view. It's very so whenever we get a case of like tracheal stenosis, the method of dilatation is by keeping a Benz cuts in the most fibrous area of the stenotic area. So once you make a nick over that fibrous area, that the lumen will get opened up initially. So this is how with the electrocautery knife, needle knife, will be opening up the airway. So once electrocautery nicks are made and the fibrous strictures is released, what we will do is this is the CRE balloon dilatation of the airway. So we'll pass the CRE balloon into the stoma and we'll keep it in the middle. The one advantage of this using a CRE balloon is it will have the radial expansion will be uniform throughout the area compared to this Fogarty balloons. So post it will be like a sequential dilatation. We'll be keeping it for a minute. So once after CRE balloonation, you can see that adequate lumen is achieved. So in this patient, after this, we can apply cryo, like what we discussed. We can cryo over the stenotic area to make the tissue devitalized to prevent it from again going into restenosis. But in this case, what we did was we reinserted the tracheostomy tube again inside, and we inflated the cuff of the tracheostomy tube. So that acts as a temporary stenting for that area actually. And another case was a 64-year-old female who presented to ER with severe breathlessness and stridor, and she is diagnosed as a case of anaplastic thyroid CA. She had severe orthopnea and respiratory distress. So CT chest, which we done, showed an extensive compression of trachea by the mask. And emergency tracheal stenting done with laryngeal mask airway, and a self-expanding metal stent has been deployed. For deploying a metal stent, we can deploy it with the help of flexible bronchoscopy, also with the help of an LMA. And the patient extubated on table and stridor settled post procedure. So this is the type A lesion where you have it's a type B lesion where you have only extensive compression in this case. So this is the CT image showing extensive compression by the mass and narrowing of the trachea. And this is performing a flexible bronchoscopy under LMA. You can see there is a significant narrowing of the tracheal lumen at the middle 1/3 of the trachea over here. So this is because of this extensive compression, and there is no endobronchial lesion in this case. So this patient, we took it for a self-expanding metal stent. And these anaplastic thyroid carcinoma, it's a fast-growing and aggressive tumors, and these patients will have only some 6 to 8 months of their survival over there. So we can perform metal stent for this patient to palliate the symptom of stridor for him. So this is a post-straight SEMS, which is fully covered stent we'll be using for any malignant condition. to keep the lumen open. And you can, this is the post-stenting X-ray showing a presence of the self-expanding metal stent in the X-ray. And the third case is a 63-year-old male who presented with severe orthopnea and desaturation, and he was diagnosed as a case of CA esophagus. So for him, bronchoscopy done showing near total occlusion of trachea with an endotracheal growth in the distal end of trachea and carina, and the carina is not visualized in this case. So for this patient, we performed a rigid bronchoscopy guided tumor debulking and an electrocautery snare, and coring done with an endobronchial with a rigid bronchoscope, and a fully covered YSEMs of 18 to 16 mm deployed. So this is the pre-procedure video with the rigid bronchoscope in situ. So in all the cases which we are performing, these interventions like snaring and electrocautery and cryo, we will use rigid bronchoscope as a conduit, and we will work mostly with the flexible bronchoscopy equipment. So you can see the entire carina is not visualized, and there is a tumor arising from the posterior wall of the trachea, which is occluding the airway, and patient is breathing through the small slit opening which he had. So this is the video show of post tumor debulking, and this is where the base of the tumor is. So we have cleared the tumor, and carina is visualized, and both lumen patency is achieved. Not only this endobronchial tumor, and this patient has also had a extensive compression of the left main bronchus by the CA esophagus mass, which is present beneath it. So this patient is a combination of both an intrinsic and extrinsic pattern of obstruction, and as the lesion is more close to the carina, which is around less than 2 centimeters from the carina, we performed a fully covered YSEMs for this patient. So this is a post-tracheal stenting. This is a fully covered metallic Y stent. Post-deployment, the luminal patency is achieved, and these kind of patients will be presenting to our ER with a very poor performance status. But once we do this kind of an intervention to them, their performance status will increase, and they can be taken up for further radiotherapy management or palliative RT, or any definitive management is possible when we improve the performance status of these patients. And this is a case of CA thyroid with an endobronchial growth. As you see, the growth is more it's more close to the vocal cords in the subglottic area, and the base of the growth is it's quite longer compared to the previous cases where we see it is in the localized area. So this kind of patients, when they presented with stridor, we use a combination of techniques. Like initially we do this debulking. We'll start with an LMA, laryngeal mask airway, then we'll convert into rigid bronchoscopy. So this is electrocautery, using electrocautery electrode. We are coagulating the tissue to prevent the bleeding when we are doing this intervention procedures. As CA thyroid usually bleed a lot when we are doing this intervention. So first we will try to cauterize the tissue base like this. Once the tissue gets devitalized, then we will try to remove the tissue bits with the help of a cryo or a forceps. So this is a cryo probe. So once we keep the cryo probe and we will try to freeze the tissue around, we will be able to see a white color layer appearing around the tissue over here. So this is how the freezing is happening with the cryo, and then we'll pluck the tissue which has got adhered to the cryo probe. Whenever we are using an electrosurgical equipment or doing any procedures, we have to make sure the FiO2 is maintained less than 40% to prevent tracheal fire. In this case, even after doing this electrocautery coagulation and cryo debulking, there is still persistent tumor left over there. So this is the kind of patients where we will take for a rigid bronchoscopic coring with the help of a tracheoscope. So this is how the coring is done. So the coring is a clockwise and anti-clockwise rotation of the rigid bronchoscope around 90 degrees, so that it will, the sharp bevel edge of the bronchoscope will cut the tissue over the surfaces. And we'll keep a suction apparatus close by to suction if any bleeding happens. So this is how the coring of the tissue is done. So once the coring is done, all the tissue particles are coming into the center of the bronchoscope, which is cleared with the help of a suction apparatus here. And when we are doing the scoring, we should be make sure that we maintain the central path in the trachea. Otherwise, we'll be creating a false strata or we'll be perforating the tracheal lumen actually. So this is post debulking the tissue and after the rigid bronchoscopic coring, that luminal patency is achieved. But in this case, you see still there is, because of a CA thyroid extrinsic compression, the luminal narrowing is still present for him. So this patient required a silicone stenting. So now we are trying to do silicone stenting even for malignant cases. If we are expecting a definitive treatment and the curative intent is there for these patients. So silicone stent, usually when we are deploying a silicone stent, the silicone stent should be deployed more distally and it should be taken up with the help of a rigid bronchoscopy forceps. So this is how a silicone stent should be mobilized. We should hold it and we should twist it to decrease the luminal diameter, and then we should pull it up. This silicone stents, pulling up is easier compared to pushing it down those stents. So this is post-stenting procedure, like we are maintaining the luminal patency. And most of the times our radiotherapist will request us to put a stent into the airway to prevent from airway edema, which is secondary to radiation therapy which they are going to give. So this patient, we have stented the lumen and luminal patency is maintained in this case. And another case is a case of she's a 65 female, is a CA esophagus with status post radiotherapy, presented with episode of recurrent aspiration pneumonia. So CT chest done showed an esophageal stent in situ with the features of aspiration pneumonia. Bronchoscopy done shows a tracheoesophageal fistula in the distal 1/3 of trachea with an esophageal stent eroding the posterior wall of trachea. So this is the pre-procedure video. You see there is a esophageal stent can be visualized through the posterior wall of the trachea over here. And there is a significant luminal compression noted in the right and left main bronchus. So this is the tracheoesophageal fistula, which is, it's a huge defect which is noted in the posterior wall of trachea. And an adult bronchoscope was not able to pass through both the left and right main bronchus, secondary to the compression by the stent itself, actually. So this kind of patient will require a self-expanding metallic Y stents for these patients, because metal stents have better approximation to the wall to prevent this recurrent aspiration pneumonias. And usually we do the fluoroscopic guided Y stent deployment. We will so these are the markings which is placed over the chest wall of the patient. Like this is the carinal marking and this is the left and right main bronchus. And you can see the esophageal stent which is noted in the background. So this is our stent which is we are deploying inside. Once both the limbs of the stent is kept in situ, first the left limb is open, right limb, then you can see the tracheal limb is getting opened up in the fluoroscopy over here at this point. So this is how the fluoroscopy guided Y stent deployment is done. So this markings will be done with the help of a fluoroscopy. Like we have to place a bronchoscope inside and we have to see the tip of the bronchoscope and mark it with the help of any metal or things can be used, like lumbar puncture needles or blades, whichever available with us, we can do this thing. And this is a post-procedure video, which is showing fully covered self-expanding metallic Y stent is there, covering the fistulous tract and also securing the airway by opening it from narrowing. And this will be the last case for discussion. So we are seeing each case in each categories, like whether an intrinsic, extrinsic and all. So this will be an interesting case which had a endotracheal tumor. So she's a 50-year-old female who presented with an impending respiratory failure with respiratory rate of around some 45. She's tachypneic and not able to lie in supine position. And CT scan suggestive of left destroyed lung with an endotracheal tumor noted in the distal end of trachea with near total occlusion of the only patent right main bronchus. So bronchoscopy done showed a near total occlusion of trachea. And you can see there is a left-sided destroyed lung with a compensatory hyperinflation of the right lung is seen in the CT. And this is an endotracheal tumor which is sitting inside, which is occluding the only patent right lung. So this is the pre-procedure video of this patient. This case, we had challenges in maintaining the airway lumen because we thought that once we paralyze this case, we are going to lose her because of the, once we paralyze, the muscle tone will be getting lost, and only this patent lumen which is seen here is going to get closed, occluded by that. And the risk of doing a pre-procedure bronchoscopy in this case is if we try to touch the tumor and the tumor got swollen up, then again we are going to lose the whatever remaining lumen patency we had. So this case, we performed a rigid bronchoscopy, get a tumor debulking. So this is under sedation. We try to pass an ultra-thin bronchoscope through the tumor to see whether the right main bronchus is patent because we are going to intervene her to save. So we want to know whether what is there behind the tumor, which is in this. So by passing the ultra-thin bronchoscope, we are able to see right main bronchus is patent in this case. So we did a rigid bronchoscopic intubation, and we put an electrocautery snare around the tumor to dissect the tumor. So in this case, as I was telling, we kept her in a spontaneous ventilation, and under a deeper sedation plane, we are doing this procedure. So the rigid bronchoscopy will act as a conduit, and all those snaring procedure has to be done with the help of a flexible bronchoscope by maneuvering it from the outside. So this is how the looping of the snare to be done. Like, so once the snare is looped around, we will do the cutting and coagulation at the same time to prevent bleeding from the tumor to happen. Until this point of time, the case was going as we planned. But what happened, like after cutting the tumor, we have mobilized the previously stable fixed tumor into a mobile part. And when the patient is on spontaneous ventilation, this tumor fell into the right main bronchus because the patient, she used to take her breaths. No? So whatever tumor we resected it, the tumor went and got obstructed, and patient saturation gone till 0 at that point of time. And luckily, I had a good anesthetist to reduce my tension. So he take care of that part. So you can see in this video that's happening. So once the tumor is removed, like previously stable tumor, we have mobilized the tumor at this point now. So whenever a patient takes a breath, you can see the tumor is plugging into the right main bronchus. See, this is how the tumor will get inside the air. You can see the tumor is sucked into the right main bronchus over here. So with the help of forceps, I try to remove this tumor. We don't have cryo at this time when we are performing it actually. So we used a jumbo forceps from our medical gastro colleagues. They have a forceps with a larger bite thing. But one thing, another challenge what we faced was this tumor size is so huge to be taken out through the rigid bronchoscopic lumen. So we have to remove along with the rigid block, end block, we try to remove the tumor with this forceps. So under direct visualization to see the tumor over there, and we try to remove that entire thing. So this is a purely an intrinsic growth. So these kind of patients, once we remove the tumor, it doesn't require any stenting or any procedure, just opening up the lumen, and the luminal patency will be maintained for them. And it turned out to be a carcinoid tumor, and luckily it doesn't bleed like what we suspected in usual carcinoid. So once tumor is removed, we're able to see the distal carenas visualized clearly, and the entire right main bronchus is open. And as the patient has been living with this single lung for a long time, luckily she able to maintain oxygenation with this one lung what she had. And these are the post-obstructive pneumonic secretions which is there inside the airway, and we have tried to suction and clean it out actually. So so these are the cases and experience which we had in our institute. Thank you so much for the presentation. Any doubts regarding the cases you can.
Any questions? Last case, how to prevent it from happening? Dislodgement of tumor.
Yes, sir.
If same case comes next time,
okay,
what precautions you will take?
No, I think it's not like removing the tumor in toto. We have to remove it as a piecemeal to prevent it from occluding the airway. Or suppose if that happens, see, this case is quite a riskier thing because we don't have the other lung to ventilate. But most of the time when there's a patent left lung, what we do is we will put an MLS tube into the left lung, we'll try to isolate the lung, and then we'll work on the right lung action. That will be the ideal cases which we see, both patient having both the lungs with a huge tracheal tumor and all. So we'll try to isolate that lung actually.
One more question. Suppose if you get a case with stridor, but oxygen requirement is very high, like 60. So you're left out with what options?
The reason for stridor will be like malignant
endobronchial lesion.
Endobronchial lesions, tumor. So most of the cases, the oxygenation can be taken care by HFNC, HFNO by giving it. So that can be maintained. But removing the but symptomatic improvement of the stridor will be there only if you try to remove the tumor which is causing the obstruction actually.
My question is, heart procedures are riskier because oxygen requirement of patient is high. So we're left out with what options to debulk?
So that's what oxygenation is primary. Maintaining the oxygenation will be primary thing. So either you intubate the patient or intubation will be a good option actually. So putting an ET tube inside and then trying to maintain the oxygenation level, then performing it with a we can do with a flexible bronchoscopic guided with an ET tube also, sir. Because that we have to have a good conduit to maintain the luminal patency actually.
Oh, Mike, actually what I'm asking is, if you use laser or some procedure with high oxygen requirement is risky.
No, I mean, with the higher oxygen requirement, yeah. But using electrocautery will be quite risky thing. But what I'm telling is like we have to improve the oxygenation status before doing it. Then decrease it, and then we have to do it. Actually.
And suppose if you get a young patients with mediastinal lymph node extensive compression, but you don't know diagnosis, patient is symptomatic, what stent you would prefer? Where diagnosis is unknown.
So we have done cases like we have done a EBUS guided mediastinal sampling. And then we have done a stenting that can be done actually. So both diagnosis and therapeutic can be done in the same sitting for these patients. And if it is in the level of carina, definitely we have to go for a Y stent. But what usually is like, unless there is a tracheoesophageal fistula, I try to avoid putting a metal stent inside. We usually try to put a silicone stents for them actually. For the patient who's having good response, if it turned out to be a tumor responsive, like tumor markers are positive for those cases, then those patients will have very good response for this.
So basically, you'll do on-site rows.
Rows.
And if it's malleable, decide on the stent based on the diagnosis.
Diagnosis.
Okay.
Can be done.
And for carcinoid debulking, are you using embolization routinely? Broncholateral embolization?
No, sir. Like we are not routinely using it. But if we could do a pre-procedure bronchoscopy and see there is a lot of tumor vascularity noted over the tumor, then we may consider giving a bronchial embolization.
Okay, depends on the
tumor. And it depends on the financial status of the patients because we cater very poor class patients, those who don't, they are not affordable for this bronchiolateral embolization procedures and all. So, but if it definitely needs for a procedure, we'll go ahead with the bronchiolateral embolization.
So, do you use routinely embolization? Is any role?
Yeah, good question. I think if it's a long-standing carcinoid and if bronchoscopically it looks very vascular, it's a good idea to do it. The only thing is the timing of the embolization. You'll have to do immediately. Immediately meaning within a day or two. Otherwise, there will be a little more bleed. We've in fact published one of the cases, which is significant. The chronic left side and the tumor from the left side goes all the way and then closes the right side. The patient came in an emergency Sunday evening, and then we had to go do a two-stage procedure. So first stage was removal and then significant bleed, embolized it and then removed it and subsequently had a surgery done and the patient was good. So in a carcinoid, yes, if it's a long-standing carcinoid, it picks up a lot more of vessels, it becomes a lot more of vascularity. A bronchial artery embolization will definitely help in reducing our thing. And as far as the removal and the moving thing, use a rigid bronchoscope packet. The two things that happens once you remove it. One is that tumor keeps moving inside and can migrate. And second thing is if there is a lot of secretions behind, that will come and flood. By the time you take this tumor out and within that, there will be a lot of messy secretions. So we do two things. One is before removing, we try to go around or put in a section, make sure that the distal portion is a little less mucky. And second thing is once the thing is off also, we'll just push it in and then make sure wait for the cryo and use a cryo. I mean, obviously you had limitations at that point. I enjoyed all the cases. Thank you.
Thank you.
Thank you, Dagesh. It was a good presentation. So regarding after doing all these procedures, how frequently you do a chexoscopy and what is its importance?
Sir, in our institute, we have like after a month, we will be doing a check bronchoscopy to see the stent condition for the granulation tissue and all those things. But if there is anything based on that first month follow, we will try to make up for the next. But routinely, we'll do the first month bronch will be there. Then after every 3 months, we try to do a bronchoscopy actually. Sir. But based on the patient symptom, also we'll be trying to do the deciding the bronchoscopy part.
So the last case that you used a gastro through.
I said.
How did you insert? I mean, through bronchoscope or direct?
Yes, sir, through the bronchoscope, sir. They work in a 2.8 channel bronchoscope. Sir.
Oh, that goes through it.
Yes, sir. So most of
because
the
that's a huge.
Yes, 2.8 channel.
Means they have you expected that do you call them on emergency basis?
We share the same endoscopy suit. We don't have a separate bronchoscopy.
Because they only
Yes, sir. So
because
most of my equipment I borrowed from gastro guys actually. All my snares and all those things are like from them because the snare which I used also is a larger size snare actually. It's not a routine snare which we use for colonoscopic snares. Sir. Thank you. Sir.
Thank you, Dagesh. It was very interesting to listen to you. Right. You must be living day in and day out with all those cancer patients with stage 3, stage 4.
Yes, sir.
Just for the information sake, I want to know how much extra lifespan your intervention has added to these patients. Definitely, they must be thankful to you.
Yes,
so just share your experiences, how much your intervention has impacted their life.
Sir, most patients like coming like this in stridor and dyspnea, they'll be probably living for a day or two if you're not intervening them actually. But when we put a stenting procedure for them and we monitor them regularly, it definitely they will survive up to more than 8 to 9 months of time, sir. But when we anticipate for longer survival, we'll go for a silicone stenting. So they it's been 1.5 years I joined the institute, sir. There are only few patients which are on silicone stents. I'm still keep on monitoring, but those who put my metallic stents, maximum 7 to 8 months we can give the time. Yes, sir. So that's
good on that. I think a point's taken. The best thing to look at if you want to have a data on this is Prashant Chajat's a paper on this. This came out in respiration. So there were two things. So all these patients don't come into clinical trials. The patients who have a central airway obstructions are right away taken out of chemotherapy trials because of this. So when Prashant was in Switzerland, this study was done by them. The two groups of patients, non-small cell lung cancer, age matched, everything matched. One group had central airway obstruction. And then they do the lasers and stenting and so on. Then they go for the chemotherapy and radiotherapy. The other group was the ones which had no central airway obstruction to start with. And they were age matched, everything else matched, including performance scale. Subsequently, they looked at the survival, and the survival was similar to what you have without a central airway obstruction. So these two are matched. If you take care of that component, they behave exactly like the others. So as Tyagesh said, what would have otherwise been a mortality would continue to have the benefit of all that as far as lung cancer goes, non-small cell lung cancer. About esophagus, I have my own reservations about the esophagus, the double stenting and so on. We were also very enthusiastic initially. We looked at our data, 14 cases in about 5 years, and then we looked at our data, it gave 105 days, and we looked at the literature for 120 days. Again, they go with the same kind of a problem subsequently. So we are giving an additional 3 months in a esophageal malignancy, especially when there is a GI stent. That's the usual way they come to us. GI guys will put in a stent and the patient develops a stridor and we have to handle. We have to anyway handle. But the thing is, the prognosis of that would be around another 105 days. So only one patient will live beyond 1 year. The rest of them didn't make it, and some of them didn't do well even in 2 weeks of time. So esophagus is an issue because there is a radial force on two sides, mucosal ischemia. They can also involve the vessels. They can have a torrential bleed and die. And they'll have an extension of this thing. You put in a stent and then the fistula goes beyond what you have stented and all that. So those are the things that will happen. And I'm sure you'll have a better experience.
Yes, sir. So the last patient is a CSO. That's my recent case, sir. I hope yes, sir, she's still there actually, sir, unfollowed. Yes, sir.
What do you think about the quality of life of these people?
Sir,
After your intervention?
Sir, all these patients who have put a metallic stents, they will we will be providing like home nebulization with saline and some cough suppressant. All those medication should be there, sir, because we are eliminating that mucociliary clearance spot for them, and they'll be having this cough with but minimal cough will be there. But once we keep the airway humidified, I think that part has been taken care of, sir. Actually, sir.
Thank you.
Yes, sir. Thank you, sir.
Thank you, sir. That was really an enlightening session, sir. We are so happy to see you perform many challenging procedures, and we could see that glow of pride in our HOD sir's face. Sir. I would request our HOD sir to hand over the memento to Dr. Tyagesh, sir.
Chairpersons also. Yeah.
And we would like to give the memento to our chairpersons, Dr. Praveen sir and Dr. Pratap sir. Now I would like to call upon Dr. Ramanan sir, Dr. Vimmi Varghese sir, and Dr. Jagadish Kumar sir to chair the upcoming session.
Good afternoon. I welcome Dr. Roshan, who is an assistant professor in Stanley Medical College. He is an alumni of Mahatma Gandhi Medical College. He has completed his interventional pulmonology from National Hospital and also in Malaysia. He has been regularly doing his IP procedures, and he has published various papers in national and international journals. He has received the virtual second place in virtual NAPCON conference in 2021 for the e-poster on clinical features on outcome of granulomatous polyangiitis. He received the Best Image Content Award in 2022 for bronchoscopic image of airways at World Association of Bronchology and Interventional Pulmonology. I invite him to deliver his lecture on linear E-bus basics.
I have two tough job. I know it's a pre-lunch and corners A-bus pressing in the front of an pioneer. Patabi sir. So I have this two tough job right now. Okay. So let us move on to, I'm just going to keep myself basics about the convex E-bus. We all know the convex E-bus has been a part of a regular interventional pulmonology practice and has been there for more than a decade. I thank my teachers, Palni sir and Surendra Menon sir, who have been mentoring and guiding me throughout this. So moving on to basic history, so 1949, the first transbronchial aspiration was done, but initially it was done through rigid bronchoscope. Then Wang and colleagues successfully diagnosed lung carcinoma with introduction of Wang's needle, but that was done to the flexible bronchoscope. Then it was introduction of a radial E-bus, followed by 2023, there's an introduction of an bronchoscopic guided real-time lymph node under ultrasound. By 2010, E-bus was used as a part of E-bus TBNA and endoscopically trans-esophageal bronchoscopy TBNA. By 2023, TBNA was an accepted preference of choice for the mediastinal in non-small cell lung carcinoma. I have missed one part of the history is in 2008 in India, the introduction of E-bus by Patabi sir, that history I deleted, sir. There's one because you are evident of this history. In 2008, I think first E-bus was done in India by the Patabi Ramasaran group. So basically, what is in E-bus? It is just a linear curved array. It is incorporated in the tip of the bronchoscope. Definitely, it is an accurate with a minimal invasive procedure that can be performed as an out procedure. Advantage of conventional from TBNA is from the E-bus is in real-time guided transbronchial needle aspiration. The key factor that we look for a E-bus TBNA is a high diagnostic yield and has a relatively safety profile. The recommended from the global is that at least we have to perform doing a fellowship, we have to perform at least 25 to 50 bronchoscope observation, then assess and perform. It has to be around 25 to 50 to for a competence level to perform an E-bus. So it is important to know the basic understanding and the knowledge behind when you're performing the E-bus. So first comes anatomy and imaging. It is an PET CT. First CT, then PET CT of individual mediastinal lymph nodes and correlating with an ultrasound bronchoscope. Definitely lymph node mapping by international guidelines. Then diagnosing and staging of non-small cell carcinoma and the role of E-bus in the staging algorithm. More importantly, it is known as having an organized endoscope room, a good third hand, and to understand the equipments required for the E-bus TBNA. And strategic of systematic approach and selective case approach, knowing the contraindication, and most importantly, understanding the basic principles and physics of ultrasound. So E-bus was basically first started for the staging of non-small cell carcinoma. Then it was evaluated in using the post-operative evaluation, restaging, and any tumor surrounding the airways and esophagus. Then any mediastinal lymph nodes and any mediastinal metastatic nodes from the extrathoracic tumors. So contraindicated severe thrombocytopenia when there's a confined mediastinal cyst, non-correctable severe hypoxia, and definitely a lack of personal experience. So we all know that mediastinal scope was a gold standard procedure that was performed way back in a decade ago. It's a surgical technique where you had an excision biopsy of the lymph node through the rigid mediastinal scope, where you could only section and remove 2, 4, and 7. There's a landmark trial by Aster randomized control trial, which was looking at mediastinal scope of endoscopic for the mediastinal nodal biopsy. So here the study was looking a patient who undergoes directly a mediastinal scopy for a patient who's planned resisted operation versus undergoing an E-bus followed by a staging mediastinal scopy. So this study has shown that they had a similar sensitive comparing both mediastinal scopy, but what could we look is at a lower complication level, fewer unnecessary thoracotomy. follow that, we have many studies that have shown that the sensitivity and negative predictive value for EBUS and EUS were more comparatively better than the mediastinoscopy. So then is there no role of mediastinoscopy? Definitely there's a role of mediastinoscopy. Whenever there's a high suspicious of malignancy in spite of a negative EBUS, always consider mediastinoscopy. So next question comes, who should resume mediastinal staging via EBUS? Okay, looking at the factors, first to understand there is a non-invasive staging and an invasive staging. When see a non-invasive staging, it is a CT scan and a PET CT. Okay, the sensitivity comes around 80% to CT is lesser sensitive, it is more sensitive. But when this was compared with an EBUS, the sensitivity rose up to 92% and the specificity was 100%. Then they look upon the invasive part of it, mediastinoscope, EBUS and EUS. Definitely EBUS had a upper hand with a sensitivity of 90% and a specificity of 100%. So the guidelines from ERS and European Society of Thoracic Surgery, their recommendations were when the patient with proven or suspected non-cell carcinoma, when there's no mediastinal involvement in a PET or CT, consider EBUS only when they have three or following condition. When they have an enlarged or FDG uptake on a ipsilateral node. Second, a primary tumor without FDG uptake. Third, tumor size is more than or equal to 3 centimeters. So irrespective of the mediastinal involvement that you can see in the CT or PET, when you have these three conditions, consider doing an EBUS. And other recommendations are when there is a centrally located or suspected non-cell small carcinoma, even without the involvement of mediastinal or hilar lymph nodes. So next question comes, what lymph nodes should be sampled during the mediastinoscope? So all the recommendations says when the sample or the intrathoracic lymph node, when the size is more than or equal to 5 millimeter and the accessible to EBUS has to be sampled. The sensitivity when the nodes were sampled more than 5 was a sensitivity of 89% and specificity of 100% for detecting malignancy. And this and the European Society guidelines also recommends to sample any mediastinal lymph nodes of more than equal to 5 millimeter when they are considered for surgical resection. Other condition is when there's an enlarged or PET-avid lymph nodes. So how do we sample? I think one of the questions that was asked by the audience, what kind of sampling has to be done? So always when you suspect a tumor on one side, always sample the tumor on the opposite side. So for looking at this graph, so the tumor is on the right side. So we have an N1, N2 and N3 staging. Basically N1 staging is what we call an ipsilateral peribronchial or hilar lymph nodes. N2 is an ipsilateral, mediastinal or subcarinal. So we can take as 4L or 4R with section 7. N3 is a contralateral, mediastinal, hilar or supraclavicular nodes. When we take this picture, the lymph nodes is on the right side. So first, whenever you do an EBUS, always consider doing the EBUS on a contralateral side. So when you can consider N3, so N3 comes an hilar interlobar or hilar interlobar nodes. Okay, when you consider if this is also negative, when you should understand whenever you sample a contralateral, even one node, even the first sample has come as positive, you can stop it. No need to go and access all the nodes. That's one key advantage of doing an EBUS. Even one sampling has comes as positive malignancy, you can stop the procedure there itself. When N3 is negative, then consider doing an N2. N2 is 4R. In this patient, N2 is 4R or subcarinal nodes. If those also negative, then consider doing sampling N1 nodes. So let us quickly go to this basic understanding of a lymph node mapping. They are divided into a 7 zone and 14 lymph node. So I'm not going to go in detail, but what my point is that to understand what are the most accessible for EBUS. When you see the accessible site, it is 2R, 2L. There is upper paratracheal on the right, on the left. Then lower paratracheal as a 4R and 4L. And there's a subcarinal node 7. And there's an hilar interlobar nodes. When you add upon this, okay, with an EUS, okay, the advantage of doing an EBUS, trans-esophageal bronchoscope, DBNA. So the accessible sites increase where you can involve 8 and 9, and if there's an enlarged, significantly enlarged subaortic nodes, that also can be done. So always now we are trained with EBUS, but upcoming I think EBUS with USB is also going to be an add-on, and it's going to be a complementary procedures. So it is before performing an EBUS, it is always important to know the landmarks of the session. And the recommendation is to search for the landmarks in the order of 4R, 4L, 7, 10L, 10R, azagus, and 4R. All this all these landmarks comes with the adjacent vascular structures. So identify the vascular structures, and surrounding that you'll have all these landmarks. So quickly going to the left, first go to the left lower particle, just the scope, okay, near the carina, just 1 to 2 centimeters before the carina. Okay, turn your scope on the left side and screen for the 4R. The 4R usually appears at the Mickey Mouse sign. You can see him. Okay, where you have an aortic and a pulmonary, left pulmonary artery. This is an 4L. So again, for a 7, it is easy. Put on the either on the right and left side on the medial side of the bronchus. Okay. So you have note 7 there. For 4R, just tilt the scope on the right side. Look for the azagus one. Just scroll, with the rotation, and you're able to see SVC, and above the SVC is in 4R. 10R and 10L, it is come, just take a transducer, go into the right main bronchus with a facing upward. Okay, you are going to get an 10R or 10L. For 10R, it's simple. When you trace an 4R, and you will find next an azagus vein, and stay at the same point, just move the scope little down, and you're able to find 10R. So 11R, it is between then upper lobe and bronchus intermedius, and 11L, it is between the right and left, left upper one and lower lobe bronchus. So once you know the staging, it is also important to know the TBN equipments. So the one that denotes is an ultrasound transducer, second is in working optics, third is an working channel. So currently we have 3 different models of EBUS from the Olympus, Fuji, and Pentax. They definitely have a very difference, and one has advantage over the other. If you see, mainly looking at the direction of view, because EBUS is not like a conventional bronchoscope, like how you directly view, and it is have the same direction. For Olympus, it is 20-degree forward oblique. For the Fuji, is a 10-degree. So for the Fuji, 10 degrees is more like an performing a conventional bronchoscope. Pentax is an 45-degree. It has to be look up at 45-degree, and you have to go anteriorly to the coracoid cords, and you have to insert over the trachea. And next, considering the distal tip, for the Olympus is 6.6, Fuji is 6.7, and Pentax is 7.4. Pentax is a little bit larger compared to other two. And when you compare the ultrasound, Olympus has its inbuilt ultrasound processor, even the Fuji, but Pentax has a sole console ultrasound machine. And when you look at instrumental channel, Pentax, Olympus has 2.2, Fuji and Pentax has 2. So when a 2.2, Pentax only, you have an 19 G needle that only passes to the Olympus. So needle, there are multiple companies that comes in the needle. You have a Boston, Cook. This needle, their advantage as one or other. If you look at the needles, we have 2 types of needles. One is a cytology, one is a histological tool. Cytology, more you get a smaller sample. Histology, you have a bigger tissue sampling. If you see in Boston, you have a 25 and 22, which is most of cytology, and acquire final biopsy, which is 22 and 25, more on histological sample, where the edges, we have 3 cutting edges, so the sampling is a bit more. Then you have one more to have a greater chunk of sample is called core DX mini forceps. That is more of an histological tool. This compared with Olympus, Fuji, and Pentax. Then Cook also have a 2 type, histology and cytology and histology. In histology pattern, if you see, there's a core trap design for the better tissue sampling. Olympus, we have a newer series of VZ-Shot 22 and 21, and Olympus has an 19G, which is more of an histological tool. It is compatible with Olympus, Fuji. Mediglobe again has a 2 kind of sampling, EBUS 22 and ProFlex 22. Now, looking at the different size of needles, are there any different size of needle when comparing 19, 21, 22, and 25? Are there any sample differentiation? Is any difference in the yield, diagnostic yield when you compare all this? Definitely, almost most of the studies say there's no there's an insufficient evidence to recommend one size over the others. So almost all had a similar diagnostic yield. The Chest Society and the Indian guidelines recommends to do an 21 gauge or 22 gauge for an EBUS TBNA. So what is the amount of passes that needs to be done per lymph node? When you consider a patient with a non-small cell carcinoma, the recommend is 3 passes per lymph node session. And if you want to do a diagnostic and a mutation analysis, they consider to do a 4 passes. In sarcoid, the recommendations are to either do a 4 from a single node or do a 2 from 2 different nodes. So after understanding what and needles, let's look into the ultrasound characteristic. So we definitely look into multiple characteristic of ultrasound. First comes the shape, so round shape or oval shape. How you define a round shape or oval shape? If then short axis is a long axis with more than 1.5, then we call this an oval. If it's less than 1.5, we call this a round shape. So significant is most round shape or likely favors malignancy. Heterogeneity, look at homogeneous and heterogeneous. Most heterogeneous or favor malignancy. Calcification, is it present or not? Then we look at the size. So size has to be done comparing the short axis. The size is more than 1 centimeter, that also favors in malignancy. Margin is an indistinct margin or well-defined margin. How you characterize is an indistinct or well-defined? If it's more than 50% of the margin, if you're able to see, it is a well-defined margin. The most important two characteristic of EBA that we have to look on every patient is central hilar structure, that is defined as a linear, flat, hyperechoic area. You can see this one, hyperechoic area in the center of the lymph node. The presence of central hilar structure favors the diagnosis of benign. And coagulation necrosis sign, it is a hyperechoic area with the absence of blood flow. There's an absence of blood flow in the Doppler. So when there's a present of coagulation necrosis sign, that denotes favors of malignancy. But most of the studies had looked into this characteristic of favoring for malignancy when the notable size, round shape, heterogeneous ecotexture, absence of central hilar structure presence, definitely this denotes or favors the diagnostic of malignancy. But even the absence of this characteristic, still you can get an positive cytology, malignant cytology. But when you look on the sensitive pattern, the absence of central hilar structures is more sensitive compared to the coagulation necrosis. But if you look on the specificity of this test, presence of coagulation necrosis is more sensitive than compared to any other characteristic noted. There are many scorings available, but no scoring defined exact sensitivity, the good specificity and sensitivity for diagnosis of malignancy. When after this, when with this, there was a new add-on of elastography. This is basically a technique to assess the tissue stiffness and a distribution of stiffness in the selected area. There are two methods, qualitative and quantitative method. Basically, the blue signal represent the hard tissue and the green represent the softer tissue. Quantitatively, we do a strain ratio, stiff area ratio, or blue color proportion and a strain histogram. Again, when you perform a bronchoscope, there's a challenge to either to perform section or not section. There was no difference when you perform it section or not section. But what they say is when you add a section to it and when you find a bleed, then the subsequent procedure not to be performed with the section. So coming to the last few slides, anesthesia, it was an operator's choice. But mostly EBUS is performed as an OP patient with unconscious sedation, could be fentanyl, midas, and with an LMA, could be propofol. Some use ID tube, but whenever you consider doing endobronchial, always consider the size of 8 and more. So coming to last few slides. So general tips when you do a bronchoscope, always proceed with EBUS, always do and proceed with the bronchoscope. Look for the airways, look for the mucosal secretion, clear the mucosal secretion. Apply appropriate local anesthesia, clear the airway secretion, and know the forward oblique. So as I said, for EBUS is 10 degree, for Olympus is 20, and for Pentax is 45 degree. And the main point is balloon handling. Balloon handling is mainly because to have a clear image of an ultrasound and not to have a distorted images. Then always keep the EBUS head clean. Look for the landmarks on convex EBUS. hold the bottom part of the needle, because sometimes when you do a jab, or when you try to fix the needle, it moves here and so tell your assistant to hold the needle at the end point. Retract the stellate 1 centimeter to make the needle sharp. Wedge needle in the intracartilaginous space. Maintains appropriate angle at the time of entration. And most importantly is lock the needle and remove the equipment from the bronchoscope, or the whole bronchoscope will get repaired. So to summarize all this, first understand EBUS lung cancer diagnostic, secure the diagnosis, do an initial medicinal staging. If required, restaging after therapy, obtain additional tissue for molecular testing, additional PD-L1, then identification of the lymph node identification of tumor involved lymph node. Look at all the characteristic features: short axis, loss of fatty hilum, ill-defined margins, central necrosis, heterogeneous opacity, and consider elastography. The biopsy technique, sample all the nodes if more than equal to 5 millimeter, and sample all the PET avid nodes. Consider 21-22 gauge needle. Biopsy suspicious node last should have at least 3 passes per node, and additional 2 to 3 passes for the molecular studies. So rapid onset evaluation, look for the larger bore or 19 gauge of crown cut needle for dense and calcified nodes. Apply session for necrotic nodes. Consider needle biopsy or a cryo biopsy for insufficient samples. Thank you.
Thank you, Arun, for your excellent presentation. Any questions from the audience? I have a question. Any preference of needles?
No preference of needles, like all 21, 22.
Like between Cook and any advantages and disadvantages?
Sir.
My advice is only stick on to one kind of needle,
because
whatever you're comfortable with. There has been no head-to-head comparison. Different companies will claim things because based on how needle looks and how it works, what is the logic behind all that. My thing is, since it is not only you who is going to do the needle, it's a whole team. The nurse who prepares, so don't confuse them with a lot of options. Use one kind of needle and stick on to it and continue. That's what, because there is no difference between these two. As far as sizes go, probably 21, 22 and 19 are available. So and there are core needles, the Supro Core by Cook, and there is a Acquire needle by Boston Scientific, and there are a few more in the market that is coming up, and the cryo. So I think there are a lot of options. No difference between these needles as far as the thing goes. So use whatever you're comfortable with, but stick on to that.
Okay. Now we are having the FNB needles. Does still FNA needles have a role?
Everything has a role. In thyroid, we use a 26 gauge for a FNA, and that's good enough to make things. So making a diagnosis for cytology is good enough. Using a cell block, again, there's no big difference between a 21 and a 19 also. 19 makes a little more messier, but a bigger tissue. PGH Chandigarh gave, when there was a trial conducted between a 21 and a 22, no difference between the two. So till we have some data to think all these are just plain and scientific logic, there is no data. So stick on to single needle list.
Only sample sizes because some of the diagnostic yield remains the same for everyone.
Diagnostic yield remains the same, and what you're going to do is, well, we are now in a more nuanced state where all the tissue has to go through. If it's a non-small cell, we are looking at the next genome sequencing, NGS, PDL1 platforms are all there. But all the trials have continued to show that there is no difference even in these as far as the needle size goes. As he said, the size might be different, the tissue size might be different, but diagnostic yield remains the same.
So sometimes when we oppose the probe, ultrasound probe, still we could not just having the sheath proximally, we could not reach the jab. We could not do the jab correctly. Is it in that case is it okay to advance the sheath till the mucosa? Is there any?
You could do that's not going to cause any safety issues for the scope. You could do that if you have. And this typically happens when there is a very high kind of flexion involved, as in 4L side or in the 11R side. There might be, or a 10R. 10R is difficult, very difficult to get a position with that kind of an angle. You could advance it, but with practice, you slowly, kind of reach there. What happens is, bigger the size of the needle, stiffer the scope gets. So in that case, there is a merit in going for the lower gauge needle, because the caliber of the needle is thin. You may see that when you have no needle, you can actually see a lot. But once the needle is in the scope, doesn't bend as much, because there's also this instrument channel, because the scope gets a little stiff. You will not be able to see what you saw without this needle inside. Those cases pick up this smallest size of the thing, and there is a 25 by Boston Scientific. Now, since we are on the needles, Boston has a 25 size. That will be the thinnest needle. But the second thinnest is not 22 of Boston, it's a 22 of Olympus, because and 19 is almost equivalent. It flexes as much as a 21 of Boston. So 21 and 22 of Boston is stiffer. Cook is stiffer. So if you have to go through these things, either a 25 size of Boston or a simple 22 size of Olympus will be good enough.
I think unless you're able to see the needle in the ultrasound.
Yeah. Yeah, so his point is whether can we advance the sheath further and then jab it. Only thing is, you might miss out on the accuracy part. I mean, you might not get it in the frame properly.
Even calcification also can be a part. Calcifications happen.
Yeah, I mean, if
The thick capsule, sometimes it is difficult to jab, and
it happens in a fibrotic sarcoid kind of things. The rest of it is usually, and if it's a heavily calcified node, as Roshan says, it will be difficult to poke in. But if it's a complete calcified node, there is no point in poking, whatever the size.
So what is your take on lymphoma, sir? Because most studies shows a low
lymphoma, so we have a NHL and AHL, high grade and low grade. High grade, we can pick up in cytology as a suspicious of lymphoma. They will necessarily need to look at the architecture. In a Hodgkin's lymphoma, you might get a granuloma or in a mixed cellularity background. So there might be a granuloma doesn't mean tuberculosis always. So you can get in a granuloma in a setting of a Hodgkin. So lymphoma is an issue. So we try to do a cryonormal biopsy. We do it for whenever there is a suspicion of that thing. We have a rose. So when the rose says not enough, or there is a granuloma, but it's not a very typical granuloma, we try to make multiple cryo-nodal biopsy passes.
It's like a PG class for me, sir. From you, it's more like a PG class for me from you, sir.
Thank you, Roshan. Move on to next.
Thank you, sir. The way you explained the topic was exemplary. I would like to call upon our Associate Professor, Dr. Vimalraj sir, to hand over the memento to Dr. Ramanan sir, Dr. Vimmi Burgess, Dr. Jagadish Kumar sir, and Dr. Roshan Kumar sir. There's a slight change in plan as we are running ahead of time. So we'll break in for lunch now and we'll get back by 2:50. Thanks.
I'm extremely sorry, Kaushik. I think we need to, anyhow, in Italy, it is morning only. So right, you can wait for half an hour. So we'll get back to you, Kaushik.
Sure, sir. Okay, sir. Thank you, sir. Thank you.
Right.
Good afternoon, all. I would like to call upon Dr. Ramanan sir and Dr. Varun sir to introduce the speaker for the session and start with the proceeding.
Good afternoon, everyone. Welcome back after the lunch. Kaushik, are you there?
Yes, sir. Yes, sir. Can you hear me? Are you audible?
Yeah, I can hear you.
Thank you, sir.
For the next session, we have Dr. Kaushik Reddy. He's a consultant and interventional pulmonologist in Medicover Hospital, Nellore, India. He has completed his fellowship in interventional pulmonology at Yashoda Hospital and also in Malaysia. He has been trained in EBUS bronchoscopy, thoracoscopy during his interventional pulmonology fellowship. He has published papers in various national and international journals. And he has also been a faculty in various national conferences. I invite Dr. Kaushik to take over.
Thank you, sir. My screen is sharing?
Yeah, visible.
Okay. So good morning, everybody. Good afternoon to everyone out there. So I'm Dr. Kaushik Reddy, and consultant clinical intervention pulmonologist at Medical Hospitals. And I apologize everyone for not being there in person. And from my bottom of my heart, I thank my professor Pajnuvel sir and Vimal Raj sir for giving me this opportunity to talk about thoracoscopy and how to choose the right fit. So when we decide on it's a semi-rigid or a rigid thoracoscope, we'll all be in a dilemma what to choose, which scope to go with. Those of you who knows it, it's very well understood that which scope to go with. If not, then we will just get into the topic and we'll talk about few things about history, indications, contraindications, types, and which is rigid, semi-rigid. Then we'll talk a difference between semi-rigid and rigid, and we'll take home points. So no conflicts of interest. So basically, what is a medical thoracoscopy or a pleuroscopy? Is nothing but a small layman's word, a window to visualize the pleural space. And when we define medical thoracoscopy is a minimal invasive endoscopic procedures utilized by pulmonologists to evaluate, diagnose, and treat pleural pathologies, mainly pleural effusions, and which also helps in assessing the pleural cavity. So let's talk about the person who first did thoracoscopy. Is the father of thoracoscopy is Jacobius. So when he saw, this was the ray of light which has thrown upon so many pulmonologists or physicians that era, where they thought of doing procedures in thoracic cavity. Now, this is what Jacobius, when he takes class to all the physicians out there, when he told the world, this is what about the thoracoscopy. Now, when we see about the history, it's very complex. At least 10 decades back, around 1866, first Richard Cruz, he in Ireland, he performed thoracoscopy. That was not known. Then Jacobius, he was the first Sweden intensivist who performed diagnostic thoracoscopy on a pleural exudative effusions. And he published in 1921 a case series of diagnostic value of thoracoscopy in tuberculosis and malignant effusions. In 1970s, these two people, Brandt and Burton, who is a German and a French physicians, they confirmed the value of publications upon the thoracoscopies. Then comes the era of semi-flexible. He's a Japanese surgeon, Teniko, who did like a semi-flexible thoracoscopy for diagnosing pneumothorax. Then, and also he has treated it. Then comes 1998, where Olympus has given their 2 mm fiber optic thoracoscopy with the help of MacLean and his co-workers. The next generation has come in 2002, where 2.8 mm with video imaging has come. Then in 2007, there is an autoclavable semi-rigid was introduced. Now, now we have come to 2023, where the new semi-rigid thoracoscope also has been releasing by Olympus. So this comes take away from a journey of from along now. We are there's so much of guidelines, written, everything. So this is what a generation of the thoracoscopy evolution has happened overall. So what's the concept of thoracoscopy is very simple. We have to have a port off or for entry of the thoracoscope. We have to have a camera and light source. We have to have suction. We have to have forceps biopsy and cryo and cautery. Or with this concept, we'll move forward. So what are the indications of doing a thoracoscopy is whether two types, whether it's a diagnostic or the therapeutic. When you see diagnostic, to diagnose the undiagnosed exudative pleural effusions, for diagnosis of and staging of malignant mesotheliomas, and diagnosis and staging of lung cancer. When you think of therapeutic, talc pleurodesis, management of empyema cases, and management of spontaneous pneumothorax patients. So before entering into any procedure, stick on to your rules. We have to see the contraindications. Don't just do the procedure. We have to see what are the contraindications. So absolute contraindications is when there's lack of pleural space. In lack of pleural space, whether there's an advanced empyema or pleural thickening of unknown etiology, suspected mesothelioma, previously if patient has undergone pleurodesis, or in any patient whose inability to cooperate with the procedure. Or the relative indications would be any inability. Patients can't lie on the lateral decubitus position, or if he has unstable cardiovascular or hemodynamical status, whether presence of severe or uncontrollable hypoxemia, whether they have bleeding diathesis or anything, pulmonary artery hypertension, refractory cough, drugs, hypersensitivity, and who has short survival rate. If you think the patient is not indicated for doing thoracoscopy, we should avoid those. So there are two types of thoracoscopy or pleuroscopy. There's either one is rigid thoracoscopy and semi-rigid thoracoscopy, which we call as flexible. So in semi-rigid, we have one brand, Olympus. On rigid thoracoscopy, there are 3-4. I'll tell you in detail. So let's talk about the instruments that are used for semi-rigid thoracoscopy. So we have semi-rigid thoracoscopy, which is a 22 centimeter proximal rigid shaft and 5 centimeters of a flexible distal tip, and outer diameter of it is 7 mm. So the flexible tip allows two-way angulation, which is upward and downward. The upward goes 160 and the downward goes 130 degrees. The handle is very simple, like a flexible bronchoscope, which has a 2.8 mm working channel and the lever and the suction port. The scope utilizes a custom-made plastic tokar of outer diameter of 8 mm diameter. So in Olympus, we have two models. One is LTF 160-240 and LTF H290, which is yet to be coming 290 when. Now they released a brochure of 290. So let us talk about 240 where we are using nowadays. So it was released in 2001, which is a 27 centimeter, proximal 22 centimeter rigid, and distal tip is about 5 centimeters. The flexibility, it has an angulation, if you can see in the B picture, it's 160 degrees forward movements and the backward movements of around 130 degrees. So the outer diameter is around 7 mm. The working channel is 2.8 mm. So this one, which come recently in 2023, it's going to come. So here, when you see the forward angulation, it is around 180 degrees and the backward angulation is around 130 degrees. The outer diameter is 7 mm. The working channel has increased, which is from 2.8 to 3 mm. Now, the best advantage is you have NBA compatibility in the recent one. And they're also released endojaw single-use biopsy forces, which is FB240K, which has a biopsy forceps with an alligator jaw. So if you can see the picture, it is there. So with the help of this, you get a large volume of sample, which is not actually achieved in semi-rigid. So this is an outline. So the best thing that I can say, a thoracoscopy in a semi-flexible is the look and the feel of it, because we use bronchoscopes. So the outer diameter is around 7 mm and the length, the shaft, the tip angulation, the working channel, all these things. Now, these are the instruments that can be used in semi-rigid, where we have a catheter, a spray catheter, a coagulation electrode, a cyto brush, a hot biopsy forceps, and now we can use cryo also in it. So it's simple. Where if it is a semi-rigid, if we already have a tower of Olympus, so the connection, the light source would be the same tower. So visualization and visualization of the semi-flex rigid fluoroscopy can be connected to the existing endoscopy processors. So it could be CV160, CVU40, EVIX, which is come now, and also CV240 and 190 series also we can connect. Oh, my computer is stuck. So these are the images that has been released. Now see the NBA quality of the thoracoscope, which is coming in 290. So a small orientation of for you in a semi-rigid. This is the diaphragm. That's a parietal pleura. This is diaphragm. This is the lung. So this is how we can angulate. Now, if you see the retroflexion, this is the apex of the lung. Now see the retroflexion, which helps in the advantage of the semi-rigid, where you can see the posterior wall where you inserted also. So this is how visualization of semi-rigid thoracoscope would be. Now, what are the advantages of flexible thoracoscopy is the look and the feel of it, and it interfaces easily with the existing processor, and also it has better manuring options, and we can also, it's better, even patients who undergo talc fluorodesis also, insufflation would be better with it. And flexible, on the other hand, the feasibility and the operating negotiation of this thoracoscopy in semi-rigid is very helpful. In very loculated efficiency, the ability to retroflex the fluoroscope for the biopsy of the parietal pleura is advantageous, but it's not feasible with the rigid thoracoscope. But yes, the image quality is lightly or slightly less compared to the rigid thoracoscope. So the disadvantage is what it is. It's two things: whether the working channel would be very less because the forceps biopsy which goes gets the biopsy tissues is very less, and even there will be no mechanical strength as compared to the rigid thoracoscope. In patients with mesothelioma or benign fibrothorax, we face a lot of challenges with the semi-rigid fluoroscopes. So when we talk about rigid thoracoscopes, these are the set. So there are different companies for the rigid thoracoscopes like Richard Wolf, Karl Storz, Stryker, and also the domestic ones. So what do we need for a rigid thoracoscope set is the telescope and the light source, where trocar and forceps. Now, when we talk about the telescopes, we have Stryker telescopes, Storz telescopes, and also Now, those be around 27 to 31 centimeters with a diameter of 7 to 12 mm. The largest ones would be like 10 to 6 mm. I personally use a 6 mm telescope, and we also have 10 mm telescopes. So the best advantage of these rigid telescopes is they have degrees, angle degrees, where it can focus 0 degrees, 30 degrees, and 45 degrees. And these will come with a disposable plastic trocars also for the rigid thoracoscopies now. So the thing is, for the rigid thoracoscope, we need a separate light source or a camera and eyepiece telescope for it. So the different brands, I'll tell you in different things. Now, Richard Wolf, they have rigid telescope of around 5.5 mm with a working channel of 3.5 mm. And they suction, undervision, coagulation button electrode, hook electrode, probe rods, but the image quality is slightly poor. Now they come up with a mini rigid, which is new kid in the block. So they have 5.5 mm diameter operating metallic endoscope. In this, if you see, there's a eyepiece, and also you can do on the same settings the biopsies and all. Now, Karl Storz, they have two types. One is 6 mm, one is 10 mm telescopes. Now, if you see on the right-hand side, those are the trocars where it is flexible and it is come with plastic. And so this is Karl Storz. When we see the angulation, it's 0 degrees angulation and 30 degrees angulation, which helps us to visualize the pleural cavity in a better way. And also they have 45 degrees angulation. And this is the complete set of rigid thoracoscopy. This is a metal trocar where when we insert the telescope, then we put biopsy forceps, go inside, take a biopsy. I'll show that video in detail for you. Now, this is an example of a rigid thoracoscopy. This is the diaphragm. Parietal pleura. The apex of the lung. To see, this is the posterior gut. So it is little angulated. So one should perform rigid thoracoscopy after a good training. So what are the advantages of rigid thoracoscopy? We have trocar with multiple walls, large biopsy specimens can be taken, and biopsies are from dense lesions are easier to take. It's and it is helpful for radiolysis of the patients. And the best thing is it is less expensive also, it is more robust and less maintenance and repair cost also. Disadvantages, yes, there is a limited maneuverability, and the angulation of scope whenever you angulate the scope, the patient will have more pain also. But when you see the safety between rigid and semi-rigid is, there's so many studies which said not much of difference, but yes, even in patients who has more empyema, severe bleeding, port metastasis, persistent leaks are more common. But if you see the patient comfortability in pre-procedural pain, large trocars during rigid thoracoscopy cause more discomfort. And also patient may need more of sedation in patients with rigid thoracoscopies. But regarding talc fluorodesis, not many people said which is better, like rigid or semi-rigid, whatever they're comfortable with, it has no outcome. There are few studies which has been done on rigid versus semi-rigid thoracoscopies for diagnosing pleural disease. This study, they have taken instruments of Olympus and semi-rigid also. They subjected 84 patients. They did both forceps biopsies, and they said the samples obtained by the rigid thoracoscopy was smaller but adequate quality. There was one more study which was done. They said the rigid thoracoscopy was fine, more superior than semi-rigid. So there's always a controversial thing that goes around whether it's semi-rigid or rigid. So if you see the yield of the rigid thoracoscopy in tuberculosis patients, if it's going to empyema or anything, we have 100% near diagnosis for the patient, and also in malignancy, a high diagnostic yield. In semi-rigid, Diagnosis of undiagnosed pleural effusions were having 100% specificity and 97 sensitivity. So the negative predictive values for rigid and semi-rigid biopsies were 100% and 92.3% respectively. So when do you do it? I think both procedures should be done in procedure room under monitored anesthesia care. And yes, training is obviously needed for a patient. If you see training, the rigid thoracoscopy procedure, it is like a steep learning curve. But semi-rigid, it's relatively easy, particularly with comfortability in handling the scope and also the patient pain tolerance. So small thing. So the steps for the thoracoscopy, it's all, whether it's a rigid or semi-rigid, it's all the same thing. We see ultrasound, we diagnose, we see where the location is, we do these steps. So we inject local anesthesia, we see where it is, then put a nick. Then how we do for intercostal drainage, it's the same way, then put the trocar. Then there we go, we put the thoracoscope. So this is a patient we got with squamous cell carcinoma. So this step shows the semi-flexible thoracoscope, what instruments can be given, what is the better thing, what instruments can be passed through this, and how an adenolysis can be done. The best, the thing is we can suction. I've done a suction now of the effusion first. So these are all additions which are seen. I passed a brush. Now scrape little bit for the rows. The second instrument that can be passed is forceps biopsy, biopsy forceps to take a tissue of it. Now, even these adhesions can be broken by the forceps biopsy, but not much like the rigid thoracoscope. This is a cytobrush I've done again. Just to show the brush in close call. Right. Now, this is a thing, the same patient has undergone, we have done rigid thoracoscope also. Now see the image clarity, but the angulation would be much different. But look at the tissue size of the biopsy that we take. So that's the tissue size that we get in a rigid thoracoscope. Now, how to select it? Whether it's rigid or semi-rigid, what are the indications? We have to see the performance status. And if at all, if it's a semi-rigid, we can do outside OT or bronchoscopy suite or anything. And yes, obviously what the institute has, whether it's a rigid or a semi-rigid, the availability of it. So to conclude, what are the advantages and disadvantages of semi-rigid and rigid? The semi-rigid has more flexibility, where the rigid has limited flexibility. The ability to retroflex is advantages in semi-rigid, and the rigid with its inability. So the semi-rigid has we have existing endoscopy procedure. Yes, it is more advantage to connect the same thing, but the rigid needs a cold light source and the camera attached to it. And the disadvantage, it has small working channels. This has big biopsy facilities, but yes, semi-flexible rigid, you can take multiple biopsies so that you can get more tissue. Because we're in an era of NGS, we need more tissue for sampling. So rather than patient subjecting for another procedure, we need more sample. So think what are the pros and cons? So this is all I said. What are the disadvantages? And these are the advantages. So my take-home message would be thoracoscopy is an important aspect of IP with significant role in establishing the diagnosis and specific role in therapeutics. But it is comfortable to begin with semi-rigid thoracoscope and evolve into rigid as it gives more advantages beyond routine pleural biopsies. So I thank my professor, Dr. Pajnivel sir, for giving me this opportunity. This was the picture. He came to my place to see my hospital and everything. And I thank Vimal Raj sir also for giving me and pushing me to present this. Thank you, sir. I know they know that I'm in Italy, but they told me you can present online also. Thank you for giving me that opportunity, sir. And yes, this is my family where I graduated. And this was the sleep lab we inaugurated in sleep apneas. So I'm happy to be a part of this. And Dr. Harikishan sir, he's everything in IP for us. And he's given us a different platform here in the world. So I thank sir for giving this opportunity. And here are the intervention pulmonologists that I'm doing my course on. Dr. Professor Lorenzo Corbeto, and I've met Sir Taiwan sir in Malaysia conference, and Jamal sir in Malaysia. So I thank everybody for listening to me. Thank you, sir. Any questions?
Thank you, Kaushik. That was a wonderful presentation. Any questions from audience? Yes, sir.
Me and Vimal were discussing about it. Kaushik, you said this Olympus, the latest version, is it out in market 2023?
No, sir. No, sir. I also want to get, but they didn't come up with 290 scopes still, sir.
Yeah, actually, we wanted to buy that, but they said it takes some more time in market.
Yes,
so
sir.
just to clarify on that. Thank you.
Thank you, sir. Thank you.
Kaushik, this is Varun here. So can you tell me what is the role of doing an ultrasound before you plan for a procedure? I mean, thoracoscopy.
Sir, we do ultrasound to check where the space is first, whether the fluid is there, whether it's a dry thoracoscopy or whether it's a pleural effusion, the amount, the quality, and if there is a loculations. And the site of entry is very important because when we do blindly, we end up near the diaphragm where there will be no rotation of the scope or anything, and the visualization would not be that particular of it, sir. So even in the guidelines, they said we have to, even though you are confident enough in doing thoracoscopy without ultrasound, but yes, we should use ultrasound before proceeding to any pleural procedures, sir.
Yeah. So that's an important point. Whenever you do plan for a thoracoscopy, make sure you have an ultrasound with you. So it gives you a valuable information where to go and all those things. Yeah. Thank you. It was a wonderful presentation, Kaushik.
Thank you so much.
Thank you.
Thank you, sir. Now I would like to call upon Dr. Verghese Louis, sir, our AP, Dr. Muhammad Kamaluddin, sir, and Dr. Roshan Kumar, sir, to chair the next session.
Kaushik, thank you. I think we are not able to give a memento to you. Right. So our love and wishes to you for your training in Italy.
Sure, sir. Thank you so much.
We'll meet you soon once you come back to India.
Sure,
Thank
sir.
you.
Thank you, sir.
Thank you.
Good afternoon, one and all. Next section is on foreign body removal by Dr. Varun. And he is our alumni and my dear friend. And we all did in the same period, post-graduation. And furthermore, he has done diploma in allergy in asthma, CMC Vellore, and a fellow in interventional pulmonology. And currently as a medical superintendent for PSG Hospitals, Coimbatore. And in short, he has been trained in EBUS, bronchoscopy, thoracoscopy, stenting, airway debulking, and cryobiopsy, allergy testing, immunotherapy. And he's a regular faculty for interventional pulmonology workshops in national and international conferences. And he has been invited as a presenter in Asia Pacific Conference on Bronchology 2023 conducted in Malaysia. And floor is yours, Varun.
Thank you, Kamal, for the kind words of introduction. So a very good afternoon to one and all. At the outset, I would like to thank Parnivel sir and Vimal sir for arranging such a wonderful meet and inviting us to give talks. So thank you for that, sir. So for the next 20 minutes or so, I'll be talking on airway foreign body removal, whatever I have removed for the past couple of years. It's not moving. So when it comes to airway foreign body, for like all the pulmonologists, it will be interesting as well as challenging. At the same time, it's very riskier also to because each foreign body will be a unique one, and you can face unexpected complications during removal. So briefly about the outline, I'll be talking about the common airway foreign bodies, whether to use a flexible or a rigid bronchoscope. What are the essential items that you should have in your toolbox, that is in your bronch suit, and what are the steps in removal, complexities, and the take-home points. As I said earlier, foreign bodies can be riskier. It can be life-threatening if you are not prepared well and if the appropriate care is not given, especially in pediatric population. It is one of the leading causes of unintentional death. You should have a high risk of suspicion in patients who has a risk of aspiration, like extremes of age, children less than 4 years, elderly people more than 60 years, alcoholics, and neuromuscular disorder patients, those who have a poor cough reflex. They're at a higher chance of having a foreign body aspiration. The acuteness of the problem, it depends upon the multiple factors, including the age, type of foreign body that went inside, whether the patient was aware of aspiration or not. Many times, if the patient is not aware, we may not be thinking our primary diagnosis may not be a foreign body aspiration. And depending upon the location of the aspirated material, degree of obstruction it is causing, and the access to the interventional pulmonology unit. So if you look at the common airway foreign bodies, it can broadly be classified into organic and inorganic foreign bodies. Most common being nut, peanuts, as well as the cashew nut. Various seeds can get aspirated. Something like popcorn, other regular corn, vegetables, bones also can get aspirated. The thing to note with organic foreign body is these are all hygroscopic. That is, they can absorb water and then they can swell up. So once it goes inside, it can swell up and get wedged in the airways. And it can also cause a reactive reaction wherein it can stimulate the formation of granulation tissue. So in such scenarios, removing it will become difficult. The other type is the inorganic foreign body, which includes various plastics, toys, some crayons, pen tops. Many times patients undergoing dental procedures, those dental clips can also go into the airways. Pins, LED bulbs, and screws. So these are the various inorganic foreign bodies. The difficulty with such foreign bodies is because it comes with the various shapes and sizes. You don't know how far it is extending into the airways, so it becomes a challenge. So when it comes to the location where it gets deposited, there's a publication done at Erin where they found out that most of the foreign bodies, they get into the right main bronchus around 60%. And the trachea and carina around 13%, and the left main bronchus is around 23%. Even though other places also it can get deposited. So this is a autopsy sample of a pediatric, a 2-year-old kid who died because of aspiration. What might look as a small peanut, if you look carefully, it can completely occlude the major airway, causing asphyxia and death. So which one to choose? Is it a flexible bronchoscopy or a rigid bronchoscopy? So let us discuss. So in a flexible bronchoscopy, you can choose to do it with a flexible bronchoscopy when there is no critical airway compromise if the foreign body is either in the right main or the left main bronchus, in patients who cannot tolerate general anesthesia, and if the foreign body gets dislodged and if it reaches the subsegments, and again, you cannot take it out with the rigid bronchoscope, definitely you need a flexible bronchoscope. And flexible bronchoscope, it has various accessories which you can use and remove the foreign body from the specific area. The problem with flexible scope is that it has a narrow channel, and it becomes difficult, especially in subglottic area, whereas there is a higher chance of it getting slipped away. And you also lack an airway control if you're not doing it under a general anesthesia. So what are the advantages of doing it with a rigid bronchoscopy? Yes, of course, large asphyxiating foreign bodies can be removed. You need to have a rigid backup if you want to remove such foreign bodies. And patients who are unstable, and if you're anticipating a high amount of bleeding, then you go ahead with a rigid bronch. And if there is any failed attempt with a flexible bronchoscope, so you need not try again with another flexible bronchoscope. It's better to try with a rigid backup. And if it is in the main trachea or main bronchi causing collapse, then again there is an indication for a rigid bronchoscopy. The problems is it needs a general anesthesia, it needs an expertise, and it has only limited accessories. So these are the problems with a rigid bronchoscopy. So which one to choose? There is nothing specific. So this was one of the observation study which is conducted in China, wherein they have seen children with around 1,000 plus children. So they said that most of the foreign bodies, like around 90%, were successfully removed with a flexible bronchoscopy itself. So whether to do it in flexible or rigid, the choice depends on the operator's experience and availability of equipments. So let us briefly look into the different accessories which are available. The one is the forceps. We have different types of forceps: the biopsy forceps, grasping forceps. The one in the green base are the rat tooth forceps, alligator forceps, and these are the prong grasping forceps. This is a 3-prong forceps, and this is a 4-prong forceps. The other accessory is the basket. This is a 0-tip basket, and you can get help from your urology colleagues, where you can get a stone retrieval basket as well. So these with the net are called as the Roth net baskets. So these nets and baskets will be useful in patients with seed and other nuts. You can easily grab it into the basket and then you can pull it out. Another valuable tool which you should have is the Fogarty balloon, be it for foreign body removal or not. Every bronchoscopy suit should have a Fogarty balloon of size 4 to 6 French. It becomes very important, not only for removing foreign body. If there is any bleeding also, you can put it there and then you can inflate it to control the bleeding. So let me tell how it helps in retrieval of foreign body in the subsequent slides. Another important tool nowadays is the cryoprobe. So in this cryoprobe, so the tip will get frozen. So any organic foreign body where there is a water content, you can place the tip of the cryoprobe and then you can freeze it and then you can pull it off. When it comes to the accessories which are used for a rigid bronchoscope, there are only limited options. One is a regular forceps, the other one is the optical forceps. So the regular forceps, you have a vision with a rigid telescope and you place the forceps and then try to take out the foreign body. Whereas the optical forceps, you place the telescope into the forceps so that with a single hand, the operator can maneuver and then take out the foreign body. So these are the different heads that are available. This is your basic foreign body, the basic biopsy forceps. These are the different forceps for retrieving foreign bodies. Briefly looking into the steps of removing a foreign body. The first and foremost, it is important to secure the airway. Second is to dislodge the foreign body that is impacted. The third one is to secure the foreign body, and fourth one is to extract it, that is pulling it out. So how do you secure the airway? If you are planning to do it under sedation, then only patients who are acute non-asphyxiating foreign bodies in distal airways, you can take with a IV sedation, or patients with a stable respiratory status. So those set of patients, you can take it out even with a sedation. Whereas all other foreign bodies, it's better to do it under general anesthesia, either through an endotracheal tube or through a rigid bronchoscopy. The next step is to dislodge the foreign body. So here we encounter 3 issues. One is the foreign body can get impacted. The second one, if it is a chronic foreign body, there can be granulation tissue around. And third one is in case of sharp objects, dislodging it needs training. So, so this is where the Fogarty balloon plays an important role. Say, for example, in this case, there is some kind of nut that is impacted in the right main bronchus. So to dislodge it, what we can do is to place a Fogarty balloon distally and then inflate it and pull it. So it's called as distal balloon dilatation technique. So this is one of the way to dislodge the impacted foreign body. So the other one is a granulation tissue. Again, here we need to use either hot or the cold techniques to take it out. So this particular patient, the foreign body was there inside. So like initially the patient presented with chronic cough. They took a biopsy of it. It was negative for malignancy, so he was treated with antibiotics and steroids. And subsequently, since he had persistence of symptoms, a repeat bronch was done. And then the granulation tissue had regressed, but apparently there was a foreign body distal to the granulation tissue. So dislodging from the granulation tissue, either through a hot or a cold technique, you need to do. And when it comes to sharp objects, it's very important not to tear away the mucosa. So if you go and grab the foreign body directly, there is a high chance that the tip of the object can tear the mucosa and can cause significant bleeding. So in these scenarios, you'll have to be very careful. And how to secure the object, you'll have to use your tools appropriately. So if you see here, for you to remove the screw, you need to have a star screwdriver. If not a star, the ideal would be to have a star screwdriver. If at least not that, you should have a regular screwdriver. If you try with a spanner, you spoil out, like you screw out everything, and then ultimately you cause damage to the thing. So whenever you are planning to remove a foreign body, make sure that you have adequate gadgets. The three important things what you should need is a forceps, a basket, and a Fogarty balloon. If these three things are there, then yeah, you can proceed with attempting to remove it. So the next step is to, once you have dislodged the foreign body, now you'll have to extract it. I think the videos are not coming. Okay, fine. So you'll have to extract it. So there are a few things which you should remember. So whenever you're grabbing a foreign body with a flexible bronchoscope, like you should keep in mind that you should not pull the foreign body through the working channel. So ideally you'll have to remove the scope in toto. So this one was removed recently in my hospital, where I gave a chance to my postgraduate. If you can see that foreign body is disintegrated into 4 pieces. So after grabbing it, the PG suddenly pulled it off. So it broke into pieces and then it got dislodged. Then again, we'll have to go and take all those 4 pieces. So we'll have to keep this point in mind. Another one is at the level of subglottis, where there is a chance of losing the foreign body because it's a narrow place and foreign body can get dislodged from your hold and then it can again go into the airways. So this is a small video showing a foreign body in the trachea. So if you see here, the foreign body, probably some seed, is moving around when the patient is breathing. So it was held using a snare, a basket, and it was pulled. So when it came near to the subglottic area, it slipped and fell down. So again, it went inside. So this is the place which I told you'll have to be careful. So subsequently, it was removed with a distal balloon dilatation technique, as I told earlier. So the next important thing you should keep in mind is grabbing the tip of the sharp objects. So this is another video. So this was the first foreign body which was removed by me independently. So this was a 9-year-old girl who came with a history of aspiration of a hijab pin. So the pin was sitting at the level of carina. If you see the sharp edges impinging on the right lateral wall of the trachea. So when you're holding, it is easier to hold in the center of the pin, but you're not supposed to hold there. You should hold at the sharp tip and then you should push it inside so that it doesn't tear the mucosa. So once you dislodge it, now you'll have to secure it. So you try to hold the tip of the pin and then you'll have to pull it off. So this was around 4.4 centimeter pin that was there in the carina. So pertaining to extraction, other thing is, as I said earlier, it can dislodge and migrate. So this was a 2-year-old baby with a peanut in the right main bronchus. It was an easy thing which we can easily remove, but unfortunately it was initially attempted by an ENT surgeon. So he tried to remove it, but unfortunately he broke it into multiple pieces. So then it got dislodged into the distal airway, and like the smallest size was around 1 mm also, 1 mm piece, and we had great difficulty in removing it. So another small video of so this patient was a around 8 to 9-year-old baby. Radiologically, the patient was having a foreign body in the right intermediate bronchus. So we went in, there was a granulation tissue. So before proceeding further, we wanted to check the opposite lung as well. To our surprise, there was a foreign body in the left main bronchus. What has really happened is there was the foreign body which has caused the granulation tissue in the right intermediate bronchus has dislodged by itself and then went into the left main bronchus. So this was removed using an foreign body retrieval basket. And then the granulation tissue which was there in the right intermediate bronchus was removed using a cryo. So if in case if that foreign body was there distal to the granulation tissue, you should remove the granulation tissue first, followed by removal of the foreign body per se. And this again is a 5-year-old boy who came with sudden episode of choking and cough. So the parents were not sure of what the baby had aspirated. So can you guess what is there inside this airways? Are you able to make a guess of what is there inside? So we were also not sure of what was there. So we did a check bronchoscopy. So this was what we found inside the left main bronchus. Some blackish thing with a round metal thing in the tip. So another important thing is when you're trying to trying to remove it, you should not push the foreign body distally. When you're trying to remove it, if you see here, I'm trying to grab it, but unfortunately, without my knowledge, I'm pushing it distally. What happens is, since the airway has a tapering end, if you push it, it gets wedged, and then it'll become much more difficult for you to remove subsequently. So then we removed it with a Fogarty balloon itself. So this was actually a part of a cigarette lighter, which the father was using. The baby has taken it and then had it in his mouth and aspirated. So looking into the complexities and challenges, when do you call a airway foreign to be a complex one? To keep that simple, that which cannot be removed by you. So any foreign body which you cannot remove it becomes a complex airway foreign body. It can be due to any of the reasons, most commonly being a lack of expertise or lack of equipment. This varies depending on the person who's doing. But apparently, if there is a long-standing foreign body, or if it is deeply impacted, or if it is a pediatric age group, it becomes a complex airway foreign body. So what are the other complications? What you expect? Before removal, there can be hypoxia, choking, and death. During removal, patient can have bleeding, and if there is a hypoxia, can go for hypoxic arrest, and unsuccessful removal, and even death can happen. So post removal, patient can have significant amount of bleeding, and if you leave the granulation tissue like that, the airway can go in for stenosis, and once the collapsed lung is open, it can cause pneumothorax. Fistulas can happen, patient can have subcutaneous emphysema, and post-obstructive infections can happen. So these are the complications of a foreign body. So let me share a couple of foreign bodies which I have removed, and this one was a challenging case. This was the youngest pediatric foreign body which I have taken as well. So this was a 10-month-old baby with history of sudden choking, And then when imaging was done, that was showing a complete collapse of the right side. So this was the, if you look here, this is a foreign body that is completely occluding the right main bronchus. So apparently it was a tamarind seed. So for just looking at it, it might look simple, but it nearly took 2 hours for me to remove it. Mainly because for the first time when I went inside, just to visualize the foreign body itself, the baby was starting to desaturate. We used an eye gel, the least size was 1. So just going in, the baby started desaturating. So then where will I go and dislodge it, take it out using a basket? So I didn't have time. I mean, I couldn't spare time because of the desaturation. And that is when like I was wondering what to do, whether to refer the patient or to like why at all did I take this case, like that I was thinking. Then suddenly I thought of, I would have been happy if there were 2 instruments inside. So what I did was like you would have heard of an ant blocker, that is a bronchial blocker, where there will be a loop at the distal end of the balloon. So that can be looped around the bronchoscope and it can be taken inside. But since this was a pediatric age group, what I did was I put a 0-tip basket inside the working channel, outside the like outside the patient, and then I kept a Fogarty balloon along with the 0-tip basket. So with both together, I went inside and then I dislodged the foreign body and took it out. It was really challenging to take that. So these are the other couple of foreign bodies. This was a areca nut. This was a cashew nut in the left main bronchus. This was there in the trachea, and this was again a cashew nut in the left main bronchus. So we had a publication in the respirology case reports regarding a foreign body clove. So this was an elderly female who had a right lower lobe consolidation. So she was evaluated as a mass lesion and biopsy was taken, and apparently it was negative, and the pneumonia was non-resolving. Then subsequently, when we went ahead and saw that was a clove that was there inside. And again, this is a 9-year-old boy who was having asthma. And since he was having frequent exacerbation, he was evaluated, and CT was showing a right main bronchus foreign bodies. Again, this was a clove. So take home points. So which one to use, rigid or flexible? It is always better if you have a backup of a rigid bronchoscopy. And if it is a difficult case, it's better to combine rigid bronch as well as a flexible bronch. And it is a 3-handed procedure, which means you should have a properly trained assistant, because when you're removing a foreign body, you just place your scope at the distal end, and then it is only your assistant who is going to open and close the forceps or the basket. So you need to have a properly trained person. And all the foreign bodies are not the same. You might be facing unique challenge with each and every foreign body. As I said earlier, be well equipped with all the instruments and backup plans, and know your limitations. If you're not able to do, it is better to refer the patient rather than taking challenge and complicating things. So I would like to take this opportunity to thank my teachers, Menon sir, Parnivel sir, Vimal sir, and all others. So I'm here because of what I learned from this place. It was exactly 10 years ago we joined my first year post-graduation. So not only pulmonology, you have inculcated various other good habits in us. Thank you, sir. Thank you so much. Thanks for the opportunity. Do you have any questions?
How many cases did you rigid and how many cases did flexible bronchoscope among all your cases?
So whatever cases I have done is all through flexible bronchoscope only.
Flexible. And the role of cryo in foreign body respiration.
So if it is an organic foreign body, it has a water content in it, so you can use a cryo to take it out. Again, in seeds, if you seed a tamarind seed or a chiku seed, even though it is an organic foreign body, that outer covering, it is cryo resistant. So you may not be able to use a cryo in those scenarios. And even in inorganic foreign bodies, since it is there for a long time, there will be a lot of mucus sticking around it. So that can as well be used as that becomes cryo sensitive. So you can pull out with a cryo.
Really interesting cases, Varun, both organic and inorganic foreign bodies. My question is, in case one case which you showed, where you took it out with the Fogarty from the distal lumen. So is there a chance that it displaces and goes to the opposite side?
Yeah, there is always a risk of dislodging, and because that 10-month-old baby which I showed you, I could have easily put the balloon and taken it out. But the thing is, the right lung is totally collapsed. And suddenly, if I pull it out and if it goes to the left lung, the patient will be. And so, yeah, there is always a risk. So, you'll have to be very, very careful. And generally, those set of patients, if you take, you'll have to counsel the parents that on table anything can happen. But they will also be very apprehensive to tell anything is fine because they're all young kids, no.
And sorry, one more thing. The other one case which you showed, which was pulsatile just at the subglottic area. The seed, yeah.
Yes, sir.
So in case you're not able to get it out of the cords, is it preferable at that stage to go for a rigid so that you have a more working area, or still you would prefer?
No, you just have to angulate it in a way that it comes out, because
you need to change because the rigid scope because you have a bigger channel.
Yeah, if it is very difficult, probably you can intubate with a rigid scope and use it as a conduit to
take it out.
But since that foreign body has gone through that vocal cord only, so definitely in one specific angle it should
you will be able to
come out. So in those scenarios, we can use a Rothnet basket, wherein once the seed is there inside, and then if you close it, it becomes the shape of the net, and then you can easily pull it off.
Okay.
What is the role of anesthesia in these cases? Like you have not mentioned about that, like role of any like a local or what you have done for the small babies. And
No, acute foreign bodies and not compromising the airways. If the patient is stable, respiratory status is very stable, it can be tried with a sedation itself. If it is if it is in the main airways, if the patient is having respiratory distress, it's better to go with a general anesthesia.
Thank you, Varun. Any questions from the audience?
Yeah, actually, we are really overwhelmed. Like one of you is putting inside the scope and removing the tumor, and the other one is coming inside and taking a biopsy. The other fellow goes into the thorax from the pleura, and you are going into the airway to removing a foreign body. So I think each one of you is having a different agenda inside the airway. So, right. So I'm not asking a subject question. What is interesting for me, is it because you develop training and you get a lot of cases like this, or there are a lot of foreign body cases in Coimbatore?
There are a lot of foreign body cases. Many will be attempted by the ENT surgeons itself. Unless people are aware that you are doing such cases, people start referring to you. And if you see a lot of cases, you will get more experience, and then complications also may not be there. I know, sir, before doing my IP training, I know certain places where the baby has died on table while attempting to remove a foreign body. So
no, I was more perplexed whether even in this part of the country, I don't know, in Jipmer, whether you have so much of foreign bodies presenting. It's very unusual to have so much foreign bodies from a single center. Yes. And I think you missed many cases as well. There,
last 2 years, I would have taken around 15 to 16.
There were some mutton pieces inside the airway also. You shared with that. Yeah.
Yes,
so a lot you have not presented. So I was just worrying, what is this?
For want of time, I have just put only limited foreign bodies. No, many adults also, they come up with foreign bodies. Once patient was complaining that she was planned for some surgery. She was complaining to the ward staff that my nose stud is missing. So the surgeon somehow he had some idea, get an X-ray. So that was there in the right middle lobe. So we had to take it. So it happens with the adults as well. Yes.
Thank you, Varun. It was a nice presentation. Thank you for your session.
Thank you, sir. Thank you.
Thank you, sir. That was really an amazing session. I would like to request my HOD, sir, to hand over the memento to Dr. Verghese Luis, sir, Dr. Mohammed Kamaluddin, sir, and Dr. Varun, sir. Thank you, sir. I would like to call upon Dr. Verghese Luis, sir, and Dr. Sandhya ma'am to introduce the speaker for the last session.
Good afternoon, sir. I'm now going to introduce the session speaker, Dr. Vimi Varghese, who is also an alumni of MGMCRI. And he has done his postdoctoral fellowship in pulmonology from Christian Medical College, Vellore. And he has done his fellowship in lung transplant from University Hospital in Belgium under Professor Robin Ost. And he has been trained in EBUS, bronchoscopy, thoracoscopy, thoracic ultrasound, and critical care at most prestigious Christian Medical College, Vellore. And he has presented in various national conferences, and he has been a member of organized committee in national conferences, including Allergon 2019 and 2020, held in CMC Vellore. Thank you.
So, good afternoon, everyone. I thank Pulnivel sir and Vimal sir and whole MGMCRI team for giving us the platform to present. And moving from the purely interventional to a almost like a non-interventional or very less interventional specialty of lung transplant, which is evolving. I will share the few experiences and what were the pitfalls of our work in Yashoda Hospitals, Hyderabad. So my topic is lung transplant, finding the right candidate and the window for referral. So this is our team in Hyderabad that includes the surgeon, anesthetist, or perfusionist, and backup with our interventional pulmonology team. And as you know, in transplantation, there are usually three aims. First is obviously to save the life, to prolong survival, and to improve the quality of life. But it comes with different challenges, or everybody gets misunderstood with different terms about referral, listing, and what's the waiting time. So always when we consider lung transplant, when the 2-year predicted survival is less than 50%, and the referring physicians usually refer that patients to a transplant center where the patient gets evaluated, see what are the pros and cons, and how much benefit after a transplant patient will receive. Then we actively list the patient in the state registry, and we have the state registry in Hyderabad called Jeevandan. And after the approval, patient is being actively listed, and the waiting time starts, and the transplant happens. So there is always usually three terms, that is a referral, listing, and the transplant. So why it is very important? So this is the two. These two pictures are two extreme pictures. One is a 73-year-old female who had done a transplant, who is on the 6th post-operative day without oxygen. And the left side is a patient who is in ILD, whom we are not able to wean from ECMO, who is doing actively the physiotherapy. So why the outcome is very different, I'll tell you in the subsequent slides. So what is the need to, when to consider transplant, or what is the golden hour, and when the success happens? So this is the three important challenge to tell about the outcome. So when a patient is being referred to a transplant center, there is always a disparity in the patient expectation and the doctor expectation. So as a patient, they want to go back to school immediately after transplant. They want to travel. They want to attend the usual social gathering. However, as a transplant physician, we feel that there is always at least 6 months to 1 year where they should be at least out of the social gathering. We should actually achieve no desired side effects of the drugs and avoid comorbidities, and to perform the daily activities, and more important, improve the quality of life. So our department started the transplant in Jan 2021, and most common indication is the interstitial lung disease. And as you can see from the graph, that most of our cases is in ILD followed by the COVID-related fibrosis and bronchiectasis, etc. When we compare the world statistics about the indication for transplant, the predominant cohort is the COPD followed by ILD. However, the referral to a transplant center of the cases is predominantly the interstitial lung disease in our center. Now, what are the challenges of transplant in India? So what I'm sharing this, so on the right side is the explant lung of a 40-year-old lady with a bilateral bronchiectasis, left tubercular cavity with an aspergilloma and nocardiosis. And as a transplant team, and especially for the surgeon, doing a pneumonectomy on this above patient is a great surgical challenge, posing greater risk for bleeding, on-table use of ECMO and different challenges. So this is the most common cohort of patient that comes to our transplant center. And it's not only the ILD, which even though the main indication for transplant is ILD, there will be many other superimposed pathologies that complicates the transplant. And especially this creates a lot of issues pre-transplant and also the post-transplant. So what is the importance for the right window? So as you know that transplant is a journey. So every member should be, and even the patient should be knowing about the what are the side effects of the drugs and how long the treatment should be taken and what are the pros and cons. So usually what happens is that even 2 days back, the patient after being actively listed in our registry wants a transplant in 1 week. So what happens is that if they get a lung in 1 week, they will not know what is the usual side effects, or many patients get admitted for transplant and finally we reject the lung telling it's not a, if there is an HLA mismatch. So there are many challenges of a transplant which each family member and the physician should be knowing prior to transplant. And there will be many other treatment options other than transplant which we can consider, like surgical LVRS for a COPD and etc. And there are some patients who will not improve after transplant, where we can really improve with the rehabilitation considering the age and other side effects. So every patient should be told about the post-operative outcome with the current conditions so that they are morally prepared for what is the outcome. And there are many bloodstream infection that the patient can have prior to transplant, which we have to actively manage so that the outcomes and their primary conditions are also taken care. The other most common important thing is the diet. So bilateral bronchiectasis patient to achieve a BMI of more than 20 with whatever dietary modification, it's a huge challenge. So recently we have two young about 20-year-old with the bilateral bronchiectasis who is on a RILES-2 feeding of for almost 3 months and still unable to achieve a BMI of more than 20 with the maximum nutrition. So that are the different challenges of nutritional perspective, but the good nutrition, especially after transplant, pose a very good success, which we try to stress about and we try to achieve the maximum. So we achieve at least a BMI of more than 16 or somewhere between 16 to 18, at least to actively list for a transplant. And the other most important one and most misunderstood one is a HLA sensitization, which I'll be telling in the subsequent slides about how we can do the proper matching and how we can prevent the rejection. And next important things are the physiotherapy and optimizing the comorbidities. So in a transplant center, there are usually many challenges. One is the pre-transplant sensitization, the malnutrition or the extremes of obesity, patient coming with a pre-existing renal failure, superadded coronary artery disease, and the reflux disease. So I'll be sharing at least just 4 cases with a different clinical perspective to know about how the transplant went through in this 4. So this was a 26-year-old male who was a glass blower by occupation, and he had a history of occupational ILD, who was on 4 liters of oxygen, and this was his lung. So you can see that the both upper lobe had a cystic changes, and almost his lung function was almost less than 0.5 liter. And he, whilst explanting the one lung, his oxygen saturation came down and we have to put on ECMO. And even though the transplant happened, his weaning off after transplant had a smooth course. He was out of ECMO by 24 hours, off ventilator by 36 hours. So I'll just show his CT scan. So this was a lung. You can see that most of the upper lobe was destroyed and other areas had a occupational ILD and fibrosis. So this was his donor lung after being properly matched, and HLA mismatch was not there. And this is during the donor time. So we do a bronchoscopy at the time of while going for the donor retrieval to see the endobronchial changes, and then we consider for retrieval. So he's on day 2 after being properly weaned off from ECMO, off ventilator, who is doing actively physiotherapy. So this is our ward and he's doing physiotherapy in our corridor. I will just. So that is one extreme of occupational ILD. Second other extreme is that case of paraquat poisoning, which we discharged about a week back. So this was a 22-year-old male who was referred to us after consuming paraquat about 5 days prior to when he was referred, for a silly reason of mother telling him not to go to a Middle East. So he consumed 30 ml of paraquat. He had a respiratory failure, who was already being given steroids with the cyclophosphamide outside, who was on ventilator, referred to us. So it was referred primarily for any other treatment option other than being on a ventilator. So this was his lung. So you can see that almost it's like a complete bilateral whiteout lung. So he was with us after being placed on ECMO almost by day 10 after the consumption. And there was many different challenges. Even though he was on ECMO, he had a recurrent respiratory infection. Almost the every week therapeutic lavage was almost very purulent, Acinetobacter infection. He had a kidney injury, liver injury, which he was recovering. However, we were not sure about the options of transplant here. So in this particular scenario, there was only a transplant done in Calcutta, and we were even contacting them about their experience. So the main hallmark is we should not be doing a transplant when there is a paraquat level in our body, which will again cause recurrent fibrosis. So the challenge was we have to make sure serum or urine paraquat level after waiting for at least a month should be negative. So we repeated the urine paraquat level subsequently in 2 sessions, which was found to be negative. And this, you can see in this picture that this was a ECMO cannulas, and he is being actively doing the physiotherapy on ECMO. However, slight decrease in the ECMO flow at any instance will drop his saturation to almost less than 70. So he was complaining about the leg pain and other different myopathy challenges. So this was the pre-transplant imaging prior, and as I've shown earlier, it's like a whiteout lung. So there is so much of dilemma, and there is only a very few case reports around the world, and it's all individual cases about paraquat poisoning. And there is only one case series about 3 patients from abroad. So we had to finally contact them to their experience, and finally he got a donor lung. And this was on post-operative day 3 when he was off ECMO. He is on a tracheostomy cannula and only on the intercostal tubes. So this on post-operative day 3, he's actively doing physiotherapy. And on day 4, this is our corridor where he's being doing the physiotherapy and doing the motivations, etc. And this is the post-transplant X-ray. So each transplant patient, whether it's a ILD, whether it's a poisoning, all will have a different challenge, right from the multi-system problematic or involvement to HLA mismatch or their nutrition, etc. So this is another patient with the scleroderma related ILD on home oxygen, who is a 51-year-old who was being airlifted from Cochin. And his main concerns were he was brought with exacerbation and he was almost on a very high oxygen requirement at admission. Thereafter, after the evaluation, he was actively lifted. And finally, after transplant, he was off ECMO and he was decannulated as early as possible. So this is after the permission from the patient, where the patient is being actively doing the incentive physiometry, spirometry, and different leg movement exercise and different etc. And finally he's back home almost by 2 weeks. Last one is the case which I want to stress about how much the HLA mismatch bothers to a transplant team and what is important. So this was a 41-year-old male with a bilateral bronchiectasis and workup for cystic fibrosis was negative, who was on 2 to 3 liters of oxygen for most of the time. And he was a teacher and was having pulmonary hypertension, and he had 2 exacerbation in the last 1 year. HLA screening done, there was no the antibodies or the single antigen bead shows no sensitization, and he was actively taken for transplant. And you can see that this is the pre-transplant X-ray and this is the post-transplant X-ray. So usually what everybody will ask is what happened immediately after transplant. You're almost getting a whiteout lung after the transplant. Now I'll just show you one bronchoscopy image. So this was on day 3, where you can see that bloodstain secretion flooding the carina, and even after recurrent aspiration, it's flooding again. So this patient was diagnosed as alveolar hemorrhage, where he was being actively pulsed and IVIG was done, even though the sutures you can see as intact. So his biopsy shows features of alveolar hemorrhage with capillaritis, and class 2 DSA was positive. So this there was a lot of questions about why DSA became positive after being properly sensitized. So it was a non-DSA mediated hyperacute rejection that was a main culprit, and even though we did the maximum treatment towards him, he was not able to sustain the different modalities, and he passed away after 1 week. So a pre-transplant sensitization is a core for any transplant to have a success, and it involves typing of HLA, different antibody identification, and finally the cross-match. So as I said, nutritional management is a core or the most important parameter that turns a transplant to be a success in any solid organ transplant. And this is the another cohort where people are being demotivated pre or post transplant. So on the right side, you can see this is the scleroderma associated ILD, where we have transplanted about 2 weeks back, who is on tracheostomy, who is finding very difficult even to stand up and doing the physiotherapy. This is another cohort who had done a transplant, and finally he's back home in almost 3 weeks. So this is another different cohort that we come across about demotivation. And finally, most transplants, especially the lung, will have some sort of renal failure because of hemodynamic disturbance, patient on ECMO, long-standing surgery, and different comorbidities, etc. So we should actively involve a nephrologist prior to transplant about whether how will be the renal function post-transplant. This is another simple example where a scleroderma associated ILD has done a manometry, and you can see that the LE junction was found to be very lax, and we had finally done something called ARMA, or anti-reflux mucosal ablation, where we are trying to reduce the size of the LE junction, which to reduce a reflux, which will really improve the outcome after transplant. So this is the second time I'm putting the slide, because the transplantation, I said, there are many challenges, and the patient should be really told about how the transplant works, and we should be actively treating the infection. HLA should be properly sensitized and read, and we should be stressing the importance of physiotherapy. So a pulmonologist by this small graph will understand about the what are the condition and what stages to refer to a transplant center. So this this on the left side is the percentage where 80% FVC is being should be considered at least referred to transplant, or same way like cystic fibrosis for 30 and COPD for at least 20% should be actively listed. I'm not going to the individual details, but there are different referral criteria and different listing criteria for individual diseases. However, the most important referral and listing criteria for COPD is a board score and the spirometry and the different patterns of pulmonary hypertension and exacerbation. Same way with the interstitial lung disease, it's the decline in FVC or the DLCO that is the core importance for the documenting the decline along with the FVC and DLCO and other parameters like supplement oxygen, hypertension, hypercapnia. This is an additional slide about bronchiectasis where the criteria is 30%. This is another important criteria or the slide about pulmonary hypertension where a lot of work is going on, and we look at something called a reveal score to know the response after the vasodilatory therapy. So finally, to tell about what determines the success, it's the proper counseling, pre-transplant sensitization, proper HLA and induction strategy, the physiotherapy plan pre and post-transplant, and the patient should be told about the medications after transplant. So we always have a problem where patient is being transplanted, but after 3 months he stops and comes with the features of obstruction or chronic allograft lung dysfunction after transplant where they stop the tacrolimus. So this is a non-tuberculous mycobacterium patient which we recently transplanted, and he's doing the physiotherapy and finally he's back home. So to conclude, lung transplant is a life-saving treatment for most patients, but we should consider telling actively the risk factors and what are the contraindications before declining a patient, and careful selection is of utmost importance, and the timely referral, and it's finally a teamwork of the patient, relatives, the referring physician, and the transplantation team. So we also do a lot of thoracic work in our hospital which is a backbone for the transplant success. So I thank all my teachers for giving the opportunity and which ventured me into transplant, and finally I'm here speaking about transplant. Thank you.
Thank you, Remy, for an excellent session. The floor is now open.
How frequently you see BOS?
So most of the patients after 1 year comes with some form of chronic lung allograft dysfunction, most commonly being BOS and less likely to be a restrictive allograft. However, over the time we see more of restrictive allograft. If you tell me from the 52 patients that we have transplanted right now, almost if you around 32% has some form of chronic lung allograft dysfunction, and most commonly in that 70% is a BOS as per our data.
Okay. Know the importance of referral. How many patients do you reject for every transplant you take?
So in a month when 6 patient is being referred, at least 2 patients we have to actively reject, telling there is not much benefit after transplant. Especially we had recently a 64-year-old female who was bedridden, who was on high oxygen requirement, where the family really insisted to have a transplant. However, we know that the post-operative outcome after transplant, if she's just being on the bed again, it's not going to be a success. So we are actually aiming at improving the quality of life. So if you tell me at least out of 6 referral, almost 50% we might have to reject, or at least 25% we have to reject from the referrals.
We had one session, last session of TAPCON 2017. You are there, right?
Yes, sir. Yes.
Suresh was telling,
yes,
if you walk for a transplant, you will walk home. If you come in a bed, less chance of getting home
Yes, sir.
successfully, right?
Yes, sir. Sir, especially for a RA-ILD and non-scleroderma related ILD, the success rate or prognosis is good when they are being referred for in the 40 to 50-year age group and who are on at least on 2 to 3 or less than 5 liter of oxygen, having at least able to walk in a corridor with that quality of life. However, scleroderma, there is a lot of issues, especially with regard to extra parenchymal issues, which we have to properly manage before transplant, before we consider actively listing for transplant. Otherwise, like the patient which I shown, they tend to have all this post-transplant reflex, post-transplant myopathies, which will have a lot of issues. Yes, sir. So what happens in transplant is usually we give other than MMF and steroid called tacrolimus, which has a more immunogenic potential, and we try to regress from that point of view. So tacrolimus is one cornerstone after transplant that improved the outcome in CTD-ILD.
See, before a transplant in COPD and all, pulmonary rehabilitation plays a bigger role.
Yes.
And you have showed some slides about physiotherapy after transplant.
Yes.
Is there any need for pulmonary rehabilitation post-transplantation? And if it is there, how long they should do that?
So to document about how much is the requirement or how long to perform, we actually do a CPET. So we do a CPET. Right now, we don't have the CPET machines in Yashoda, so I cannot documentally telling about how long. But where I was trained, we are supposed to do a CPET pre-transplant, make sure how is their VO2 max, and do a post-transplant to see how much they are achieving. So we perform about the CPET every month and to see how is the response to the VO2 max. Then grade the exercise. So when there is no CPET available, we do the same thing with the 6-minute walk test and the spirometry to see how much lung function they are attaining and how is their myopathy of other limbs. Then we grade the exercise and we give a plan.
It's almost 6 years back that we listened to your PG seminar on indications and contraindications of lung transplant. And now you are the master of the lung transplantation. I say it's a overwhelming growth what you have, and congratulations for that.
Thanks.
I think among all the experts here, I think you must be having the most challenging job every day. We should agree to that because it's a teamwork and there are a lot of ifs, buts, and counseling the patients. It's all there. So keep up the good work. Only my question was that this regarding to that paraquat poisoning.
Yes.
Is that the fibrosis which sets in so fast because within 7 days you need to go for a lung transplant? Was the indication was fibrosis or?
No, sir. It has a chemical pneumonitis associated with ARDS. Sir.
Okay.
So usually what we do is that we wait for 1 month to know there is no blood or urine level available. But sadly, we don't have a serum paraquat not available anywhere in Hyderabad. So that's why we did the urine paraquat level. And after transplant, we do an actively induction so that the chance of recurrent fibrosis is less. But they tend to have frequent collapse of different lobes, which we have to manage. But the chance of fibrosis is less, and we keep the tacrolimus level also at a slightly higher levels in this paraquat.
Because paraquat poisoning is very common in these areas. Even
Yes,
here,
sir.
MGM, we get a lot of paraquat poisoning. The second was that HLA mismatching.
Yes.
Was it behind our thing? Like, because you must be having the most sophisticated screening for HLA mismatch. But despite that,
he was having some antibodies pre-transplant, sir,
which we could miss.
No, sir, which we detected. But while we are doing the matching, there was no mismatch, or it was not a sensitized, or there was no antibody available.
Okay.
So we went ahead, we took the donor lung, we went ahead with the transplant. But on the day one, there is always two issues of primary graft dysfunction or like a pulmonary edema, which they're having recurrent blood stain secretion. So it was like a misnomer, which we did a biopsy on day 2, thinking it's a graft dysfunction, which can happen up to 72 hours. But when we did the biopsy, and we also thought there is also chance for hyperacute rejection, and they did the DSA on day 3. So when we did the DSA, even though it was positive, we again went back and saw the single antigen bead report. So there was no mismatch available. Then it was a non-DSA mediated, or like KU, MU, different antibodies, which we cannot type. So that was a probably reason, but we cannot detect that.
How are you taking care of further episodes, like to prevent further episodes?
So usually, sir,
this could happen in any other patient as well.
Yes, sir. So we usually try to properly match, but at even a slight chance of this presence is there, we do a plex in drop.
Okay.
So we do plex in drop. We serially monitor the DSA. The DSA is coming down, then we change the strategy of plex or IVIG and steroids, etc.
Thank you.
Yes.
What is your stand on bilateral with single lung transplant, sir?
So, ma'am, abroad, even single lung right now, it's more or less not being done, but there are some centers who is still doing when they are elderly beyond 65. But whoever has a good quality, I mean, whoever has, we are able to do double lung at any point should be done. And if they are, even though they are elderly, who is having oxygen requirement that is not very high, who is having at least good muscle rehabilitation, if option available, should be only done double lung transplant, because post-operatively single lung will have a lot of aspergillus issues and a lot of infection, which we find very difficult to manage. And again, considering for a retransplant in our setting, it's not possible.
Yeah. To sum it up, Vimal, if you could, like a two-part question. One is, how frequently would you call them back for a review? These patients who you have discharged, and like how regularly would you want a check bronchoscopy done for them? And last, for all the young budding pulmonologists, when would you want others to refer to a transplant specialist? Like if you could tell some 3 points, so we will be aware when we should refer to a transplant surgeon.
So a patient after transplant, usually we call them every week, and we monitor the serial blood test about the RFT, LFT, X-ray, and the tacrolimus level up till 1 month. Then after every 2 weeks, we call them. And by the end of 2 months, we usually discharge them to their home. And we usually tell them to send this blood reports every 3 weeks. So every month, in the first month, every week, second month, every 2 weeks, then every 3 weeks, in short. And at the end of first month, we call them for a bronchoscopy to look for any chronic lung allograft dysfunction or the chronic rejection, and we do the biopsies. So this biopsies, we look for the different molecule or different changes at the tissue level for chronic rejections. And the bronchoscopy we classify in first month and third month, 6 months, and 1 year. And other thing is that on day 1 after surgery, we'll do a bronchoscopy to see the suture and prior to extubation. And at any moment, if there is a clinical worsening, we do a bronchoscopy to look for the endobronchial involvement. Now, coming to third point, when to consider transplant. So a patient with an ILD with having a progressive decline or a progressive decline in lung function at any of your OPD visit, consider at least being a referral to a transplant center. And when they're having a pulmonary hypertension, whether it's for a COPD or bronchiectasis, within desaturation on a 6-minute walk test, at least consider referring to a transplant center, telling that it's not for a doing a transplant that you are referring. It is just to make sure you are being listed, or at least listed in the registry, so that at any moment, if you are clinically worsening where we are out of treatment options, should be actively registered for transplant. And if they are able to have a good physiotherapy with an underlying chronic end-stage lung disease, that should be the way to go ahead from here on for any end-stage lung disease. So if you are able to have that quality of life with the clinical worsening, the post-operative outcome is also very good.
Thank you.
Thank you.
Thank you, sir, for such an amazing session. I would like to request our Associate Professor, Dr. Vimal Raj, sir, to hand over the memento to our AP ma'am, Dr. Sandhya ma'am.
We'll take a quick 10 minutes break and we'll assemble the ground floor college block for workshop sessions. Tea is in the college building only, not here. Okay. Refreshments are in the college building. Okay.
Venkat, take sir to the workshop block. Manju is messaging that he is not able to read the topic. No. You are not able to reach him. You are taking messaging the past.